Capacity to learn is a gift. The ability to learn is a skill. The willingness to learn is a choice. And today, we all gather in this hall by our choice. Introducing myself, Dr. Pooja Khadka.
And myself, Dr. Rosin Thapa. We thought a resident at Patan Academy of Health Science will be your host today. On behalf of Association of Clinical Pathologists of Nepal, we would like to welcome you all on the 10th National Conference being held with motto of Evolution of the Pathology, Guiding the Way to Modern Cancer Care.
Today we have a total of 3 chaired sessions followed by panel discussion on the lung tumor and oral case presentation by the residents. I would like to announce, please make sure the oral presenters submit their PowerPoint presentation in the respective hall. Hall 2 is downstairs. Without further ado, we would like to start out today's session. Today's first session will be chaired by Professor Dr. Smriti Karki and Professor Dr. Eva Pia. Introducing Professor Dr. Smriti Karki. She is the head of Department of Pathology of BP Kerala Institute of Health Sciences. She has several scientific publications in different national and international journals and has a special interest in surgical oncopathology.
Introducing you Professor Dr. Eva Pia. She is professor at Nepal Army Institution of Health Sciences. She has several scientific publications in different national and international reputed journals. Now we would like to request Professor Dr. Smriti Karki and Professor Dr. Eva Pia to chair the session. Please give them a big round of applause.
Good morning. I am Dr. Smriti Karki and Dr. Eva Pia. We are honored to open this session. Welcome to everybody on the day two's first session. So without further ado, I would like to welcome our senior consultant pathologist from Tata Medical Center, Kolkata, Dr. Divya Midha. Okay. Good morning, everyone.
I've had a lovely couple days in Kathmandu. It's my first visit. I've been jazzing off from the meeting because I wanted to try everything from the thakali to Tamil, and I've been to all the cafes, shopping, spice market, and I thank you all for this wonderful hospitality. And I hope that all of you can come to Kolkata and spend some time with us, attend our meetings, or just visit us. So in case you do come to Kolkata, do look me up. Girishma has my contact, and it'd be wonderful to have you in my city. So without wasting much time, let me just delve into my topic, which is pitfalls in bladder neoplasms, a diagnostic roller coaster. Now, yesterday, I spoke on endometrial carcinoma because I jokingly tell everybody I'm a pelvic pathologist. I do gynae and I do uro. So, I mean, there's no pun intended. But yeah, these are the two areas I take a lot of interest in. So yesterday was more morphology, IHC, and I put moleculars in that perspective. But today is morphology, morphology, morphology. I've not put a single slide of molecular because we don't do it in our practice. You don't do it, even I don't do molecular. So today is only morphology, so let's start the roller coaster ride. Now, when I was growing up, this was my favorite band. It's called the Bangles. I don't know anybody remembers the Bangles, and this had a song called Walk Like an Egyptian. And my mother would say, the whole day I say, walk like an Egyptian, I would do this step, okay? And so it was really funny. But in the last 2 years, I have one mantra: think like a clinician. So I forgot, and so I say, think like a clinician. And we were just talking that in your head, you have to remember that you are a clinician. First, who is a pathologist second. If you think like them, there's going to be no issues ever. And you have to know what they want. And to say that, my first slide is a clinical slide, because we're all clinicians. So yesterday I showed you the ESMO, ESTRO, ESCO guidelines. Today I show you the ESMO guidelines, which is in bladder cancer. And if you see the guidelines, it's all, again, based entirely on us. There's nothing to do with them. They just listen to us, and then they treat. So they better listen to us, and you better give them a good, report. So the main things in bladder cancer is the treatments are of two types, okay? I'll just skip the slide. It's either for non-muscle invasive cancer or muscle invasive cancer. By muscle, we mean muscularis propria and not muscularis mucosae, okay? So the treatment guidelines are based on whether the muscularis propria is involved or not. And you may think, so what, muscle involved? We'll tell them, but no. Muscularis mucosae can closely mimic muscularis propria. So you have to be very good at that because the treatments are different. So let's look at first non-muscle invasive, okay? Now, this entire thing over here for non-muscle invasive, this is non-muscle invasive, low risk, intermediate risk, high risk, and a highest risk. Low risk is low grade. High risk is any of the following. T1 means lamina propria invasion or subepithelial tissue. It could be T1 or high grade or carcinoma in situ or multiple recurrent tumors. And the highest risk is when all of these are present or when there is some particular subtype like the micropapillary, etc. So everything is pathology. There's nothing to do with these guys, everything to do with us. And so on this basis, the risk stratification is done. So you better know what is low grade, you better know what is high grade, you better know what is lamina propria invasion, you must know what is muscularis propria invasion, you must know the subtypes of urothelial cancer, because if you call it low grade, it's only surveillance. If you call it high risk, there is BCG, which is toxic therapy. If you call it very high risk, straight away cystectomy. This is for non-muscle invasive. If you call it muscle invasive, NACT followed by cystectomy, or no NACT, directly cystectomy. So do you understand that your report determines that somebody has a bladder or somebody doesn't have a bladder? Somebody receives a chemo or somebody doesn't receive a chemo. Now, what used to happen earlier, I used to say, Focal invasion present, lamina propria. Just bol dete hain, you know. What if the second pathologist it goes to says, no, no, we don't do that. Just to save our skin or suspicious. Do it when you're really suspicious. Learn how to be, you know, definitive. Don't try atypical, reactive, atypia, suggestive, suspicious. Okay, reserve that. I mean, we're all humans. Reserve that. Keep a threshold. Even I question myself. How many times have I used suspicious in this month? If I have, I need an eye checkup or I need a vacation or something because it cannot be too much, okay? So with that, let me start the roller coaster ride. What are the problems I face? What are the problems you face? When I'm seeing a bladder tumor, sometimes the first question, really a tumor, na? Is it really malignant, right? Not some reactive process. Okay, now, okay, this is some tumor. Is this, what about the dysplasia, carcinoma in situ? What is this? Is there dysplasia, low grade, high grade, in situ? You know, in situ comes in the treatment guidelines. In situ, high risk. Be careful, okay? Now, okay, there is, it's non-invasive. I'm sure this is a urothelial carcinoma, low grade or high grade. Very important. Low grade, surveillance, high grade, BCG or even cystectomy. So be careful. Lamina propria invasion. Earlier, I was so casual about lamina propria invasion. I would say, okay, foci suggestive. Okay, some tangential cut cannot be ruled out. I used to love using those terms because then look at the heartburn the clinician would feel. Then I started thinking like them. What if somebody is sitting in front of me and they see my crappy report and say, what does this girl mean, yeah? Kal ko join kiya TMC and she's writing all this, you know, cannot be. Then he'll pick up the phone and then he'll be sweet to me and then he'll keep the phone and he'll probably curse me under his breath that I'm not giving him a definitive answer. So lamina propria invasion, please don't take it lightly, very, very important. Now some things like, okay, now you've mastered lamina propria invasion. There are people now who want, what's the extent of lamina propria? Focal, extensive, even that's coming into the guidelines, not into the guidelines. So I really don't, what is not in the guidelines? I'd like to, you know, move with the think about the future, but I'm not really going to stress too much on PT1 substaging. LVSI, something people just casually we write, LVSI present. Only if there's lymph node mets, then you write LVSI present. Otherwise, please look for LVSI and really write it if you see it. Otherwise, just don't say, "Arey, time nahi hai, 6 o'clock, I want to go home. Must be present, yeah, somewhere, you know, let me just write it." Don't do that, okay? Because this comes in the risk stratification. What comes in the risk stratification? Please pay attention to it, okay? All right. Muscularis mucosae, muscularis propria are not to be played the fool with. I have done it and I feel ashamed and I'm sorry to all those patients with whom I probably have, you know, in my immaturity done that. So I don't want to do this anymore. Histological subtypes of bladder cancer. Earlier, in the earlier WHOs, it was called variants. Now it's called subtypes. It's just a change of nomenclature. We use variants, the word variants now, when we're dealing with genetics. Variant of uncertain. So the word variants has gone to genetics and molecular path. It's just a term change. But subtypes is the one which we should use in histomorphology. And subtype is very important. And I'll tell you why. There are certain subtypes. If it's there on your tumor, or your tumor is of that subtype, even if it's not muscularis propria, direct cystectomy is recommended. So be aware of those subtypes. And last, I told you I'm not going to even talk molecular. We don't do luminal A, luminal B. They are there in the current WHO. We are not practicing it. When we practice it, when it's important, so think like a clinician. When the clinician needs it, we'll talk about it at some other point, maybe a couple of years after this. But right now, no. IHC, yes. But the good thing in bladder is you don't need really IHC. You just need morphology. But there are situations you need it, and I will be covering that quickly through cases. The rest of my cases, the rest of the discussion is purely theoretical, from articles, from a little bit of experience, okay? So, first question, is this really a tumor? Is this malignant? Means, can you recognize the benign mimics of urothelial carcinoma, okay? For this, I get your attention to 3 articles which are brilliant. Tumor-like lesions of the urinary bladder, modern pathology 2009. Nothing has changed in 2023. Same morphology. Please refer to this article. It's brilliant. Annals of Diagnostic Pathology, Mimickers of Urothelial Neoplasia by Epstein. This is also an article a little later which came, and it's just brilliant. And Mimickers of Urothelial Carcinoma and the Approach to Differential Diagnosis by Lopez. Also, this is a great article, and you must refer it, and it's only morphology based. So, when I say recognizing benign mimics of urothelial carcinoma, I mean to tell you there are things in your bladder biopsies sometimes which are actually benign, but they look malignant. How to pick them up and not call them malignant and subject the patient to unnecessary toxic BCG or even a cystectomy. So we say, chalo BCG mil jayega. Kya hai BCG? Chemotherapy? It's not chemotherapy. It is really, really toxic. Those patients have dysuria and symptoms which are uncontrollable sometimes, and they have to discontinue BCG therapy. So BCG is not a very innocent therapy. It can be very toxic. So please be careful. So what can mimic cancer? Sometimes a transitional or the urothelium can proliferate and look pseudocarcinomatous. That's one. There are some glandular lesions in the bladder which can look like adenocarcinoma of the bladder. That's two. There are some papillary lesions. Everything papillary ain't tumor, okay, which look malignant. There are some spindle cell lesions which look malignant, but they're not. They're reactive or not malignant. And there are some miscellaneous lesions like, malakoplakia, schistosomiasis, which can cause proliferation and therefore can look malignant. Let's look at the important ones quickly. Von Brun's nest. All of you are familiar with von Brun's nest? So there are epithelial proliferations in the lamina propria, which can mimic a cancer. And the second one is epithelial proliferations associated with radiation and chemotherapy. So this picture everybody knows. This is the overlying urothelium over here, and these are the well-delineated von Brun's nests, okay? And they are just invaginations of the urothelium which have lost the connect with the overlying urothelium. Now, sometimes they develop these small glands, a process leading to cystitis glandularis. Now, how do you recognize them? They are benign and reactive. Endoscopically, they are, so you always look at your cystoscopy. There will be small bumps. Nothing very, a papillary tumor. Always, always look at the cystoscopy finding. I quote my cystoscopy at every report of TURBT. They are round regular nests that are not interconnected in the lamina propria. So if you go back, there is no connection in between these nests. They don't have an infiltrative pattern of growth or any retraction artifact. There is no mitotic activity or cytological atypia. Sometimes a ureter around this, there can be von Brun's nest. This is a florid proliferation of von Brun's nest with cyst formation. But look, none of these are interconnected. Can you see any connection between this nest, this nest, this nest, this nest? They're all not interconnected, and they have a non-infiltrative even base, okay? So, and they do not infiltrate the muscularis propria. This is reactive von Brun's nests. Sometimes it can be florid. There's some stromal changes, but these are all von Brun's nests mimicking a nested variant. That's the biggest mimic, the nested variant of urothelial carcinoma. How do you distinguish it? The nested variant is got an infiltrative irregular base. And look at this. What is this? Anybody quickly? Otherwise, I may overshoot my time, which I normally do for talking too much. Muscularis propria. So nested variant looks atypical, has an infiltrative base, and it invades the muscularis propria. So presence of tumor nests of urothelium, atypical looking in the muscularis propria, allows an unequivocal diagnosis of nested variant of urothelial carcinoma. So the most important thing of von Brun's nest, even base, no infiltration, whereas a nested variant, irregular base with infiltration into the muscularis propria. Now coming to post-RT or CT, post-radiotherapy or chemotherapy associated proliferations, they can proliferate, and look really ugly with some risk, even a stromal response. And you have a history. This is where it's very important. I'm not saying that post-RT and post-CT you can't develop a recurrence. Of course you can develop a recurrence. But please have it in your mind that I'm looking at a post-RT-CT situation. I shouldn't you have to be aware. It's just that self-awareness is very important. Be aware, okay, I'm dealing with this situation. Let me look at it again, double, triple. Let me look for infiltration. Let me look for all the features where I can definitely say it's malignant before calling it a recurrence. So look at this. Over here, there is this urothelial nest maybe, but look at this. There are these dilated, congested vessels. This is a low power view showing irregular dilated vessels, hemorrhage, inflammation, extensive fibrin deposition post-RT-CT. There is some, pseudosarcomatous urothelial hyperplasia showing some atypia over here, but they are encircled by fibrin. But this also does not extend into the muscularis propria. So in a post-radiotherapy, chemotherapy, antenna should be like this. And you should say, no, I have to be very careful. I have to see unequivocal muscularis propria, unequivocally bad to call it malignant, because this could very well be a pseudocarcinomatous urothelial hyperplasia looking like that, but I should look for other signs of radiation or chemotherapy like fibrin, hemorrhage, etc. Okay? Remember, they can show some cytological atypia also, so look for muscularis propria invasion. All right. Now coming to some glandular lesions which are benign, but they can mimic cancer. So a glandular lesion which is benign will mimic an adenocarcinoma, right? And a transitional epithelium will mimic a urothelial carcinoma. So let's look at those. Florid cystitis cystica et glandularis with intestinal metaplasia can look like adenocarcinoma. Mullerianosis. What is mullerianosis? A combination term, endocervicosis, endosalpingiosis, endometriosis, can happen in the bladder. A combined term is called mullerianosis, okay? And the most treacherous one, nephrogenic adenoma. So these three lesions can mimic an adenocarcinoma of the bladder. Let's look at them quickly. So this florid cystitis cystica is a broad-based mass. This lacks cytological atypia, lacks necrosis, lacks signaturing cells, lacks mitotic activity. It can have mucin coming out, but the bad news is cystitis cystica, etc., can also be present in the muscularis propria. So what do you use for Von Brun's nest, etc.? In the glandular lesion, it goes away. You have to be aware they can be present in the muscularis propria. But how are they going to be present in the muscularis propria? In a very pretty manner, very sweetly, sitting over there, no reaction, just sitting glands sitting in the stroma. And you know it, and pathologists need not be told. You see infiltration every day, your eye knows invasion. So when they're just sitting like that with no reaction within muscle bundles, it could still be a glandularis, don't call it adenocarcinoma. Look for atypia, look for necrosis, look for signaturing, look for mitotic activity, and then it's an adenocarcinoma. So this is your cystitis glandularis of the intestinal type. This even has mucin extravasation. It's not an adenocarcinoma. I told you, look for mitotic activity and infiltrative desmoplastic stroma, and this will be an adenocarcinoma. Whereas in the other mimics, you will not see desmoplasia, you will not see atypia, mitotic activity, and an infiltrative growth pattern. They can be in the muscularis propria, but sitting in a very pretty way. Now, can you use IHC to distinguish? Not at all. They will show you all the markers, CDX2, CK20. Every marker is going to be positive. You don't need IHC. You need only morphology. So this is cystitis glandularis and linear non-infiltrative base. And there's some mucus extravasation. These are just benign glands sitting pretty in the muscularis propria, but they're all bland. So these three are benign. This is malignant because you have to look for this sort of atypia. Is that clear? All right. All right. Now I told you what is endocervicosis, salpingiosis, endometriosis. If you see them in the female genital tract, they can also be present in the bladder wall. And by bladder wall, I mean they can also be present in the muscularis propria. So again here, muscularis propria is not helping you, morphology is helping you. So for endocervicosis, mucinous glands of the endocervical type, if they are sitting pretty in, you know it's endocervicosis. Endosalpingiosis, you should be able to see this tubal cilia. Endometriosis, you should be able to see the, anybody? Endometrial glands and stroma, and you have your diagnosis, okay? And when these lesions are seen together, it is called mullerianosis. The problem is they can be as large as 5 centimeters. So yes, you will look at the cystoscopy and say, oh my God, 5 centimeter mass, is this malignant? But look at it once under the microscope. Is it very pretty sitting in the muscularis propria? Are they staining for PAX8? Is there endometrial stroma? Make your diagnosis on the basis of that. So I'm going to skip this. This is endocervicosis with benign endocervical mucinous glands sitting in the muscularis propria, but you can see there is no desmoplasia, it's not infiltrative. And this is endocervicosis in this field and endometriosis with your endometrial glands and stroma in this field. This is endosalpingiosis, just looking like your fallopian tube with the cilia present, and then you know this is endosalpingiosis. Nephrogenic adenoma. Now this is something when I joined as a resident, I still remember it was a very florid nephrogenic adenoma, and I wrote adenocarcinoma of the bladder, and I submitted it. Thankfully, patient, nothing happened because I just gave it to my boss, and the boss said, you're not going home today, you're just going to read up benign mimics of urothelial carcinoma, and I spent that night just reading that, and that's how I fell in love with nephrogenic adenoma. So all good things are, it's also for your own benefit when somebody tells you that you're spending the night with nephrogenic adenoma. So it is a relatively frequent lesion in the bladder. It develops in patients with urinary stones. So the history is very important. There will be a history of urinary stones or instrumentation, etc. And it is at this area of trauma that the renal tubular cells shed and they implant themselves. And therefore the term nephrogenic adenoma. It's asymptomatic. Most of these patients are patients of bladder cancer, and they're coming to you to the clinician for surveillance cystoscopies. They come for a surveillance cystoscopy. They see some red area or maybe an elevated area, sometimes even an exophytic papillary area, and they send you a TURBT. So be aware of the history of past TURBT. So if a patient has urothelial cancer and comes to you on a cystoscopy for surveillance, again your antenna should be up and you are looking for recurrence. But lo and behold, sometimes you get nephrogenic adenomas. And I'm going to show you. It comes with a variety of images: tubular, cystic, polypoidal, papillary patterns. They can be signet ring cell, nested, corded, spindled, fibromyxoid. But they are surrounded by a prominent basement membrane and they have some eosinophilic secretions. But they are bland. They are totally bland in morphology. They are cuboidal to low columnar. They can be hobnailed, and the nuclear atypia is very, very uncommon, and if present, it's going to be of a degenerative nature. Mitosis is absent, and there is an area of chronic cystitis. So let me show you a lot of images. So this is a nephrogenic adenoma, typical tubules, but with a single lining of cells. There are some tubules and some cysts. Look at the florid nature, which can even push you to call it carcinoma. Here, it's formed an exophytic pattern. It's so easy to call it a recurrent papillary tumor. But look at the lining. It's a single lining of cells, single. And if you see, papillary tumors generally are multi-layered, isn't it? And there'll be this hobnail blebbing over there. Look at this, looking like a signet ring carcinoma almost, with a pseudo-infiltrative pattern. Again, many tubules, look at this, they have this hyaline material around it. And this has some colloid-like secretions. Another example of some with some conspicuous nucleoli and some looking like signet ring cells. All right, so this is a nephrogenic adenoma, again with a papillary pattern, but a single lining of cells. They can sometimes mimic a clear cell carcinoma. Now, female bladders can have endometriosis. From endometriosis can arise clear cell carcinomas, and this is a very, very close mimic. So, pseudomalignant features like muscle invasion, nuclear atypia, and occasional GATA3 positivity can be seen in nephrogenic adenoma. But The combined expression of Pax8 and the absence of P63 and GATA3 in nephrogenic adenoma should solve all difficult cases. So it is here that you may need IHC. So if you put in Pax8 is a renal tubular marker. It will be positive in nephrogenic adenoma, but will be, and GATA3, which is a urothelial marker, will be negative. If at all, some focal staining may come, but that's not important. You will not get strong GATA3 positivity in nephrogenic adenoma, and P63 will be absent and Pax8 will be strong. So this is a strong Pax8 in nephrogenic adenoma. Now, I told you about clear cell carcinomas of the female bladder. Clear cell carcinomas of the female bladder are Pax8 positive. So how are you going to distinguish it from nephrogenic adenoma? So clear cell carcinoma has predominantly clear cells, more prominent pleomorphism, especially hyperchromatic nuclei, extensive muscle invasion. They form a mass-like lesion, Pax8 positive, and this is here where I use a Ki67 in bladder, and this is over here. They'll have a high Ki67 as compared to a nephrogenic adenoma, and let me show you a picture. Sorry. So this is a clear cell carcinoma, and this is looking like a nephrogenic exophytic picture that I showed you. But this has got a high Ki67, and this is nephrogenic adenoma with a low Ki67. If you use Pax8 in this situation, it's not going to help you because both nephrogenic adenoma and clear cell carcinomas are going to be Pax8 positive. In this case, Ki67 is going to help you. Now, coming to two papillary lesions in the bladder, which can mimic urothelial carcinoma. One is an inverted urothelial papilloma. Many times I see reviews of a papilloma being called an inverted growth low-grade urothelial carcinoma. Remember that that patient will also be given intravesical methotrexate, which can get very toxic. So be very careful about the diagnosis of inverted urothelial papilloma. Excuse me. Thanks. A papillary polypoidal cystitis. These are two papillary lesions which can closely mimic urothelial carcinoma. All right. So an inverted urothelial papilloma can develop at the trigone and otherwise almost anywhere. They're usually solitary and present as broad base sessile lesions with a smooth surface. Rare cases can be very large. Now, important thing is that it is an inverted growth. The trabeculae are anastomosing and they are mixing with each other, unlike von Brundt's nests, which are all away, okay? There is central streaming and peripheral palisading. So let us just look at that. Mitotic activity is absent, cytological atypia is absent, and inverted papillomas, they generally lack associated inflammation or a stromal reaction or a retraction artifact. It can have some squamous metaplasia. This is a typical inverted papilloma, a smooth surface over here. These anastomosing trabeculae, and they're all intermingling with each other, peripheral palisading, central streaming of cells. Sometimes they can have prominent cyst formation, but remember they are all interconnected. The central streaming and the peripheral palisading is very, very characteristic of these inverted papillomas. They lack the cytological atypia or the mitotic activity. The second important lesion is papillary polypoidal cystitis. Papillary cystitis is nothing. I'll just quickly show you a picture. Papillary cystitis, these are papillae. Around 3 to 4 cells line, but they are filled with inflammation. Don't call this a urothelial carcinoma. And a polypoidal cystitis, this is a very broad bulbous papillae, edematous stroma, inflammation in the stroma. These are more fibrotic papillae with inflammation in the stroma. This is not a urothelial carcinoma. Now, coming to some spindle cell lesions which mimic urothelial carcinoma, there are two important ones which you need to keep in mind. One is a post-operative spindle cell nodule, and the other one is the IMT, or the inflammatory myofibroblastic tumor. Now, post-op for a bladder tumor, sometimes a post-URBT, the patient comes for surveillance and there is another lesion which gets biopsied and you see a florid cellular spindle cell proliferation having even atypia and mitosis. Please keep in mind, yes, it could be a sarcomatoid urothelial carcinoma, but it could also be a post-operative spindle cell nodule. So keep that in mind. A post-operative spindle cell nodule can look malignant, but it has a very good base. The base is clean. It's not infiltrative. If it was a sarcomatoid urothelial carcinoma, it would be deeply infiltrating the muscularis propria. This just stops. There is a proliferation of spindle cells which just has a very neat base. So please keep in mind post-operative spindle cell nodules in your differentials of a sarcomatoid urothelial carcinoma. Now, pseudosarcomatous myofibroblastic proliferation includes IMT, and you're very used to IMT at other sites. There is inflammatory cells along with your myofibroblastic proliferation, which are ALK positive. So this is another important differentials. And then the other important things are, which you need to keep in mind amongst the miscellaneous, xanthogranulomatous, BCG changes, schistosomiasis, IgG4, these can all mimic urothelial cancer. Now, we have part of the, the roller coaster is done, and let's go to the next question, dysplasia or CIS. Please don't use these terms loosely because they have connotations. If you call it CIS, it puts the patient in high risk or highest risk. So it's important to recognize these precursor lesions, and for this, the latest WHO is an excellent reference. Also remember that your normal urothelium has umbrella cells. And if it is tangentially sectioned or deeply stained, those umbrella cells can itself look pleomorphic. Don't call these umbrella cells as malignant. These are the normal umbrella cells, which on tangential sectioning can look hyperchromatic. Also be aware of reactive atypia. If you have neutrophils and a background of cystitis, there can be slight nuclear enlargement with prominent nucleoli, with intraepithelial inflammation. Don't call this CIS. Now, what about the term dysplasia? WHO 2022 does not really address it in a specific chapter. It just deals with it when you're talking about CIS. Carcinoma in situ is a definite entity. Anything which falls a little short of it, a little, is dysplasia. So if you're not too sure about carcinoma in situ, don't call it because you're putting it in high risk. The patient may get BCG or even a cystectomy, so be careful. So carcinoma in situ is a high-grade malignant urothelial cells, high grade, which you can see at low power, there's no doubt, and it is a flat lesion. So this is a carcinoma in situ. Does anyone have any doubt that this is not malignant? This is carcinoma in situ. Be bold and report it, but anything falling short of it, be careful when you call it carcinoma in situ. The cells are more than 5 times the size of the normal urothelial cells, prominent nucleoli, mitotic activity, but flat, not papillary, okay? All right. What is this term, urothelial papillary proliferation of undetermined malignant potential? It's a tongue twister. It was there in the previous WHO. I never used it. I prayed to God that it should just disappear, and it has disappeared from WHO 2022. It's a rubbish term. These lesions don't even exist. They are possibly low-grade urothelial carcinomas, non-invasive ones, so don't bother. Now, I'm getting a bit scared now, because it comes to the important one, low grade versus high grade. If you follow criteria, it shouldn't be a problem, and the criteria is what you get from your WHO 2022. So this is your low grade. No, I'm talking about non-invasive. They are low grade because of the way they are oriented. They are all oval nuclei perpendicular to your basement membrane, and there is no variation. They're all perpendicular. There is no disarray. Nucleus here, nucleus there, nucleus. No, they're all in one way. There is no cytological or mild cytological atypia. Look at the nuclei. How are they oriented? They are all perpendicular to the basement membrane. And there's no disarray. There is no brisk mitotic activity. And this is your typical low grade. And high grade is when there is a disarray. The nuclei are in all directions. There's necrosis. They can see apoptosis. You can see pleomorphism, mitotic activity at all levels. That's your high-grade papillary urothelial, non-invasive. Now, what do you do when you see small amounts of high-grade in an otherwise low-grade tumor? If it is 5%, you call it high-grade. Directly, even if you're seeing 95% low grade. But anything less than 5%, you call it low grade tumor with less than 5% high grade component. So these are clear-cut guidelines by the WHO 2022 and should make your life easy. And therefore, this is a high grade. Look at the nuclei. They are in all directions. Some are here, some are faced the other way. Prominent nucleoli, mitotic activity at all levels. And I also give a lot of importance to this necrosis apoptosis. It really helps me to distinguish low grade from high grade. All right, lamina propria invasion, the most important thing. I mean, definitely before muscularis propria. These are the wonderful articles which I always refer to. No IHC, no molecular, just plain morphology. Stage 1 T1 bladder cancer. So stage 1 lamina propria is T1, right? And this is by Lopez and Cheng. And this is very crucial for patient management. And we discussed that right in the beginning. How do you recognize lamina propria invasion? By the histological grade of the tumor. A high-grade tumor invades the lamina propria. A low-grade does not invade. So for me and for a lot of uropathologists, we don't call a low-grade tumor as invasive. They are all PTA. If you're calling some low-grade tumor as invasive, it could be a deceptively low, like a nested one or something which you're probably mistaking. So this is the referrals that I get, that someone's called a low-grade as invasive. So there are two possibilities. Either this is high-grade and invasive, or it's low-grade and non-invasive. So there are only two possibilities, okay? Or it's a benign mimic, one of them. So you have to look at the histological grade of the tumor. It's high grade, then I'm going to look for lamina propria invasion. What is the nature of the invading epithelium? What's the stromal epithelial interface? What's the type of stromal response? What's the pattern of invasion? And are there pitfalls? And believe me, pitfall when it comes to lamina propria invasion. Okay, I discussed this. So this is the grade. If it's high grade, yes, I'm going to look for lamina propria invasion. And this is lamina propria invasion over here. So what are the characteristics? Single cell infiltration, irregularly shaped nests, finger-like extensions, and the invasive component looks more pink than the overlying. This is called, they look a little morphologically different from the overlying non-invasive component. This is lamina propria as finger-like projections, small nests, single cells. This is lamina propria invasion. This is again finger-like projections. These are small nests. Here, there is paradoxical differentiation. The invasive component looks more pink and more differentiated than the overlying urothelium over here. This is a very important clue for lamina propria invasion. Stromal epithelial interface. So there is a change in the stroma, and this is a helpful clue. So this is just tangential sectioning. Look at this. This is such a uniform basement membrane, and these vessels around it, this is not lamina propria, this is tangential sectioning. And if you did an antibody, which is anticollagen 4, it would highlight the basement membrane. This is only tangential sectioning. But none of us use this antibody, it's plain morphology. The presence of these cells and a very smooth basement membrane, no stromal reaction suggests that this is not lamina propria invasion. The stroma can be desmoplastic, retraction artifact, very important, inflamed stroma, myxoid stroma, pseudosarcomatous stroma, absent stromal response. I'm going to rush now. This is a desmoplastic stroma, myxoid stroma, and an inflamed stroma with these singly scattered cells. And this is just, probably no reaction or some myxoid change here. This is another inflammatory stroma. These are small nests. This is the typical retraction artifact I was talking to you about. This is characteristic. If you see this, this is lamina propria invasion. What are the patterns of lamina propria invasion? I'm going to skip. This is the carcinoma in situ with microinvasion. This is a papillary tumor with invasion into the upper lamina propria. So this is your carcinoma in situ with microinvasion. This is your papillary tumor with clear-cut single-cell infiltration into your lamina propria. This is invasion into the stalk over here. This is invasion up till the level of the muscularis mucosae, something like this. This is going through the muscularis mucosae bundles, but not reaching the muscularis propria, something like this. This is again microinvasive carcinoma arising from urothelial carcinoma in situ, and these are some retraction artifacts, again lamina propria invasion. This is single cells infiltration highlighted by cytokeratin. And this is nothing but this is not a urothelial carcinoma. This is just a pushing inverted pattern, which is just pushing, but this is not invasion. What are the pitfalls? You have to recognize tangential sectioning, which I showed you, thermal artifacts. Sometimes there's so much inflammation, you cannot pick up the single cells. You can do a cytokeratin in that particular situation. Sometimes you have carcinoma in situ involving von Brun's nests. They look like invasion, but you have to see that they have a very well-defined basement membrane, and that's not true invasion. You can have invasion into adipose tissue within the lamina propria. You can get sometimes, don't think of this as extravesical invasion. You can have some very deceptively bland urothelial carcinomas like nested variant, be aware of that. The microcystic variant of urothelial carcinoma is invasive, be aware of that. Broad front or inverted growth pattern can also raise the question of invasion, and be aware of the nested pattern. So I'm going to just show you some pictures. This is tangential sectioning, I've already shown you. This is single cell infiltration into the inflammatory cells. This is highlighted by cytokeratin. This is von Brun's nests involved by urothelial carcinoma. Look at the base, it's quite regular. This is not true invasion. This is a nested variant of urothelial carcinoma. Look at the irregular base over here. This is the large nested variant. It is going into the muscularis propria. This is the tubular and microcystic carcinoma invading the muscularis propria. Okay, almost nearing the end of the roller coaster ride. I told you in the beginning, is there need for PT1 substaging? Not really. It's going to come in the protocols in the future. Right now it's not there in the protocols. Don't worry too much. I will just tell you how it's being done. So we can do it as focal lamina propria when only one focus is present at high power, or non-focal when more than that, if you want to give that information to your urologist. But they don't really ask you, at least our urologist doesn't ask us, they just want to know lamina propria invasion. Focal, extensive, they don't want to know. Some people have also tried to add all the greatest dimensions of invasive foci. So if you have 0.3, 0.5 here, you just add them up. But nobody's asking for this, so don't bother as of now. All right, now I'm happy because I'm nearing the end. Recognition of LVSI. Please don't be casual. Each must be there somewhere. Let me just write it. It's a part of those guidelines. If you say LVSI, you know, it puts you in the highest risk if the other factors are present. Be very careful and give LVSI some respect. Again, the same. So this is a true LVSI because the presence of unequivocal endothelial lining, nests attached to the wall of lumen, nests taking the shape of the vessel, a peritumoral location rather than an intratumoral location. And if you're really worried, and if you have the IHC, you can do those ERG 31, etc., but you can do it on morphology. And this holds good for LVSI at any other site, okay? So next one. This is your true LVSI. And the pitfalls, of course, you know, the carryover due to fragmentation, retraction of stroma, don't call them LVSI. All right. Muscle. I'm just going to spend, can I have 5 more minutes? Thank you so much. So muscularis mucosae versus muscularis propria. Please, your entire treatment protocols differ. Non-muscle invasive, no cystectomy unless you're of the highest risk. And muscle invasive, cystectomy, with or without NACT. So please learn to recognize muscularis mucosae versus muscularis propria. One is PT1, one is PT2. The treatment protocols rely on this. So again, as I said, treatment protocols rely on non-muscle and muscle invasive. Okay? Muscularis mucosae are thin and disorganized. Muscularis propria are compact. And you have a fibrovascular stroma in mucosae, but you do have interspersed collagen in propria. I think of it like this, and this is from Dr. Sangeeta Desai when I was, I used to attend her lectures, and I love this one. And it stayed in my mind, and I wish I can put this in your mind. A dense cumulus cloud, muscularis propria. These wispy clouds probably today in the sky, muscularis mucosae, they are thin. Can you do markers? I actually do markers sometimes, I love to do markers, and for this, and I will tell you what I do, and then we can skip. If it's definite, not a problem. But if there are foci suspicious of muscle invasion, I'm not sure what muscle it is, because sometimes you can get hypertrophied mucosae, which starts looking propria. I like to do Desmin first, because Desmin tells me how compact it is. It gives me that cloud wala picture, you know. So positive Desmin, I know there is muscle invasion, but is it mucosae or propria? I don't have smoothulin, because I've worked with it, I was never happy. I do Vimentin. If I have Desmin positive, and I know the shape is like a propria, I put a Vimentin. If the Vimentin is weak or negative, I'm sure it is not a hypertrophied mucosae, but a muscularis propria. So Desmin positive giving you that shape with Vimentin negative, muscularis propria. And of course, muscularis propria, as per literature, shows strong smoothulin. I have worked with smoothulin. I have not had great results, but I'm sure if anybody else has, this is the algorithm. Now, Desmin negative, there is no muscle only, so forget about it. But Desmin can also be present in mucosae, but that is Vimentin strong and smoothulin negative. So if at all you want to follow any IHC, I find this useful, and if you find it, it can, because it makes a huge difference to treatment protocols. Sometimes you get floaters. Don't call this muscle, just a fragmented tumor in the propria. Don't call this muscle propria invasion. All right. All right. So is there need for histological subtypes of bladder cancer? Yes. And what is histological subtypes? What is divergent differentiation? We'll just quickly do this. The 2020 says you have to give the percentage and the type of divergent differentiation or the subtype. What do you mean by subtype? Subtype is something which is urothelial in nature but a different architecture. Divergent means urothelial, say diverge, it's diverged from urothelium, becomes squamous or glandular or something else. So please understand, subtypes will retain urothelial markers, divergent will lose urothelial markers. So I'll quickly show you. When you say something is micropapillary or sarcomatoid or plasmacytoid, they need upfront cystectomy, even if they are not muscle invasive, muscle propria invasive, okay? So you need to recognize these subtypes. You have to give a percentage to these subtypes. These subtypes retain markers of urothelial like GATA and P63, whereas a divergent loses it, okay? So the 5th edition maintains the recommendation that all invasive subtypes of urothelial cancer, as well as those of divergent, should be graded as high grade, should be given a percentage, and should be mentioned in the report. Because the 3 subtypes, plasmacytoid, sarcomatoid, and micropapillary, need cystectomy. Okay. Now, the divergent ones are those which can lose GATA and can lose P63 because they are squamous, glandular, trophoblastic, and Mullerian. So I'm not going to show you squamous and glandular, trophoblastic with beta HCG. This is a clear cell carcinoma. This is an endometrioid carcinoma arising from an endometriosis, which is ER positive. These are your micropapillary tumors, clear cell subtype, lymphoepithelioma-like subtype. These are all there in your WHO. Lipid-rich urothelial, okay, nested urothelial, large nested, tubular and microcystic. All right, sarcomatoid, giant cell, all right. Practically the end of the roller coaster ride. Are there pitfalls during IHC interpretation? Can I discuss 4 cases, short cases? So everybody comes with hematuria, and that's the history. And the history is that everybody was diagnosed outside as high-grade urothelial carcinoma. That was the history. So 58-year-old, outside TURBT, high-grade urothelial carcinoma, and there was a cystectomy done. And this is the low-power view, a very busy slide with blue. You can see the entire, from the urothelium right up to the inked perivesical margin in this slide. It's invading the muscularis propria. There's no doubt in this. This is I don't need markers for this, right? This is a cystectomy slide. And it's just going right down. Yes, it's gone into the perivesical fat, not gone to the margin. What does it look like to you? They're all plasmacytoid, eccentric nucleus. Plasmacytoid, eccentric nucleus. Any idea about the diagnosis? There's one subtype I didn't discuss. Going into the fat, CD138 plasmacytoid. What is this? What is CD138? What marker? Very good. It's a plasma cell marker. So what is this tumor? Excellent. Plasmacytoma. And that's it. Let's go next. Are plasmacytomas cytokeratin positive? No. So that's a pitfall. CD138 is a plasma cell marker, but is also an epithelial marker. And there is one subtype of urothelial cancers which look plasmacytoid. And that one needs upfront cystectomy, which happened in this case. Next marker, GATA3, urothelial marker. E-cadherin is lost. They lose the cell adhesion, intercellular adhesion molecule. It's lost. That's why they become single. And E-cadherin was retained in your internal control, the overlying urothelium. So you know it's worked. Plasmacytoid urothelial carcinoma. You should know this subtype. 61-year-old, TURBT, high-grade urothelial carcinoma, called high-grade urothelial. Slides blog submitted for review. She's a female, okay? She's a female. Called high-grade urothelial. Slides blog submitted for review. A papillary tumor. Papillary tumor, yeah, it can be a papillary high-grade urothelial carcinoma. Micropapillary urothelial carcinoma, correct? What are these in the arrow? What is this in the arrow? Bone, yeah. Calcification, Samoma bodies? Okay. Calcification, Samoma bodies, micropapillary urothelial carcinoma. She's a female. Very good. Mitotically active. P63 negative. It's a subtype. It should retain P63. It's not a divergent micropapillary. GATA3 negative. What else do you want to do? Female. Paxate, wonderful. I looked at the imaging. The imaging, the patient has omental disease, perivesical plaque-like thickening, prevascular node, peritoneal deposits, umbilical nodules. Does this happen with bladder cancer? It doesn't happen with bladder cancer. And as you said, Paxate, strong positive, WT1 strong positive. It's adnexal or peritoneal in origin. High-grade serous carcinoma, tubo-ovarian involving the bladder. So keep in mind, but you can get female genital type of cancers from the bladder, but they are endometrioid and clear cell because they arise from endometriosis. But serous, no. Serous is going to arise from your tube or the ovary or the peritoneum or the endometrium. It's not going to be of bladder origin, okay? 75-year, last two cases, TURBT, TURP outside, high-grade urothelial, detrusor-free, called outside, submitted for review. Again, a papillary tumor can be urothelial. It's papillary, right? But they have a distinct, very slender fibrovascular cause. Very slender fibrovascular cause. Any marker? GATA, obviously, first, negative. If papillary tumor should be GATA positive. P63 negative. Sorry. PSA, strong positive. So it's a prostate cancer with ductal features mimicking a urothelial carcinoma, so be careful. 25-year-old, last case, high-grade urothelial carcinoma, but detrusor-free. 25 years old. You want her bladder out. Slide block submitted for review. Again, a very blue fragments, very blue tumor. Some amount of nests you can see here. Nests, monotonous nuclei, more nests, monotonous nuclei, GATA positive. Can I call this urothelial carcinoma? Nested pattern, monotonous cells. Anything else you want to do? Because this is a huge pitfall. Urothelial, anybody? Very good. It is. So synaptostrong, chromostrong, and S100 highlights the cystenticular cells. Look at the age of the patient. Paragangliom of the bladder, very common in young females. I won't go into the literature. So please recognize these pitfalls. And today was just morphology. I didn't even touch molecular. There are molecular subtypes of bladder cancer. I would suggest it's all there in the WHO 2022. It's not that deep into clinical practice right now. And when it is, we can have another lecture on that. So thank you. We're at the end of the roller coaster. And thanks for a patient hearing. Thank you.
Dr.
but I cannot help but comment that I think as much as I did, I think the entire audience here enjoyed the roller coaster ride.
Thank you so much.
So hats off to you for that beautiful deliberation, as beautiful as you are from Bengal. I would call it a Mishti deliberation, really.
Thank you.
So we really enjoyed on your unmasking of those mimickers and precursors to the neoplasms that based on the cases. So I think as morphologists, for most of us here, we could catch up on all our pitfalls during our reporting, where low-grade urothelial carcinoma gets reported as with lamina propria invasion, which I myself personally I could acquaint myself to. And also the entire, I think, presentation where you discussed and you touched upon the practical aspects of our day-to-day reporting nuances. So I think it was wonderful. And at this point, I would just like to open the floor to any concerns or queries that we have. Yes, yes, please, Dr. Anil.
Thank you, sir. Yeah.
We should report it and then do your markers, and then later they got less excited, so we stopped doing it.
Yeah.
So I just wanted to know, in all invasive cases, do you look for it, and do you do immunohistochemistry?
No. No. So we look for it. If you find it, I report it. If I don't find it, I don't say negative. I don't report it. But if I find it, if I'm saying LVSI, I truly have to mean it's LVSI, because LVSI is one of the points which is puts the tumor in the highest risk for non-muscle invasive. So if I find it, I would, and if I have any hesitation, I would put in a marker. But I would also be aware of pitfalls of a carryover or a retraction artifact, etc. So I'll be careful. But it's not the only factor. So my only, what I wanted to say was LVSI is used in all organ systems, right? I think we have to give it some respect and treat it respectfully, because it's now being a part of treatment guidelines. So where it's a part of treatment guidelines, show even more respect. And if it's there, I report it, but I only chase it sometimes with a marker, but not always.
A very good presentation.
Thank you.
Yeah, and as you mentioned, to think like a clinician, I want to highlight one of the few things that I noted in your presentations. You mentioned about a pitfall in a diagnosis where there was PSA positive.
Yes.
And I would like to know if they had done PSA before the operation.
No, they hadn't.
Nothing.
So you don't have prostate cancer patients presenting with hematuria.
Okay.
Okay, so this was in the dome, and this was presenting with hematuria. The PSA was done later. It's just the way the cores were. Okay. They are not urothelial cores. They are very slender cores, and a patient presenting with hematuria, yes, you'll think of urothelial, but just the way the cores are, and there were these tall columnar glands as well, which made me think that this is probably, this is not a typical papillary urothelial carcinoma, a multi-layered carcinoma. And the way it was, the radiology, the centering of the tumor, where it can, so these ductal carcinomas actually present with low PSA. They are not high PSA tumors, and they're more aggressive. Now they're, in the biopsies, the current guidelines say you're supposed to report them as prostate with ductal features, and not ductal. This is an older presentation, prostatic ductal. We call it prostatic ductal when it's more than 50% in your resection. But on this one, this was definitely PSA positive, and it was a prostatic adenocarcinoma. The papillae are different.
And in case of the serous carcinomas, any pre-op investigations that were done that
Yes, so this was a slide and block review. Okay. Now I'd like to highlight one thing, that in a female patient, if you see a micropapillary bladder, always think of serous before you call it micropapillary bladder. So before you suppose you don't have an immunohistochemistry, you must look at the radiology. A bladder micropapillary will be centered in the bladder. Very rarely it causes you extra, it does, but this was omental, ovarian masses, peritoneal deposits, umbilical nodule. This is so typical of an ovarian high-grade serous. Another point, which is very, very important, micropapillary urothelials don't show seminoma bodies. I don't want to say don't, like, you know, like some god saying that. No. Usually don't show. There may be some odd case, but usually they don't show, whereas serous carcinoma, high grade, you all know, shows some seminoma bodies. So what caught my eye was this. I still remember with my resident, we were screening, and she said, 61-year-old female micropapillary, come on. So I said, okay, seminoma body. You know, just put a Paxate also. To make it a story, we make it look like this, so it comes like that. And then you say, okay, put a GATA for completion and put a GATA for presenting it in an audience. But you see a seminoma body, you have to, in a female patient, rule out a high-grade serous. And of course, radiology is certainly going to help you in this.
Thank you.
I just wanted to, when I think like a clinician, I mean, I fail to understand why PSA is not ordered before a procedure.
Yes.
I mean, it's a very simple test and done in almost every center where tube RBT is done. And many a times, I mean, we have seen prostate cancer involving the bladder, and PSA has not been done.
Oh, that's very strange. For this particular case, actually, I won't blame the clinician, the patient, because it's a dome tumor. The patient presented with ductal carcinomas present with hematuria. So hematuria is not a feature of prostate cancer in general, isn't it? They don't present with hematuria. So a cystoscopy was done, and this was probably taken out, and then this was a ductal variant. The papillae, as I said, were different, but I totally agree with you that I would say we should think like an evolved clinician. Next time I'm going to add that and not say just a clinician. So I hope there are no clinicians, but we're just kind of praising you if you're there in the audience.
Good morning.
Good morning.
Thank you very much for an amazing presentation.
Thank you.
And since I work in a cancer center, going through your slides, I feel like I'm doing the day-to-day reporting of my cases. So I think it's an extremely eye-opening session for me. And regarding the last 4 interesting cases, when I was going through the cases, I felt like in case of the plasmacytoid variant in a female, I think if we go on history, sometimes we should also check for a history of lobular carcinoma.
Absolutely, brilliant. So we should. So a plasmacytoid carcinoma, a lobular cancer, and I've seen it at so many locations. The cervix, the most commonly. Endocervical polyp, you're seeing these plasmacytoid cells. No history of cancer.
And the GATA3 is also for breast cancer.
Absolutely, it's for breast cancer. I totally agree. Her breasts were normal.
Yeah,
no, that's a male patient. Sorry.
Yeah,
that's
yeah,
a male
no,
patient.
But if it has been a female, yeah.
Yeah, it's a female lobular cancer, GATA positive, EC-adherent lost.
Yes.
ERPR.
ERPR, yes.
ERPR. And then your markers are ERPR.
And another similar thing, because I have a little more interest in breast cancer as well, that's why. In a micropapillary variant also, I think we should go back and take a history of breast cancer, because we also get a micropapillary
Absolutely.
variant in
breast.
cancer.
So in a female patient, you have to be very careful.
And GATA3
because
is
GATA of the
positive
breast
both.
and GATA urothelial, I totally agree. Absolutely.
Yes. Thank
so
you.
you have to have your antenna up at all times. And if you're very tired, you should just go home, I feel, some days.
Yes, thank you so much.
Thank you so much. Thank you.
Thank you.
Thank you, ma'am. It was wonderful listening to your roller coaster ride. Session was indeed full of jail and valuable knowledge. As with this insight, Dr. Divya Mida is leaving, so I would like to request Professor Dr. Eva Pia to come on stage to hand over token of love to our keynote speaker. Can we all give big round of applause? Thank you. Thank you for being with us. Hope to see you and listen from you in near future events. Let's continue with the session.
Good morning, everybody. Second speaker of today's session is Dr. Hari Chakal. He is Senior Consultant Pathologist, Head of Department of Pathology and Laboratory Medicine in Nepal Cancer Hospital, Harisiddhi, Lalitpur, Nepal. Dr. Hari, please proceed.
Thank you very much, respected chairpersons. Yeah. Slide. Thank you very much. Good morning, everybody. Thank you very much, ACPN and organizers, for giving me this opportunity. Slides. Good morning to everyone in the hall. It's an interesting lecture before that must have, sparked, ignited every audience. But my topic is a little different from the urothelial carcinoma and others, and it's a more of there are no many slides, histopathological slides, but I'm talking about subtypes of the breast cancers based on immunohistochemistry. That is pertinent, important in our context.
Dr. Hari Dhakal has got special interest in cancer diagnosis, molecular pathology, prognostic and predictive markers in cancer, tumor biology, cancer research and prevention, and education as well. And he has got several scientific publications in different national and international reputed journals.
So this is the slide may come later on, but let me talk something while standing here. This breast carcinoma is very much common in the world, and this is ranking #1 now. In 2020 old cancer report, you can see that it's a #1 cancer combined both male and female. So it's very, very important to know something about, but it is a very heterogeneous tumor. So genetically, genetic alterations are so heterogeneous that to classify it into small groups is difficult. So in our part where resources are constrained, how to classify at the molecular level triple negative breast carcinoma, and what is that importance in our context, and how they are being treated in Nepal also is important. So we as a pathologist, Dr. Mehta just told that we should be clinicians. We classify, subclassify, we subgroup, and we give the stage for the oncologist to treat the cancer. भाई पेन ड्राइव तो चले ना.
ल्यापटपमा अलिकति सानो प्रब्लम आएको छ, द माउस इज लक, सो वी आर चेन्जिङ द ल्यापटप, प्लिज बियर विथ अस.
Fine, fine. एवढे मात्र ACPN. Breast cancer is very important. So it is a huge burden. There is huge burden of breast cancer in the world. So I'm talking about basically triple negative breast cancer. But before going to that, I want to talk about something about the case. There is no conflict of interest, and you can see the breast. Okay. Breast cancer is, we all know that where it comes from, and it is genetically very heterogeneous disease. And so we must be aware of that. Diagnosing breast cancer alone is not sufficient. So we have to be careful that after diagnosis malignancy is positive, then we should think of subclassifying and making it tailored for the treatment, individualized treatment for the patient. You can see the most common type of cancer incidence in 2020 in each country among women all over the world. This red color, you can see almost all countries in the world except few have the highest incidence of the breast cancer. So, but these countries, they have the cervix cancer more common. So you can see the cancer breast in female is very much common now. You can see here 6.8 million in 2018 across the world were living with breast cancer. It's very, very high prevalence. But here you can see 2.26 million new cases were recorded during 2020, and 685,000 were died of this disease. So this is still, if we see this picture, here is a cancer registries provided data, but they are incomplete. Developing country, underdeveloped country, they might have reporting less. So it's very important that the load is very high, burden is very high. Here you can see that this is new cases and deaths for cancers in 2020 for both sexes. Female breast cancer is on the top of the list. Previously we used to call the cancer cervix, but now it's lung cancer used to be the topmost in both sexes, but now it's a number 2. So in male still it's a number 1, but combined it's a number 2. So this is a very alarming state of the disease. So in Nepal, if you see in Nepal, in 2020 Globocon, you can see here both is a number 3, but whereas in female is number 2. But if you see the data from NHRC, population-based cancer registry, you can see the urban area has the number 1 breast cancer, whereas rural area has the cervix cancer. So population-based cancer has given that to us. So we should be careful while dealing this disease. So you can see this is second most common according to Globocon. But considering the recent Nepalese census, population census, if you see, 10 years ago our rural population was 2/3. Now rural population is 1/3 and urban population is 2/3. So that might change the case load in future. Classification of breast cancer is mostly histological. We love histology. We saw that. Histology, and that is a very important. Of course, it is essential part, but it is not sufficient for the personalized treatment. So for personalized treatment, we need furthermore immunohistochemical and molecular analysis, and they should support, that information should combine. So now modern pathology reports should have a histological diagnosis combined with immunohistochemical and molecular information that combines the final diagnosis, and that can give the platform for the clinicians, oncologists to treat the disease. So here, classification: histological, in situ, invasive, ductal, lobular, and in the invasive, lobular, and ductal. So there are very special type also, mucinous, medullary, and then tubular, cribiform. A lot of variants are there in WHO classification. So these are, is it sufficient for the treatment purpose? No, this may not be sufficient. So we have to go for the classification, molecular classification based on IHC, and there are, luminal A, luminal B, HER2 positive, and also there are normal-like and TNBC, triple negative breast cancer, which is my main topic to subgroup and discussion today. If you see this here, the duct, luminal cell, basal cell, myoepithelial cell, all this comes, whatever yesterday also Dr. Mehta, he had talked about NGS, all these cells, they transform into malignant cell, and then there are a lot of changes we can see in the genomic and other profile. So what we see is, if you correlate genetic profiling with the histologic correlate, you can see here, this is a low-grade tubular carcinoma. Here you can see the ER positive, and here is high-grade, this is also low-grade, but still there ER positive. This is luminal A and B. If grade 2 and grade 3 ER positive, HER2 negative, we still call luminal B. And this is HER2 enriched genes. You can see this is high grade, and apocrine changes. You can see this is HER2, and here basal-like tumor, this high grade, very high grade, and cysts-like necrosis is present, inflammation is present. You can see that. And so surrogate markers we can use, that is in our part of the world. Not everybody can afford the molecular testing, but immunohistochemistry can be done with the breast panel, and we can subclassify the tumors into 4 categories here. Luminal A, B, HER2, and this TNBC, that is a basal type, we can use. And prognosis-wise, you can see the luminal variants. This A is very good, and then B is intermediate and worse in the HER2 and worse in the basal-like. So response to chemotherapy, low grade, chemotherapy may not be necessary at all. Luminal A, they give only endocrine therapy, and there is also oncotype DX test they do if to determine if they need the chemotherapy. In A, B also, it may need chemotherapy based on those findings. But this targeted therapy and chemotherapy, these two group of patients they need. So this is you can see, we can currently, this is only in TNBC, we have a investigational treatment. Otherwise, normal, conventional chemotherapy is being done. You can see here, breast cancer histologic subtypes and molecular alterations. Here is a luminal type series, here is a basal-like. And here, you can see all low-grade tumors, and but still, they can have a overlapping feature. Some percentage can have a triple negative, HER2 enrich, and you can HER2 positive cases, molecular changes can be there. So heterogeneous, you can see. This can have all this, though this is lobular pleomorphic, but still ERB can be positive, and lot of molecular alterations are there. So this is, we should not forget. Here also, you can see the triple negative can be as high as more than 60%. These are the also, you can see metaplastic carcinoma, adenoid cystic carcinoma. These are considered low grade, but still here you can have the lack of ER positivity, PR positivity, and HER2 positivity. So this can be like, you can overlapping molecular features. So all these combination put together can make a solid final diagnosis. So luminal, if you consider in Canada they have done luminal. This is the luminal A is the most common type, but you see the triple negative is only around 9%. In our part of the world, it's much higher than this. So we follow this here, immunohistochemical based molecular subtype like breast cancer, luminal A, all hormone positive, HER2 negative, low Ki67, luminal B, hormone positive, or HER2 positive, and or high Ki67, HER2 enriched. You can see the hormone negative, HER2 positive, Ki67 can be high. And normal like this is normally we don't do here, but this is normal is also ER positive, PR positive, HER2 negative, low Ki. And basal like this triple negative can be subclassified into two. Triple HER2 negative, PR negative, but here CK56, EGFR, they can be positive and Ki is high. Claudin low type triple negative, here is also triple negative, but there is a low Ki, and this is a low grade tumor. E-cadrine, Claudin 3, 4, 7 are positive. So this is important. So this is what is the importance of this subclassifying? We have clinical implications. We have to treat this based on this prognostically. When patient asks what will happen, what is my treatment to the oncologist, they can answer only based on this. See, this is luminal A, this is very good prognosis, and you don't need further treatment, only endocrine therapy. Or it's a triple negative, we give the care. Now, even triple negative, we diagnose before treatment starts. If in the biopsy, we say triple negative, they give even chemotherapy in early breast cancer so that they can downstage melt the tumor. We have seen some cases, even primary tumor has disappeared after the chemotherapy in such cases. So this directs the plan. This subgrouping is important for direction of the treatment system. So we must have a directed therapy, personalized therapy, or individualized therapy, what is called tailoring of the treatment. Like stitching the sort for a person, we have to stitch the treatment to the patient. So you can see what is the here. You can see 4 classification. This is a large number of cases where subclassified, and you can see the prognosis, overall survival. Triple negative is worst, and luminal A is the very good. You can see the difference between the curves, Kaplan-Meier curves. You can see very good prognosis here. Luminal A, but you can see both HER2 enriched and triple negative have a worse survival. So what is triple negative breast cancer then? A specific subset of breast cancer that lack expression of ER/PR, HER2 on IHC, and that includes we should call FIS positive also. That also includes FIS negative also. If 2+ we do FIS, and if negative, it's a triple negative. If IHC 2+ and FIS comes positive, it is not triple negative. So accounts around 15 to 25%, but varies from around 9% to in Asia that go up to 40% around. Overlaps like basal-like breast cancer, which are defined by gene expression profiling, is now gene profiling may be overtaking the other things if it is cheaper and doable in our context. Highly aggressive tumor, this triple negative, but it is very heterogeneous tumor. and higher rates of axial lymph node metastasis, and it is considered highly chemosensitive. Triple negative breast cancers have been reported to exhibit heterogeneous morphological features. We all know that. And this although they primarily express as invasive ductal carcinoma, they have been found to exhibit medullary, apocrine, and metaplastic nature as well. This is very important. And we already saw that there can be low grade, intermediate grade, high grade in the same slide in histopathology sections. So heterogeneous. We have seen that grade 1 to grade 3 or 4 tumors can be present in any tumor in the hematoxylin eosin stain. So you can see here, this is a low grade TNBC, this is high grade. You can see this is adenoid cystic carcinoma, secretory carcinoma, and this is metaplastic fibromatosis-like metaplastic carcinoma. You can see these are the low grade. Morphologically, it is different from these. So this is a high grade infiltrated ductal carcinoma. This is squamous cell carcinoma in the breast. This is a spindle cell carcinoma or sarcomatoid carcinoma. And here you can see carcinoma with heterologous element. This is a chondroid. This is osteoid elements. So this is you can see carcinoma with medullary-like features. And here necrosis and anaplasia, anaplastic features, and frequent mitosis. This is completely different. All morphology is so heterogeneous, so heterogeneous. So this all are triple negative tumors. So it makes the problem, it creates the problem what treatment they respond to. So we have to tailor it down. So here also, if you see morphology, this is a seeds of tumor cells, but there is pushing margin. You can see the variation. And here is nested patterns, and there's groups, and there is a pushing pattern, but here is peritumoral lymphocytic infiltration is also there. In contrast, this high grade, very frequent mitosis, and this is anaplastics there. Here, estrogen receptor is negative, but you can, I already talked that CK5 or 6 and EGFR can be used to divide triple negative cancer into basal-like and non-basal-like tumors. So that also differs, that makes the easier for the oncologist to choose the treatment. You can see the stage is, in any stage, TNBC and non-TNBC has different survivals. In all the stages, you can see you can see here stage 3C to stage 1. You can see all TNBC is worse survival than non-TNBC. Red is non-TNBC and black is TNBC. So this is very important. So to differentiate between two categories. So if you see this image also, triple negative breast cancers have tendency to metastasize to brain and lungs, the more propensity compared to the non-TNBC, which has more bone and liver. So this is important also. Race and survival, you can see the difference in African American and Caucasian, that TNBC survival is very different. So it's there is a variation between group, ethnic group, and race and survival. So now, as we talked, there is still ongoing research, and they are trying to subclassify TNBC also into different categories, subgroups, like basal-like, 1, 2, and luminal androgen receptor-like, and mesenchymal. They have clubbed this together in some places, mesenchymal and mesenchymal stroma-like, and immunomodulatory. This is very important now at tumor-infiltrating lymphocyte. This immunotherapy is important in this category of the tumor. So based on this, there are a lot of cell signaling pathways, cell cycle and DNA damage pathway, growth factor signaling and metabolic pathway, hormone regulation pathway, and cell motility and cell differentiation pathways, and similar to this one. This is, we can call together, and cell immune, like a tumor infiltrating it. Here, in cold tumor and inflamed tumor, non-inflamed tumor and inflamed tumor can be there. So based on that, they select PD1, PDL1 in staining can help here. So this is important. So now PARP inhibitors, platinum treatment, they can select based on this. So we have to subclassify as per, this is all important, but it is still in process, in the evolution. So in Nepali context, TNBC, only 3 reports I found, that Acharya et al. 2012, Nepal et al. 2015, and Khanal et al. 2020. These 2 are from TUTH, I think, and this one is from Beer Hospital. So this is the percentage of their cohort which has the triple negative tumor like that, from 17 to 4%. We also looked into it. Say, present study in Nepal Cancer Hospital Research Center, we did it to determine prevalence of triple negative breast carcinomas and evaluate its association with different histomorphological, histopathological parameters. So this is, I wanted to see if we can have a significant number of triple negative breast cancers so that we can help our oncologists to decide the treatment. It was the cases that came to the Department of Pathology at the hospital between January 2016 and 2018. We selected only those cases which had all 4, ER, PR, HER2, and Ki67 done and information available. And we had 258 cases during that period, and 31 didn't have full report, so we excluded them from the analysis. So we classified tumor like this: luminal A, hormone ER positive, or PR positive, or both positive, HER2 negative, Ki67 low; luminal B, ER positive, and or PR positive, and or HER2 positive or Ki67 high; HER2 enriched, ER negative, PR negative, HER2 positive, and TNBC, ER negative, PR negative, HER2 negative. You can see how we classified our tumor, where based on immunohistochemistry, this is a ER positive, PR positive, and HER2 score. This is a not complete, and then Ki67 10%. So we put it as a luminal A. And here you can see this is a 80% PR, ER, and PR also high. And here we can see there is a 2+ equivalent, equivocal. So Ki67 was 20. So we thought, irrespective of this FISH test, we put it luminal B. And here we can see ER negative, PR negative, and HER2 very distinctly positive, HER2 positive. And here all 3 negative, and Ki67 very high, triple negative tumor. This, based on this criteria, we subclassified tumor, and what we found was, to our notice, that luminal B was in the Western literature, it was luminal A was high, but in our case, we found luminal B was around 40%, and followed by nearly 30% were TNBC. If you see this TNBC with the age, you can see in less than 40 years, significant, around 41% cases are in this age group. Total, you can see 38 is non-TNBC and 26 is TNBC. So this is a graph shows already that this is more common in the younger age group. This is very aggressive tumor present in the younger age group. And even below 50 is higher rate. So this is, but considering above 50, below 50 is more common. You can see the more common. And here histological grade, higher grade, and more TNBC. If you see lymphovascular invasion, this is a more, it is to our surprise, lymphovascular invasion absent group has a more TNBC compared to the LVI present cases. This is to our surprise. That is very something different. And TNBC with versus T stage, you can see stage, we can see the higher stage, higher TNBC. This table show the same thing. You can see the clearly significant association in the age group. Younger age, below 40, almost out of 64, 41% around is TNBC. Here, grade 3, you can see almost equal to both of them, TNBC and non-TNBC in here. But LVR T stage, you can see here also more in the TNBC group. So these three groups were showing significant association, but other like histological subtypes, Ki67, any stage, and lymph node metastasis didn't show any association in our group. So in conclusion, breast cancer is the most common cancer worldwide. TNBC is a heterogeneous group of disease, and it's important to take care of it because we have to subclassify. And TNBC is present in large proportion of breast cancer patients, around 30% in our group, and around 40% in younger age group. TNBC is significantly associated with age, grade of the tumor, and T stage. What are the clinical implications of this? A traditional classification we can do. That is very essential. Again, I repeat, like yesterday Dr. Pante has said, histopathology diagnosis is essential but not sufficient enough. So we have to support it by ancillary testing like IHC and molecular testing. So that is important for like hormone receptor positive. This is very important that before the start of the treatment in breast cancer, after biopsy, if we do ERPR, HER2, and Ki67, and we subclassify luminal A, luminal B, and triple negative tumor, then treatment can be tailored down to the treatment. Like in our context also, they do the chemotherapy, even if it is early stage of TNBC. So that they do surgery later on. So now, in the early stage, there is again reports, some cases like hormone positive tumor, they give the treatment or neoadjuvant hormone therapy and they go for doing the surgery afterwards and look for the Ki67 afterwards also to see whether they need the chemotherapy or not. So this is very important to qualify, to subclassify the tumors. And this is very inexpensive method compared to the molecular testings. As Dr. Mehta yesterday said, that each molecule, if we test, it becomes expensive. If we do NGS, that is less expensive. NGS in Nepal may be very expensive now because we don't have that facility as such in a given context, and there is a lot of sophistication that requires. The advent of high throughput technologies revealed an unprecedented amount of data on transcriptomic, epigenomic, genomic, and proteomic alterations. So combine this, we should, there is no shortcut, but we have to have grouping this together. We should be subclassifying breast cancer to better plan individualized treatment and convey prognosis to our patients. Because we are the important member of the multidisciplinary team, tumor board team. So we can contribute by advising or by doing this test and can help the patient get the right treatment to her as required. So does genetic testing for TNBC patients make sense? Whether we should do the genetic testing like BRCA1, BRCA2 or others. So this is recent publication, they are from Mayo Clinic. They have suggested that all TNBC patients should undergo multi-gene panel testing regardless of age. That is because ongoing development of targeted therapy for patients with mutations in these genes may be possible in triple negative tumor. Though still it's in the primitive stage, but still we can subclassify triple negative tumor and can. Because triple negative tumor the compounded in breast cancer is more tumor microenvironment. So that is the important role that plays for the individualization of treatment. So I think this is very important message to take is several genes like this BRCA1, BRCA2 and others should they predispose with high lifetime risk for TNBC. So the question comes, one TNBC patient should test their relatives or not. That is still not talked about, maybe in future. So like any other breast cancer, this should also have the hereditary germline mutation testing. Thank you very much.
Thank you, Dr. Hari, for your excellent presentation. Thank you for enlightening us on breast cancer, specifically triple negative breast cancer, its molecular classification, its aggressiveness, and its bad prognosis, and how it impacts the treatment. Now the floor is open for discussion. Any question from the audience, please?
Okay, sir, thank you.
So all cases of triple negative breast cancer, irrespective of the age profile, shall undergo testing for inherited cancer predisposition. There are 6 genes which must be tested. Those are BRCA1, BRCA2, PALB2, JAK2, TP53, and CDH1. Okay, CDH1.
They have included
so
RAD551.
That's what I'm updating on those. These are the 6 which are absolutely essential to be tested. And there are 2 genes which can be tested. These are CDK12 and BAD1. And there are 2 which are emerging marker, which are RECQL and RINT1. But I think these kind of lists are floating everywhere, 23 genes, 29 genes, 34 genes, and these people come and they try to sell bigger panels to you. The problem with the bigger panels and these genes is that we really don't know what is the relative risk of occurrence in the relative risk of occurrence of the cancers in the individuals in whom these mutations have been identified. Suppose the risk is 1.1% or 1.2%. You don't want to saddle that individual with the fear for the rest of her life that you will get a cancer. On the other hand, if the risk of developing cancer relative risk is 2-fold to 5-fold, then it makes a sense to test. So all those genes are not required, and the 6 genes that I have listed are the ones which should be tested for.
Yeah, they suggested that 30% TNBC cases, if we BRCA1 positive is there, then 30% lifetime risk to develop breast cancer TNBC again. That has been suggested. So.
Thank you, sir. So could you shed light on Oncotype DX?
Oncotype DX, maybe sir can highlight instead of me.
So, Oncotype DX there are several risk stratifiers. One of them is the Oncotype DX. This is used for invasive breast cancer, which is ER/PR positive. There is a separate one for the DCIS, but that one is not used. The one that is often ordered is the Oncotype DX breast for invasive ER/PR positive cancer, HER2 negative, with or without lymph nodes. So it's basically a 21 gene panel in which 16 genes are the genes which are actually interrogated and 5 are used for normalization. If the score is below 26, then the patient can actually avoid taking chemotherapy. If the score is 26 or more, then chemotherapy is warranted. But in case of premenopausal women, the score of 16 to 25, they can also obtain a small benefit from chemotherapy, and that will be a shared decision between the patient and the doctor whether they shall take chemotherapy or not take chemotherapy. But there is a 2% advantage of having a disease-free survival in premenopausal patients with a score of 16 to 25.
So this is only in luminal group of the patients, luminal hormone-positive cases.
So all luminal. So you can divide your luminal A and B based upon your surrogate IHC.
Yes.
But for purpose of testing, we do the testing because this kind of luminal A and B division is not absolute in terms
there
of
is a
risk stratification.
Overlapping features are there, lot of heterogeneity.
Thank you.
So
Thank
it's
you,
a,
So when you were talking about the triple-negative breast cancer, I was thinking a little bit in opposite way as I usually do. What is your experience in triple-positive breast cancer? How frequently you see, and what is the LV status? What is the T stage prognostically? Can you please share your experience?
Very interesting, cousin. When we report, we get the triple positive. But if you see the subclassification so far, we have done immunohistochemically, it is luminal B. So they might require the chemotherapy in such cases. Because there is no classification as such triple positive in breast cancer so far. I have not heard about this. Maybe Dr. Mehta can highlight it, but I have not heard about this. But this is luminal B as such, this is now.
I've actually stopped reporting breast, but about 5 years back, when I had analyzed my data, so that time we had around 22% patients who were HER2 positive, and 8% of these were ERPR and HER2 positive. 14% were just HER2 enriched, and 8% were triple positive, the cases you were asking. The physicians often find these difficult to treat, and my personal experience, and this is just observational, I've really not done much studies. These are the patients which behave worst. They have a habit of coming back where the patient, and you don't know how to combine and a hormone modulation with anti-HER2 therapy.
They are treating.
They get both, but probably they derive very less benefit compared to those with a HER2 positive breast cancer only.
Oncologists, they are treating both nowadays, both endocrine therapy and targeted therapy, anti-HER2 therapy. But this is not absolute. And I have come across the literature that there are low expression of HER2 also. 1+, 2+ being investigated. There can be also post-treatment conversion. Positive to negative and negative to positive is also issues there. So we have to take consideration of all facts while reporting and individualizing the patients. I think that's what I have come through. We do that. We take all information of a patient and then make the individualized approach for that. Because we saw that histopathology picture is one side, and when you do molecule, you put it another side. And how to correlate is important here also, because as a pathologist, if I see the adenoid cystic carcinoma, what I think is triple negative or basal-like or not. So we can select the test also, probably based on the morphology. And the morphology helps us to select the test.
Thank you, sir.
Thank you.
So I'd like to break here, and just information that we would be taking up questions at the end of the session, and we would like the speakers to finish on time. Thank you. Thank you, Hari sir, and sir, for your wonderful deliberation and answering the questions. Thank you. So now, moving on, I call upon Dr. Ranjan Raj Bhatta. He is the Chief Consultant Pathologist, Ministry of Health and Population, National Public Health Laboratory, former head of Department of Pathology, BP Koirala Memorial Cancer Hospital, Chitwan, Nepal.
Thank you for your kind introduction. My respected seniors and all my dear colleagues, I'll be talking today on small round cell tumors. Today I've been told to talk on approach and updates on small round cell tumors, which overall is a very vast topic, so I only try to scratch the surface. Coming to the approach, so what is our usual approach in the soft tissue? First, let me go to the sarcoma as a whole. What is our approach? Approach is what is the lineage? Is it coming from the fibers, or is it a neural tumor, or is it coming from the smooth muscle or a bone tumor? So how do we come to the diagnosis? Usually we have been hammered on the morphological and now the immunohistochemical features and coming up the genetic features. So usually we make the diagnosis by the IHCs, the lineage, what lineage it is coming from, the tumors. And it can be further aided by molecular testings like FISH or RT-PCR. And regarding the molecular classification of sarcoma, according to the genetic alteration, it can be divided into sarcoma with specific genetic alterations, simple oncogenic mutations, and others with complex karyotypic abnormalities with no specific patterns. So the example for specific genetic alteration will be like synovial sarcoma. And with simple oncogenic mutations will be with the GIST, where there's the activating mutation in the c-KIT gene. And other sarcomas which display multiple complex karyotypic abnormalities. We don't have specific patterns like undifferentiated pleomorphic sarcoma or leiomyosarcomas or even osteosarcomas. So how we do the molecular profiling and what are the methodologies for the sarcomas? First of all was the conventional cytogenetic analysis, FISH, PCR, and the now the massive parallel sequencing. So conventional karyotypic is of historical importance because it has a long turnaround time, and there's a requirement for the cell culture medium, and it has a low resolution and inability to pick up cryptic mutations. Then comes the FISH, where we use probes to localize the genes of interest. That may be break apart probes, dual fusion probes, or even locus specific probes. And the PCR technique is used to specific primers to amplify the known DNA or RNA sequences, and it has greater sensitivity and high resolution and a short turnaround time. But the disadvantage of PCR and FISH is lack of wide availability, and we can get the information only about the probes or primers we have. We cannot get additional information from them. So now the concept of massive parallel sequencing. So it is the comprehensive whole exome or a genome or a transcriptome approach. And my job here is made easier by the detailed and comprehensive lecture by Anurag sir yesterday. So I'll only scratch the surface. So why do we focus on massive parallel sequencing nowadays? Because they can identify novel mutations and copy number variations and point mutations. And in the massive parallel sequencing, there are the sequencing techniques include the traditional Sanger sequencing, next-gen sequencing, and now the third generation sequencing like the nanopore sequencing. So it is more useful than PCR or FISH because for the diagnosis of unknown mutations. So regarding the NGS, we can use the whole genome sequencing, targeted sequencing, or RNA sequencing. So whole genome sequencing is the most comprehensive sequencing technique where we analyze the whole genome. But it is not clinically practical and not cost effective as well. So now we are coming to the targeted sequencings, where the exomes are only sequences, and as we were discussing earlier as well, there are gene panels for specific cancers, malignancies. So regarding the whole genome sequencing, exome sequencing will limit the general cost. And since the exome accounts for only 2% of the entire genome, so it will be more cost effective. And the disadvantage will be that it will miss on the novel gene mutations. We'll be only looking at the panels, so sometimes we can miss that. And especially when the sequences are in the non-coding portion, then we can miss those. So next is the RNA sequencing, transcriptome sequencing, where we can detect all those, but more technically challenging because it has to perform in RNAs, which are more unstable than DNAs. So now coming to the practical approach. The practical approach is the shift of paradigm now. From previous we had a one-size-fit-all treatment for sarcomas, now to more histology-specific treatment algorithm, and now then to the histology-agnostic genetic approach. That attempts to tailor the treatment and oncologic resection based on these. So another approach is, as our predecessor has also said, it's a multidisciplinary approach. We have to involve the whole team. As our seniors used to say, you have to talk to the clinician, he will give you the diagnosis. So as we do a pre-treatment core biopsy or an incisional biopsy, and tissue diagnosis is more important where we use neoadjuvant therapies. And so the review of the specimen must be done by experienced pathologists with access to ancillary techniques. So NGS has also helped to spur the advent of precision medicine, and involves the designing the treatment based on the person's disease-driving molecular alterations. And we have to sequence the tumor to match these mutations so that we can target the genetic alteration that is driving the tumor growth. So it can improve the outcome by matching each patient with a therapy that is best suited to treat their individual cancers. So yesterday also the term was there, the actionable mutations, which are potentially responsive to a targeted therapy. Because the whole information we get may not be important, we may not be able to make use of them. So the precision medicine refers to the treatment that based on understanding the individual gene, and which provides a precise and individualized treatment to the certain patients and diseases. So precision medicine in oncology can be used to identify the actionable alterations or assess the hereditary cancer risk. We are talking about germline and somatic mutations here. So what we can do is to assess the relevant cancer biomarkers, and so that we can match the patient with the best treatment possible. And also used to assess the hereditary cancer risk in other patient and maybe even the relatives of the patient, so that we can also screen them. So what it has led to is the improved overall response rate and survival when compared to patients who do not receive the sequencing masked therapy. So Lee et al. Reported that PD-1 blockade treatment was effective across 12 different tumor types, which had a loss of function. So this led to a trial for the drug pembrolizumab, and which was given to all those patients solely on mutation and not the tumor type. So this is basically a histology agnostic approach or a pure precision medicine approach. So we don't care about whether it was a carcinoma or a sarcoma. If there was loss of function, then the treatment was given. So other molecular defined treatments are also present. So coming to the round cell tumors. So we all know these are the group of generally malignant tumors, monotonous proliferations, and the prototype of small round cell tumor is the Ewing sarcoma. So it is characterized with the fusion of the FET and ETS family of genes. So coming to the diagnosis, histology and immunohistochemistry are suggestive, and now it is considered standard of care to confirm the diagnosis by detection of the translocations. So here we can see is a diffuse CD99 membranous positivity in Ewing sarcoma. Now, if you don't see a diffuse and strong positivity in Ewing sarcoma, you have to reconsider your diagnosis. Then you can also do the nuclear staining for FLI and NKX 2.2, which will be positive in Ewing sarcoma. Now, these are comparative pictures of the CD99 positive. This is in the Ewing sarcoma. This is diffuse and very strong membranous positivity. While in cases of other round cell tumors, which have fusion with other genes other than the FET genes, then they might not be as positive or weaker translocated or sick translocated tumors, where there is not such strong positivity as seen in Ewing sarcoma. So if we have, we don't see this pattern, maybe we'll have to reconsider our diagnosis of Ewing sarcoma. So molecular hallmark is the translocation of a fusion of EWSR gene and ETS transcription factors. So approximately 85% of genes, EWSR will fuse with FLI1, other 10% with the ERK gene, and rest of them with the other members of the ETS family. So the molecular testing can be done by FISH or RT-PCR. And FISH, here we can use the EWSR dual color break apart probe. This is the normal signal here with the, and break apart probe, this has been translocated of the EWSR gene. But this might not be specific, because there are many tumors where the EWSR gene is translocated. So more specific will be the fusion here, where we can see the EWSR FLI dual color fusion phase. So sometimes the small group of Ewing sarcoma show first gene rearrangement instead of EWSR with the ERG or FEV fusion partner, so we may miss on that with the fusion only of the FLI gene. So now, as we have discussed earlier as well, new WHO has established the essential and desirable criteria for diagnosis. So I want to reiterate that the CD membranous expression is the essential part for the Ewing sarcoma diagnosis, and desirable is the FET-ETS fusion detection. So what are the precision medicine approaches for management? So as we have already seen that the translocation is the triggering factor and it is the driver. But here we can see that in the Ewing sarcoma, it is low somatic mutational burden. And there may be other recurrent oncogenic mutations in the tumor suppressor genes like STAC2, TP53, CDKN2A. And their germline variants may also suggest clinical use of novel targeted therapies. But in case of Ewing sarcoma, rather than upregulating the downstream pathway, it is more of the downregulation. So the treatment regarding the fusion is a bit not found till date. And sometimes the BRCA1 and BRCA2 deleterious germline mutation may also be seen in these cases, which may also benefit from PARP inhibitors. So as I said earlier, there might be prognostic markers for recurrent mutations like STAC2, CDKN2A, TP53. And STAC2 mutations, particularly combination of STAC2 and TP53 mutations, is a poor prognostic indicator. Now another technique right now is the liquid biopsy. It is of growing interest. So it can be used to monitor disease response and for early detection of relapse. So in the DNA captured by NGS or digital droplet PCR, there can be detection of plasma-derived cell-free DNA, which may be used to identify newly diagnosed patients. And presence of detectable cell-free DNA was also associated with worse 3-year event-free survival and overall survival. So initial efforts have showed nearly 100% sensitivity for detection in patients with measurable disease. And the quantity of the DNA was also noted to correlate well with the disease burden. Now coming to other undifferentiated round cell tumors we might see is the sick rearranged sarcoma, Bicor rearranged sarcoma, and round cell sarcoma of EWSR and non-ETS fusion. So sick rearranged sarcoma is usually more frequently in bones, and it clinically aggressive, more aggressive than the Ewing sarcoma. So sick sarcomas usually exhibit focal pleomorphism and at times epithelioid morphology, which can predominate. And here we can see the positivity for WT1 and ETV4. And here we can see the break apart for the sick gene. So what are the essential criteria for the diagnosis? Will be the predominant round cell phenotype, mild nuclear pleomorphism, sometimes epithelioid or spindle cell components in a myxoid stroma, and there might be CD99 staining, which may not be as strong as in Ewing sarcoma, and frequent WT1 and ETV4 positivity. And the desirable criteria is the sick gene rearrangement. The B-core rearranged sarcoma is characterized by B-core CCNB3 fusion, and other fusion partners may be mammal3, or there may be internal tandem duplications. The histological clues on B-core rearranged sarcoma will be the proliferation and spindle cell component and variably myxoid stroma with delicate vasculature. Here we can see a bit of epithelioid morphology, and they may be positive for SAT-B2, B-core, and cyclin D1, and they have a relatively favorable prognosis. And the essential criteria are the primitive round cell to spindle cell arranged in nest, seeds of fascicular growth with a variable myxoid stroma with delicate vasculature, and desirable is the molecular conformation of B-core genetic abnormality. And there may be round cell sarcomas where the EWSR1 gene is fused with non-ETS fusions. And the usual suspects are NFAT-C2 and PADS1. So NFAT-C2 sarcomas arise predominantly in the long bones, while the PADS sarcomas arise in the deep soft tissue of the chest wall and abdomen. These are also composed of small to medium-sized tumor cells or spindle cells, and they may be arranged in cords, small nest, and trabeculae. There we can see within myxoid stroma and PADS-rearranged sarcoma, we can see a more pseudoacinar pattern as well. And in the PADS, they may be positive for CD99, PAX7, and NKX2.2. And here we can see this is the break-apart port probe, where we can see EWSR is, there is the amplification of the signal. And PADS sarcomas are more, they might have divergent differentiation into neurogenic or myogenic. So we can see myogenin or MyoD1 positivity along with S100 and SOX10 positivity in these cases. So essential features for the NFAT-C2 sarcomas are mostly they are low-grade features, but high-grade features are also reported, and there might be the EWSR break-apart phase, as I showed earlier, with the amplification as well. And so the identification of the fusion transcript remains the gold standard here. So the desirable are, usually it says that NFAT-C2 are more common in long bones, while in the PADS1 rearranged sarcomas, they are round to spindle cells with divergent phenotype, both myogenic and neurogenic. Now coming to rhabdomyosarcomas are the largest category of soft tissue sarcomas in the children and young adults. They may be classified as embryonal, alveolar, spindle cell sclerosing, and pleomorphic, while pleomorphic typically does not demonstrate a small round cell morphology. The embryonal subtype is the most common, affecting the children. And these show primitive mesenchymal cells within loose myxoid stroma admixed with variably differentiated rhabdomyoblasts. Here we can see a loose stroma and a rhabdomyoblast in embryonal. And these are positive for desmin, myogenin, and MyoD1. And there are not much reproducible molecular genetic alteration in the embryonal variant. While they may be associated with DICER1 mutations, and the DICER1 mutations, if they are associated with them, the morphologically they will have islands of cartilage or osteoid or other non-rhabdomyomatous components. So the diagnostic criteria as defined by the WHO now is the primitive round to spindle cell morphology and positivity for desmin, myogenin or MyoD1, and desirable is the lack of FOXO1 gene arrangement to distinguish poorly differentiated embryonal rhabdomyosarcoma from the solid variant of the alveolar rhabdomyosarcoma. Alveolar rhabdomyosarcoma appears a little later in age, in the second to third decades of life with monotonous population, with primitive hyperchromatic round cells. Here we can see the typical alveolar pattern. And they have a diffuse and strong myogenin expression. And here we can see this is the alveolar part with the strong myogenin expression, while in embryonal rhabdomyosarcoma there may be heterogeneous and focal. Now the molecular signature of rhabdomyosarcomas are the translocation 213 and 113, which result in the PAX3 and FOXO1 and PAX3 fusion genes. So these translocation 213 and 113 are present in 56 to 6% cases. Here we can see the dual break-apart of the FOXO1 gene. Here is the normal signal, while the abnormal signal, they have been split. This is the abnormal signal. So the diagnostic criteria is the uniform, positive, round cell morphology with features of arrested myogenesis. Alveolar growth pattern is common but not required. And there must be a homogeneous nuclear expression for myogenin and desmin and MyoD1. And the desirable is the detection of PAX3 or 7 FOXO1 fusion genes by molecular analysis. So histological classification is no longer the primary tool for determining prognosis. FOXO1 fusion status drives unfavorable outcome for children with rhabdomyosarcoma. Another variant is spindle cell or sclerosing rhabdomyosarcoma. The spindle cell variant maybe we can differentiate, but the sclerosing may be confused with the small round cell tumors. Here we can see round cell tumors within a diffuse sclerotic stroma. Now, according to the genetic abnormalities, these can be characterized into 3 groups. First, the congenital infantile spindle cell rhabdomyosarcoma. Second is the presence of MyoD1 rare mutation, and another variant is the intraosseous sclerosing or spindle cell rhabdomyosarcoma. So congenital, so the gene fusions for VGLL1, SRF, and COA2 and cited 2 genes. While the second one is the characterized by presence of MyoD1 mutation, and the intraosseous variant is characterized 2 gene fusions. Again, the EWSR1 or FUS gene being fused to TFCF2 gene, or MEIS1 and NCOA2 gene fusion. So the diagnostic criteria for this category is the cellular spindle cell fascicles or tumor cells in a variable sclerotic background, positivity for desmin and MyoD1, and desirable is the presence of MyoD1 mutations or various other gene arrangements. So I'll skip this. Now coming to the other round cell tumor, the desmoplastic small round cell tumor. It is characterized by the EWSR1 and WT1 gene fusion, and primarily affects children and young adults arising in abdomen, retroperitoneum, pelvis, or with widespread serosal implants. So these are typically arranged in irregularly counted nest embedded in prominent desmoplastic stroma. And these have multi-phenotypic differentiation with the IHC positivity for cytokeratin, EMA, desmin, NSE, and C terminus of the WT1 gene. While here we can see the small round cell tumors within fibrous stroma, and here we can see the nuclear positivity for the C terminus, while the N terminus positivity of WT1 gene is seen in Wilms tumor. Here we can see perinuclear dot-like desmin positivity and EMA positivity. So detection of the EWSR1 WT1 rearrangement is the diagnostic for desmoplastic small round cell tumor. So you can see in the whole chromosome paints the translocation between 11 and 22. So the essential diagnostic criteria are nest of small round cell tumors in desmoplastic stroma, and positivity for cytokeratin, desmin, and WT1. And desirable is the demonstration of the gene arrangement or fusion transcript. So another DD in small round cell tumors may be poorly differentiated monophasic synovial sarcoma. And these arise in deep soft tissue of lower and upper extremities. And poorly differentiated areas may show small round hyperchromatic tumor cells, which may be confused with other round cell tumors. So how do we differentiate them? This is the TLE1 staining, which is diffuse, but some school of thought are now saying that TLE1 is the next Vimentin. And we are also talking about the molecular surrogates in IHC as well. So here we can see there are new stains for SS18 and SSX fusion and SSX C terminus, where we can see the positivity even in biphasic and monophasic synovial sarcomas. So the unique translocation in synovial sarcoma is the X and 18 translocation. So these also have otherwise low mutation burden. So here we can see the S18 break-apart probe showing break-apart of the signals. So if we have the molecular surrogates in IHC, which can be more readily available as FISH requires more sophisticated instruments. So coming to the round cell sarcomas producing cartilage or bone matrix are the small cell osteosarcomas and mesenchymal chondrosarcomas. So in small cell osteosarcoma, as Abhimani sir talked about yesterday, it can be difficult when in small biopsies when osteoid may be scarce or absent. So here we can see presence of lace-like osteoid, which is the confirmatory for small cell osteosarcoma, and there may be a positivity for SAT-B2. In osteosarcomas, as other conventional osteosarcomas, no recurrent molecular genetic abnormalities. There will be more complex abnormalities. So the essential criteria are the small blue cell with focal neoplastic bone formations. And desirable are tumor cells with high-grade atypia, atypical mitotic figures, which may be seen usually in osteosarcomas. Mesenchymal chondrosarcoma is a rare tumor. You may be seen in jaw bones followed by spine. And in these, we can see the primitive appearing cellular round to ovoid cell proliferation along with lobules of cartilage, which is diagnostic. Here we can see hemangiopericytoma-like pattern along with round cell tumors and a foci of cartilage. So cartilaginous markers may be positive in this one. And the characteristic is the He1-NCOA2 fusion. And IDS1 and IDS mutations which are seen in conventional chondrosarcomas are not seen in mesenchymal chondrosarcomas. So this fusion of the rearrangement of chromosome 8q was absent in other subtypes of chondrosarcomas while it was present in mesenchymal chondrosarcomas. So as we said, the essential criteria are the undifferentiated tumor cells along with islands of cartilage, and desirable are the demonstration of the A1-NCOA2 fusion. Myxoid liposarcomas may also present, especially in the cellular variants, may also present with small round cell tumors, and these are characterized by the first DDIT3 fusion. So this is the classic picture of the myxoid liposarcoma, where you can see the typical blood vessels along with lipoblast. But in the cellular variant, it may be confused with other round cell tumors. So it is characterized by the DDIT translocation. Usually, the usual suspects are the FUS and EWSR1 genes here also. So as I showed earlier, break-apart probes directed at DDIT3 will be diagnostics. These also have lower mutational burden, third promoter mutations, and mutations that activate phosphoinyl kinase pathway and mTOR. So diagnostic criteria, as already said, are the myxoid matrix, bland round to ovoid cells, variable number of small non-pleomorphic lipoblast, and desirable or the more diagnostic is the demonstration of DDIT3 rearrangements. I was given the soft tissue part. So neuroblastomas usually don't appear in soft tissues, but the metastatic variants are more be common, because the mets in the bone may be the first presentation in children for neuroblastomas. So here we can see bone mets, typical lobular pattern with small round cell tumors in a neurofibrillary matrix in a bone. So usually they are positive for the neuroendocrine markers, and the FOX2B marker is considered specific for neuroblastoma. And usually they are due to the acquired amplification of the MYC gene and hemizygous deletions of the 1P, 11Q, and gain of 17Q. Here we can see the specific probe, red signal is the probe for the chromosome 2, while these are the NMYC signals which are amplified a lot. And here we can see the only one red signal for the chromosome 1p23. These are the normal signals, so there is the loss of heterozygosity. So there is an overall low somatic mutation count, while ALK was the most frequent mutated gene here. FOX2B and ATREX have also been detected in subset of primary high-risk tumors. So the new immunotherapy with anti-GD2 or dicyalogangliosidenase as ganglioside tumor-associated surface antigen antibody. So I will not be talking much about non-Hodgkin lymphoma because the lymphohematological part was done yesterday in a comprehensive fashion. But
1 minute left.
Okay, thank you. These can mimic Ewing sarcoma radiologically. So we'll need to differentiate it from them. And the most common subtypes are the diffuse large B-cell tumors. And another, the Wilms tumor, where we can see the typical features, and in the blastomal components only seen, then it will be difficult. But here, as N-terminus positivity is seen in this Wilm tumor, as we already saw the C-terminus in cases of desmoplastic small round cell tumor. Okay, there are also mutations there. So in conclusion, so as the sequencing costs continue to decrease, NGS-based approach to identify diagnostic alterations and targeted therapy options in the sarcomas are likely to be more common. And given the rate of innovation, molecular testing of sarcomas should gain increasing importance in years to come. Now coming to the more to the essential criteria rather than the desirable criteria. So why do we need these tests? Of course, for the diagnosis, for the prognosis and treatment, and lastly, to monitor the response to treatment. Thank you.
Thank you, sir. Questions will be entertained at the end of the session. I would like to call our next speaker, Dr. Anju Pradhan from BP Koirala Institute of Health Sciences. Thank you.
Dear delegates, we are already lagging behind the schedule, so there won't be any tea break. Kindly abide as per your convenience. The program has started at Hall 2, so we request presenters at Hall 2 to move towards Hall 2. Thank you, and we'll be continuing this session.
Good morning, everyone. Good morning, everyone. Thank you. I'm honored to share this stage with such eminent speakers that we have heard so far, and I'm thankful to Dr. Runa and the entire team for giving me this opportunity. What I'm going to talk about is a roadmap to neoplastic hepatocellular nodules. Hepatocellular nodules it's a huge entity, and today I'm going to talk about the neoplastic part and with hepatocytic origin. When you have sat to report cases, have you ever been in similar situation where you get a case and you don't know which direction to go to? I've been a lot of time. So these are the various presentation of hepatocellular nodules. And where will be your direction? So we need to create a roadmap to reach our destination. Whenever you embark on a new journey or any journey, there are three important questions to be answered. What, how, and why? What? We are talking about the hepatocellular nodules and its specific entities. How? We are going to talk about the different roads that we are going to take at the moment. And why we need to embark on this journey is to reach a definite diagnosis for the proper management and treatment of the patient. So these are the three important what, how, and why, and the most important being the why. International Working Party in 1995 published a special article in which it classified hepatocellular nodules into two types: regenerative lesions and dysplastic lesions. Over the years, focal nodular hyperplasia has now been classified by WHO as a neoplastic benign lesion. Vyas M. et al. Published a review article in 2018, in which the authors classified various hepatic mass with nodular configuration definitely into 4 different types according to their origin. The hepatic origin, biliary origin, mesenchymal, and the metastatic. The hepatic origin, it is very important to understand what kind of background it has come in, whether it is a cirrhotic or it is a non-cirrhotic nodule. And then the various origin which we will not discuss today, and we'll focus only in these two areas. Now, in the non-cirrhotic livers, the authors have mentioned that HCC-NOS, fibrolamellar SSC, the benign hepatocellular lesions and hepatoblastomas fall under this category. And in the cirrhotic background, the macro-regenerative nodules, the dysplastic nodules, and the early SCCs fall under this category. So let's walk through the roadmap. Let's walk together, and I'll try to make it as simple as it can. Now, the diagnosis of liver nodules rests on proper clinical-pathological correlation. This is not only for liver, this is done in each and every organs that we report. The basis for histological interpretation requires a full clinical history, a proper radiological workup, and the tissue that we receive. Now, in liver, there are 2 types of tissue that we can receive. It can be a biopsy, or it can be a surgically resected specimen. Now, if we receive a biopsy, it is very challenging. And in these type of biopsies, we need definitely to have an adequate sample from the lesion that has been clinically and radiologically identified as a liver nodule, but we also need a separate sample of non-lesional tissue to assess the status of background liver. Why we need to do this is extra-lesional biopsy that we can receive to correlate whether the clinically and radiologically identified hepatic nodule, whether the lesion, the sample is from the lesion. If we compare the lesional tissue with the extra-lesional tissue, and if we don't find any lesion, then it is considered as inadequate. But if we see a nodule in the lesional tissue, then we consider it as adequate. Now, keeping it simple, hepatocellular nodules can be neoplastic, can be regenerative, as the working party has classified them. We are not going to deal with this. We know that liver is a huge organ with enormous functions, and there are various etiological agents that can injure liver. But we also know that liver has an amazing regenerative capacity. So any insult happening in the liver, it regenerates. And when it regenerates to a larger amount, it produces a nodule. These nodules have liver plates with 1 to 2 cell thickness. Otherwise, these are the normal hepatocytes forming the nodules. So let's keep that in mind. Let's come to the neoplastic nodules. It can be benign, dysplastic nodule, and the malignant nodule. In the benign, we have hepatocellular adenoma and focal nodular hyperplasia. Dysplastic nodule can be of high grade and low grade, and malignant hepatocellular carcinoma and its variants. Sorry, with the same slide. All right. So these 2 lesions usually occur in a non-cirrhotic liver background, and some case of SCC also come under non-cirrhotic background, but the dysplastic nodule and other variants of SCC come with a cirrhotic liver background. These are hypothetical scenarios, case scenarios that I'm giving out. A 38-year-old female underwent ultrasonography for some other reason. A liver mass was recognized, which was well marginated and hyperechoic. MRI showed a hyperintense central scar, a central scar on T2 weighted images. The patient was asymptomatic and is nulliparous. The history is negative for oral contraceptives, drugs, alcohol, and has negative serological markers. When the gross was received, all the pictures are from book. We see lobulated mass of about 12 centimeter with a central scar. And this scar is going into the parenchyma, forming a fibrous capsule around these various nodules. And under microscopy, you see these scars, radiating scars, and this fibrous tissue contains variably sized aberrant blood vessels. Now, what do you think? And there is a normal liver background. What do you think can it be? The patient was 38 years old. The patient had negative history for oral contraceptive and various other things. And under radiological evaluation, it has central scar, and so in gross and microscopy. So what can it be? So we are not dealing with this, so we can forget about that, but it should be there in the differential diagnosis. Well, it is FNH, focal nodular hyperplasia. It is a benign hyperplastic regenerative process, a polyclonal nodule, secondary to a local abnormality of blood flow due to vascular malformation or obliteration or arterialization. WHO classifies FNH as a benign hepatocellular tumor, even though it is said that it is a benign hyperregenerative process with polyclonal nodule. WHO classifies it as benign hepatocellular lesion. So it is the second most frequent liver nodule after hemangioma. It occurs in young women, about 80 to 90% in the third and fourth decade, and it is rare in men and children. It can come as both solitary and multiple nodules. These are mostly asymptomatic and hence the incidental finding. Larger ones definitely go symptomatic, and in 90% of the cases, radiological diagnosis can be given with the help of contrast-enhanced ultrasonography. And there is no evidence of relation with oral contraception. This is the revision of the same picture. Just wanted to highlight the central scar with radiating fibrous tissue into the parenchyma, forming vague nodular patterns. This is the similar picture, microscopic picture, where you can see these fibrous scars containing the nodules formed by benign-looking hepatocytes arranged in plates no more than 2 cell thick, separated by fibrous septa that radiate from a central scar, and it contains dystrophic vessels with eccentrically thickened wall and narrowed, often thrombosed lumina. Now here what we see is ductular reaction and some inflammatory reaction at the interface of the fibrous scar with the nodule. And this is highlighted by CK7. Another important thing to diagnose FNH is by glutathione synthase staining, where it gives a map-like pattern where it stains only the hepatocytes around the central vein, but the other areas are left unstained, giving a map-like appearance. So that was FNH. We are moving towards another case, which is of a 24-year female who presented with abdominal pain and mass in the right upper quadrant. Ultrasound definitely showed a liver mass, and MRI showed a hyper signal on T1 weighted images. The patient gives a positive history of taking oral contraceptives for many years, and all the rest history is negative. On the gross examination, there is a 6 centimeter hepatic nodule which appears yellowish and paler than the surrounding normal tissue. Here we can see the normal hepatocytes, and this is a lobulated mass of normal-looking hepatocytes in between these trabeculae and with extensive steatotic change. At the interface of the normal liver parenchyma and the lobule, we have these dilated veins. And there is a normal liver background. So which one of these diagnoses do you think? Any guesses from the back? You have to think about the clinical history provided. The patient had a significant years of taking oral contraception, and the patient is in a childbearing age group, reproductive age group, 24 years. So it is hepatocellular adenoma. It is a benign liver neoplasm composed of cells with hepatocellular differentiation. It is rare tumor that usually develop in women in childbearing age who use oral contraceptives. It is rare in children, men, and the elderly. Other risk factors are diabetes mellitus, obesity, other metabolic and inherited disorders. Now, there are 4 types of hepatocellular adenoma depending on its genotype and phenotype. So the genotype-phenotype classification classifies hepatocellular adenoma as hepatocyte nuclear factor 1 inactivated HCA, beta-catenin activated HCA, inflammatory HCA, and when it doesn't meet with any of the criteria, it is not otherwise specified. The characteristic microscopic picture of HNF1 alpha inactivated is marked steatosis. We will come to this in later slides. For beta-catenin activated HCA, we see some amount of cytologic atypia and pseudoglandular patterns. In the inflammatory, as the name says, inflammatory infiltrates and sinusoidal dilation. And not otherwise specified, it does not have any of these features. So grossly, these are well-demarcated, non-encapsulated tumors with little or no fibrous capsule. What we see at the periphery of the tumor are these large vessels, and often we find areas of hemorrhage and necrosis. Depending on the subtype, the color of the nodule can vary. In the steatotic HCA, it is paler than the surrounding normal liver tissue. In case of inflammatory HCA, it has this marble effect with red area and the paler areas, and the inflammatory combined with beta-catenin activated HCA, these are darker brown colored nodules in comparison to the surrounding liver parenchyma. Now there are 3 important things in the histomorphology of hepatocellular adenoma. Number 1, it is a mass of benign hepatocytes which are arranged in a liver plate having 1 to 2 cells thick. So these are looking absolutely normal, benign. These have, I would like to call it naked arteries. We know that in liver, arteries are accompanied by, can I have the answer? Arteries are accompanied by, can I have answers from the back? A liver, the structural and functional unit of liver is called? What is it called? It's called an acinus, right? It has central vein at one end and it has portal tract at the other end. Right? In between we have the hepatic lobule. And in hepatic lobule, it is composed of hepatocytes with 1 cell thick plate. It has sinusoids and it has other cells. In portal tract, what do we have? It's a triad of portal vein, arteries, and bile duct. So, portal artery, it is always accompanied by bile duct, right? So, in hepatocellular adenoma, we'll get thin-walled arteries that are unaccompanied by bile duct, and there is significant less amount of the connective tissue. Then the other things that we usually see in HCA are sinusoidal dilation, peleosis, infarcts, and hemorrhage. And the liver background is absolutely normal. This is usually helpful in cases of when we receive biopsies and not the surgically resected specimens. So microscopy, this is the HNF1 inactivated, that is the steatotic variant, where we get these steatosis. This is the beta-catenin activated, where we get this pseudoglandular or the acina pattern with cholestasis and minimal cytologic atypia. And the hepatocellular, the inflammatory HCA, we get sinusoidal dilation, congestion, and we get at the interface surrounding the thickened arteries, we get inflammatory cells. It is very important and mandatory to do immunohistochemical study to reach to a diagnosis of particular HCA, to reach to the genotype-phenotype classification of hepatocellular adenoma. The first HNF1 inactivated steatotic variant is liver fatty acid binding protein negative. And we see here the negative staining for that, while the normal liver stains for it. In the beta-catenin activated variant, there is aberrant nuclear and cytoplasmic staining by beta-catenin. And, there is diffuse GS staining. In the third variant, inflammatory HCA, we see this serum amyloid protein diffusely positive and also CRP positive. And in the not otherwise specified variant, only the normal liver fatty acid binding protein is positive, whereas all others are negative. That was about hepatocellular adenoma, the 4 genotype-phenotype classification of hepatocellular adenoma. Now this is the third case scenario. 2 liver nodules of 1 centimeter each were identified in a sonographic study of a 54-year-old male, and he is a known case of hepatitis B with cirrhosis. So we can already have in mind that there will be a cirrhotic background. There's negative history for rest of the things. In gross, what we see are these 2 nodules which appear bulging cut surface and have different color and consistency than of the background liver. Under microscopy, we see cirrhotic background, and we see a nodule here which has alternating light and dark eosinophilic areas, light and the darker areas. In this microscopic view, these are the cirrhotic nodules entirely surrounded by the fibrous capsule, and we see that the density here has increased. The number of cells has increased here, and what we see here are the thickened plates and some amount of large cell changes, some minimal atypia. Now, what can it be? There were some amount of atypia. It is not regenerative nodule. We did not see any scar with aberrant blood vessels. It is not FNH, right? We did not see any of those features we saw in SCA. So we are moving towards what? With atypia. We are moving towards the dysplastic nodule. Right? Dysplastic nodules are distinctly nodular lesions that differ from the surrounding liver parenchyma with regard to size, color, texture, and it bulges from the surrounding liver uncut surface. It can be detected but not accurately diagnosed at imaging. So these are the precursor lesions. These are 1 to 2 centimeter lesions arising in a cirrhotic background, and these are of 2 types, high grade and low grade. So what we see here is increase in density compared to what we see here. And similarly here we see increased density. It says thin trabecula, but I don't see thin trabecula, but what I see are those minimal atypia, pleomorphism. So we need to differentiate dysplastic nodule at one hand from the regenerative nodules, while on the other side, we need to differentiate it from small, well-differentiated SCC. As we said, that dysplastic nodules are of 1 to 2 centimeters, all right? And small, well-differentiated hepatocellular carcinomas are SCCs who are 2 or less centimeter in diameter. So these are smaller in size. And these are of 2 types, early HCC and progressed HCC. Early HCC, these are vaguely nodular, and these are also known as vaguely nodular type or with indistinct margin. While the progressed HCC are distinct type, they are the nodular type. However, they behave differently. Even though this is distinct and this is vaguely nodular, this is more notorious for extensive infiltration, invasion to the adjacent parenchyma. This is the gross picture, and we can hardly make out where is the nodule, and this is a small, early, well-differentiated SCC, unencapsulated and vaguely nodular with indistinct margin. While on the other side, we see distinct margin, distinct nodular pattern, whereas the behavior is exactly the different as it appears. Microscopy, These have well-differentiated histology and small neoplastic cells with high NC ratio, and these are range from well-differentiated to moderately differentiated with high propensity to extensive infiltration towards the adjacent parenchyma. There is a term called dysplastic foci. This is something, it's a cluster of hepatocytes which is less than 1 millimeter in size, and these are composed of dysplastic hepatocytes. And according to the morphology that they depict, these are of small cell chains and large cell chains. These are the small cell chains and large cell chains that we see in any dysplastic lesions. The only difference between small and large cell chains morphologically is that these are smaller size and these have high NC ratio, whereas here the cells are large, but the NC ratio is maintained. The differential diagnosis of low-grade dysplastic nodule can be regenerative nodule at one end, and towards the other end, it can sometimes, when it is especially a biopsy, at the other end, it can be a high-grade dysplastic nodule and the early HCC. The difference between high-grade dysplastic nodule and well-differentiated SCC, particularly the early type, is the small type. There is only one thing that can differentiate it, is the stromal invasion. So we need to look for stromal invasion. We have been hearing in the morning from Dr. Divya, who repeatedly kept on telling us to find the area of invasion. Otherwise, don't call it towards the other spectrum, which is called carcinoma. Or in situ in the bladder case here, it is the carcinoma. So there are three important markers which will help us identify or differentiate these different lesions, and these are glypican 3, GP3, heat shock protein 70, and glutamine synthase. And when all the three of these markers are negative, it does not support the diagnosis of carcinoma. It is suggestive of high-grade dysplastic lesion. If only one marker is positive, it suggests towards the well-differentiated SCC, but however, high-grade dysplastic lesions cannot be ruled out. But when it is positive for 2 and more markers, it is highly suggestive of carcinoma, and it does not support diagnosis of the dysplastic lesions. So it is important to have these three markers in hand. Now, we move towards another case, which is an elderly male of 65 years with known case of hepatitis B infection with cirrhosis, and has now presented with abdominal mass, pain, discomfort, and a significant history of weight loss, anorexia, malaise, and on examination there is hepatomegaly. On the gross examination, what we see are these vague nodular pattern with satellite nodules, and here what we see are the steatotic chains with etipia in the hepatocytes, a pseudoglandular pattern with cholestasis. And there is a cirrhotic background. Now we all can guess what it is. What can it be? What can it be? Yes, thank you. So, this is a hepatocellular carcinoma. It is the most common primary malignant tumor of liver in adult. There are various subtypes of hepatocellular carcinoma. I'd like to focus on one particular variant, which is called fibrolamellar carcinoma. It happens in a young patient of 25 years. It is under the microscopy, what we see are those large eosinophilic tumor cells with prominent eosinophilic nucleoli. And as the name says, fibrolamellar, the stroma shows fibrolamellar fibrosis. We know that there are various etiological agents for hepatocellular carcinoma, but cirrhosis is one important etiological factor, and that forms the basis of looking into the liver background, whether it is cirrhotic or non-cirrhotic in these lesions. So SCC, we know it is a primary disease of elderly male, and the incidence increases as the age goes higher up. But the incidence also varies according to the geographic regions. male are more affected by the females, and the clinical manifestation we already discussed in the clinical scenario. The tumor can range from less than 1 centimeter to more than 30 centimeter in diameter. There are three important features, gross features of hepatocellular carcinoma. These are the nodular, infiltrative, and diffuse. The nodular type are associated with cirrhosis, and it is the most common type. The nodules can be solitary, it can be multiple. These are well delineated, but can be totally or partially circumscribed by a fibrous capsule. In gross, under microscopy, definitely we'll see the invasion. In the infiltrative type, it infiltrates anywhere, but it is common in non-cirrhotic liver, and we can usually find the venous invasion. And diffuse pattern is we find these nodules everywhere diffusely infiltrating in the parenchyma. So the histopathological diagnosis of hepatocellular carcinoma is a multi-step process. First, we need to ascertain the hepatocellular origin, then the malignant feature, and then we'll have to look for the grading for the prognostic significance. So it shows the hepatocytic differentiation. It shows loss of normal hepatocyte architecture. Now, what do we mean by loss of normal hepatocyte architecture? We discussed earlier, right?
1 minute, ma'am.
There is a hepatic globule which is composed of hepatocytes with 1 cell thickness. Here, that is lost. The reticulin framework is lost. We have we don't even see the plates. They are everywhere. And there is loss of normal portal tract. All right? And we see a pseudoglandular pattern, trabecular pattern, solid, and macrotrabecular pattern. These are the four principal histological growth factors. Immunohistochemical markers, AFP has only 30% sensitivity, so we go for HEPAR1, arginase 1, and polyclonal CEA in the canalicular pattern. And to differentiate hepatocellular from the non-hepatocellular, there are certain markers and there are certain tumors that we need to identify them. Due to lack of time, I'm skipping this. Now, take-home message, neoplastic liver nodules, it is an orchestral work of pathologists, clinicians, and the radiologists, but where do you think we stand here? Where do you think we stand here? I put pathologist here in the diagnosis of hepatocellular nodules. And this, I'll take 1 more minute. This is a chart that I've taken from the article that I recently talked about, but I got lazy to make it on my own, so this is what I've done. We have to look at now we talked about what are the different types of hepatocellular nodules we find, regenerative, neoplastic, and the different types of neoplastic. Now let's look at the background of the liver. So if the background liver is cirrhotic, we need to look for the hepatocytic origin. If it is there, we need to look for the cytological and the architectural atypia. If it is absent, go for regenerative nodules. If the cytological architectural atypia is there, we look for further cytological atypia. If it is absent, low-grade DN. If it is present, we need to look for stromal invasion and other morphological features that we just talked about. Now, if again there is absence of stromal invasion and there is some amount of atypia, it will be high-grade DN. If the stromal invasion is there, then we will look for the size. If it is 2 centimeter and less, these are the early small SCC, which are of early and not early or progressive SCC. If the size is more than 2 centimeter, then these are the conventional HCC and other variants of HCC. If it is a non-cirrhotic background, we'll again look for the hepatocytic origin. If it is there, we'll look for the atypia. If atypia is absent and there is a central scar radiating, it is FNH. If there is no central scar radiating, then it is hepatocellular adenoma, and we will diagnose hepatocellular adenoma with the important immunohistochemical markers that we recently discussed. And in the if there is the atypia present, we will look for the invasion, and these are the HCC and the various variants of HCC. This is hospital, University Hospital in Geneva, where I was trained for liver pathology, and where I got to see many cases, even though my hospital, BP Corella Institute of Health Sciences, we are not cancer-based, but we do receive some specimens.
Thank you, ma'am.
And this is where I am from. Thank you very much.
I would like to call the next speaker, Dr. Rekha Manandar from NPH.
अगाडि Thank you, Eva ma'am. Good morning, respected chair, co-chair, and all the delegates present here. After such an extensive presentation in the morning session, I will be presenting in short related to the immunophenotyping pattern of pediatric acute leukemia at National Public Health Laboratory. So in our study, the pediatric age group that we have included were from neonates up to the 14 years with a duration of 15 months, and we do have that total cases of 66 in number, and where we have received the samples that have been kept in a EDTA and a heparin anticoagulated whole blood or the bone marrow. And after the receival of those samples, we have gone through the acute leukemia panel using the CD45 site scatter that version as such for diagnosing those leukemias. After those patterns, what we have received is 53 cases of acute lymphoblastic leukemia and 13 cases of acute myeloid leukemia. And even among those acute lymphoblastic leukemia, we do have that 49 cases of BALL and 4 cases of TALL. And among the acute myeloid leukemia, the majority of the cases were within the acute myeloid leukemia without maturation, which accounts for 7 in number, and the least number, that is only a single case of acute promyelocytic leukemia. Whereas acute myeloid leukemia with maturation and with monocytic differentiation, which accounts for 2 and 3 in number, respectively. And within that study, if we have to correlate with that of age, in the age group of 1 to 4 years, the maximum number, that is 26 cases of BLL that we have found. And in an age group of less than 1 year, only the 4 cases of BLL that they were found. But in totality, if we have to talk about the entire acute leukemia, within the age group of 1 to 10 years, almost more than 80% of those cases that do fall within that one, and which is within the very much a favorable prognostic group as such. But if the children which they have been diagnosed in infancy, then they will definitely have a worse outcomes. But in another study, what they have been found is even the children that they have been studied within the age group of 1 to 10 years, that they have been diagnosed even during the age of 1 to 4 years, they have even the best outcome. But if we have to talk about the another study related to the AML, what it has been shown that not even the infants, even the children that they have within the 1 to 4 years, that they indicate a poor survival rate. But in case of TLL, what studies have shown that it is not much affected by the age group. So in the studies, the causes related to the poor prognosis of acute leukemia, mainly in infants. It's partially maybe due to the poor immune system, more advanced stage, or the chromosomal abnormality, mainly the MML genes, which really affect mainly in the age group of less than 3 months. But if have to talk about the poor prognosis in certain age group, that is mainly due to the chromosome rearrangement, the TL AML1 gene rearrangement, where during the leukomogenesis, that during the fetal hematopoiesis, it mainly affect. And another cause, it's related to the DNA hypodiploidy and the BCR-ABL gene rearrangement. And if you have to talk about the gender which we have received in our center, that the acute leukemia, it was more prevalent in the male, which accounts for almost 70%, which is in unfavorable prognostic group. And but if it have been occurred within the female group, it is a favorable prognosis. But still, the cause of those things, what it has been found that it's mainly due to the pharmacogenetics, which may also affect the pharmacokinetics therapy in male and female children. And talking about the aberrant expression, within the case which we have studied, in B, ALL, and TALL, mainly the myeloid and the T cell antigen that they have been expressed, but in case of BLL and acute myeloid leukemia, what we have seen is even the double aberrant expression that they have been seen. So if we have to see the entire cases, the distribution of aberrant immunophenotype was almost around 20% of the total cases, that is 13 in number. So in BLL, out of 49 cases, in 8 cases, the aberrant phenotype has been seen, and in TLL, out of 4 cases, in 2 cases, aberrant phenotype has been seen, though it's been likely to have a few in numbers, but if we have to see in total number, it's almost more than 50%. But in case of in AML, that is mainly only on without maturation variant, out of 13 cases, in 3 cases, the aberrant phenotype, it has been seen. But if we have to correlate with that of adult, it's actually the studies what we have done, it doesn't match with that one, because in BLL, in a study, what it has been seen that the aberrant phenotype was commonly seen in adult than childhood, and in AML, the aberrant phenotype was more common in children than adult, and it is mainly seen in the monocytic variant. And if you have to correlate those findings with that of CD34, with that of aberrant expression, in 2 different studies, what we have seen that in one study, that means those in AML cases, the CD34 positivity is more likely to express that lymphoid markers, which is very much true in regards to that of our studies. But in case of another study, what it has been seen that even in the absence of these markers, in case of this ALL, that it is not associated with the those aberrant markers, but which is contrast to that of our studies. And related to the those aberrant myeloid marker expression in B and T cell leukemia, what it has been shown that it portend a poor prognosis compared to those ALL cases without the myeloid antigen, and same likewise that is aberrant T cell marker in AML. It also shows that it's indicative of a poor prognosis. Even in our study, what we have seen is CD7 and 56, that is the dual antigen expression. It really moves toward a poor prognosis. But still, if the leukemia with only single antigen expression, that is a good one, better than that of dual aberrant expression. And another case that, the one which we have seen even in our cases, that aberrant T-cell marker expression in B-cell leukemia and vice versa. Even as said earlier, even these also lead to a poor prognosis, but it also have adverse cytogenetic abnormalities as well. So as we have been talking that there is a T-cell antigen expression, aberrant expression is definitely there, but in some studies what it has been said that CD7 consideration as an aberrant marker has been the subject of controversy, because CD7 what it has been seen is can be expressed even in some early myeloblast. And till that, in the previous slide, what we have been seeing that the aberrant expression in the acute leukemia, entire acute leukemia, it leads to a bad prognosis. But from the study that has been done in a high-income country, it has shown that there is no significant differences in such prognosis. So the association with those prognostic factors is still a matter of debate. But same sorts of studies that have been done in a low and medium-income countries that reveal that the prognosis is different between those myeloid positive and negative ALAs. So definitely further studies that they have that definitely required in relation to that of MRDs, molecular abnormalities and cytogenetics, because as said earlier, the aberrant expression positivity that indicate a poor prognosis in those acute leukemic patients, that not only that it holds a poor prognosis, but it also is associated with a high molecular and cytogenetic abnormalities as such. So I'm coming almost at the end. It's my last slide. And even the aberrant marker, if we have seen in case of acute leukemia, that will definitely adversely affect the survival in the cases of acute leukemia if it is associated with the unfavorable cytogenetics. So that's why at last what I want to say that in our context also, we also have to have a molecular and cytogenetic setup so that we can have such integrated reporting system in our context. Thank you. Thank you, all the listeners back over here and the entire team of NPHL, especially our Dr. Sadisha, who have even collected all those those cases as such. Thank you, everyone.
Thank you, Dr. Rekha. Because of lack of time, we won't be having question and answer session today for this session. Thank you.
Thank you all the speakers for this enlightening presentation. I'd like to request our chairperson to provide certificate of appreciation to our speakers. Dr. Ranjan Bhatta. We'd like to request our chairperson to be on the stage for providing certificate of appreciation to our speakers. Dr. Ranjan Raj Bhatta. Dr. Ari for Dr. Ari Dakar. Okay, we'll take it. Dr. Rekha. Okay, Dr. Ari is not here, so we'll like to request Dr. Anju for. We'd like to request Dr. Anju for certificate of appreciation. Dr. Anju is not here. So I'd like to request Dr. Rekha for certificate of appreciation. With this, I would like to request Professor Dr. Geeta Saimi to provide token of love for our chairpersons. I'd like to request Dr. Eva P.F. for token of love. Dr. Smriti Karki for token of love. With this, we are ending our first chair session, and now we are taking 5 minutes break, which will be followed by panel discussion by our panelists. Thank you.
With 240 tests per hour for biochemistry and 200 tests per hour for electrolyte testing. The sample and reagent area are combined in a single disc. It contains up to 90 sample and 90 reagent positions. Both polytype primary tubes and micro-container cups are compatible. The sample and reagent disc provides constant cooling at 2 to 10 degrees centigrade. Continuous loading function for sample and reagent is also available during measurement. The detachable design is convenient for sample and reagent storage. The sample and reagent needle coated with Teflon is washed automatically after each pipetting to avoid cross-contamination. Other functions including liquid level detection, clot detection, and crush-proof are also available. 1,400 rounds per minute high-speed mixer coated with Teflon is used to fully mix sample and reagent and is washed with preheated water before and after mixing. Totally 80 reusable optical plastic reaction cuvettes are used for reaction and measurement. Minimum reaction volume can be lowered to 100 microliters, which is cost-effective for customers. BioSage 240 Plus adopts post-spectroscopic optical system and a long-life halogen lamp, which greatly improves the detection accuracy in reducing consumable cost. 16 wavelengths ranging from 340 nanometers to 800 nanometers meet the needs of different assay configurations. 80 reaction cuvettes can be automatically cleaned by a station with 4-step washing procedure. The maximum water consumption of BioSage 240 Plus is ranging from 2 to 3 liters per hour, which greatly minimizes water usage. One BioSage reagent kit includes 30 milliliters R1 and 10 milliliters R2. Smart Design Reagent Kit makes the benefits of loading R1 and R2 at one time. Each reagent kit has a unique barcode. Barcode recognition function is available for both sample and reagent. A simple and user-friendly software provides excellent user experience. STAT mode and automatic dilution function are supported. The needle and cuvette can be washed by acid-based cleaning solution thought, self-defined settings in software, avoiding cross-contamination to the most extent. The real-time status for reagents and each single test can be monitored on the software. It is highly compatible with major LIS systems and provides bidirectional interface transmission. With multiple kinds of biochemistry assays, BioSage 240 Plus Analyzer can provide comprehensive solutions to satisfy various requirements of small and medium-sized hospitals and laboratories. BioSage 240 Plus, one of the fastest and efficiently small-sized Snipe, a leading company in chemiluminescence immunoassay field, has a full biochemistry product line as well. BioSage 240 Plus, the latest Snipe biochemistry analyzer with compact design and high efficiency, is a reliable member worth choosing in clinical labs. BioSage 240 Plus is one of the fastest small-size analyzer with 240 tests per hour for biochemistry and 200 tests per hour for electrolyte testing. The sample and reagent area are combined in a single disk. It contains up to 90 sample and 90 reagent positions. Both polytype primary tubes and micro-container cups are compatible. The sample and reagent disk provides constant cooling at 2 to 10 degrees centigrade. Continuous loading function for sample and reagent is also available during measurement. The detachable design is convenient for sample and reagent storage. The sample and reagent needle coated with Teflon is washed automatically after each pipetting to avoid cross-contamination. Other functions, including liquid level detection, clot detection, and crush-proof are also available. 1,400 round per minute high-speed mixer coated with Teflon is used to fully mix sample and reagent. and is washed with preheated water before and after mixing. Totally 80 reusable optical plastic reaction cuvettes are used for reaction and measurement. Minimum reaction volume can be lowered to 100 microliters, which is cost-effective for customers. BioSafe 240 Plus adopts post-spectroscopic optical system and a long-life halogen lamp, which greatly improves the detection accuracy in reducing consumable cost. 16 wave lamps ranging from 340 nanometers to 800 nanometers meet the needs of different assay configurations. 80 reaction cuvettes can be automatically cleaned by a station with 4-step washing procedure. The maximum water consumption of BioSafe 240 Plus is ranging from 2 to 3 liters per hour, which greatly minimizes water usage. One BioSafe reagent kit includes 30 milliliters R1 and 10 milliliters R2. Smart Design Reagent Kit makes the benefits of loading R1 and R2 at one time. Each reagent kit has a unique barcode. Barcode recognition function is available for both sample and reagent. A simple and user-friendly software provides excellent user experience. STAT mode and automatic dilution function are supported. The needle and cuvette can be washed by acid-based cleaning. Snipe, a leading company. SNIPE, a leading company in chemiluminescence immunoassay field, has a full biochemistry product line as well. BioSage 240 Plus, the latest SNIPE biochemistry analyzer with compact design and high efficiency, is a reliable member worth choosing in clinical labs. BioSage 240 Plus is one of the fastest small-size analyzer with 240 tests per hour for biochemistry and 200 tests per hour for electrolyte testing. The sample and reagent area are combined in a single disk. It contains up to 90 sample and 90 reagent positions. Both polytype primary tubes and micro-container cups are compatible. The sample and reagent disk provides constant cooling at 2 to 10 degrees centigrade. Continuous loading function for sample and reagent is also available during measurement. The detachable design is convenient for sample and reagent storage. The sample and reagent needle coated with Teflon is washed automatically after each pipetting to avoid cross-contamination. Other functions including liquid level detection, clot detection, and crush-proof are also available. 1,400 round per minute high-speed mixer coated with Teflon is used to fully mix sample and reagent and is washed with preheated water before and after mixing. Totally 80 reusable optical plastic reaction cuvettes are used for reaction and measurement. Minimum reaction volume can be lowered to 100 microliters, which is cost-effective for customers. BioSage 240 Plus adopts post-spectroscopic optical system and a long-life halogen lamp. Snipe, a leading company in chemiluminescence immunoassay field, has a full biochemistry product line as well.
Dear delegates, may I have your attention please? We are moving towards panel discussion session, and we have renowned panelists composed of clinician, radiologist and pathologist. We have with us Dr. Anurag Mehta, Dr. Narayan Bikram Thapa, Dr. Arun Shahi, Dr. Saugat Paudel and Dr. Banita Gurung. We request you all to please join us on dais. Please give big round of applause. This session will be moderated by two of the moderators, Dr. Diksha Karki and Dr. Girisma Shrestha. Can we have big round of applause for them as well? Thank you.
Start go.
Good afternoon, everyone. Respected panelists and all our seniors and friends. This session will be conducting a panel discussion on the lung carcinoma, and we have a very esteemed panelist in this session. And we will be discussing basically a two case, and we will be focusing on the most frequently asked question, and which we face in day-to-day of our practice during the time of reporting, with a complete collaboration of pathological feature, the clinical feature, radiological finding, and as well as a point of view from the medical oncologist. So we would like to start our first case.
First off, we want to thank the patients who allowed us to use their case for this panel discussion. So we do not have any disclosures. First case is a 59-year female who presented with complaints of dry cough, fever, and shortness of breath. Initially, she was treated with antibiotics for suspected pneumonia. There's no significant family history and no other significant medical or surgical history. Now, the chest X-ray showed a hilar mass. Now we'll jump on to the radiological findings directly. Over here at this point, I request Dr. Narayan sir to say something about this lesion here.
Okay, thank you very much. I can see some section of the chest CT. There's a mediastinal window and the long window is there. and the contrast CT is there. In the long window, we can see a relatively ill-defined heterogeneous type of the mass lesion in the left. I think it's in the lower apical segment, superior basal segment of lower lobe, with some speculated few margins are there, and multiple small nodular lesions are also seen in the long parenchyma. And in the contrast, we can see the lesion doesn't show so much contrast enhancement. It's a minimal enhancement, I think, with a heterogeneous type of enhancement. With these findings, should I say the diagnosis also? Our differential diagnosis?
Yes, of course.
Differential diagnosis, I think it's more of like infective type of lesions, but the carcinoma should be ruled out in these lesions also. So as we said, we think we need some histopathological finding correlation also, but malignancy should be ruled out in these lesions.
Okay, thank you, sir. I think the reporting pathologist also agrees with you. There was a well-defined heterogeneous enhancing soft tissue density lesion. And features, basically the features were suggestive of extensive lymphatic metastasis and multiple lung metastasis. So MRI brain was clear and is not shown. So at this point, would you recommend any other radiological tests?
Yeah, we do all the workup for this metastasis in the other organs, like as you said, in the brain and bone and other also. So we have to do, we can do the PET CT also. And nowadays we can do the whole body diffusion weighted MR also, we can do.
Okay. Yes, so because considering our scenario where not all patients can afford a PET CT, so when do you think it is really, we cannot do without a PET CT? And would this patient benefit? And also I have to mention, at this point the patient did not have any abdominal mets. I've not shown it, but patient did not have any abdominal mets. And okay, so you're saying that PET CT would be helpful for our case. Okay, so PET CT was also done. So would you like to say anything about this?
So in the PET CT, I think it's almost, this optic is there all over, and it's almost, it's all metastasis there in the other lobe also, and in the, I think, bone, I've not seen in the bone, but it's totally, for staging, I think it's already the meds are there.
Yes. Okay, so the reporting pathologist again agrees. Metabolically active speculated soft tissue mass lesion along with lung, multiple lung nodules, lymphadenopathy, and pleural effusion. So going back to this image and this image, how do you think would be the best, what do you think would be the best approach for a biopsy material? Naren, sir.
I think it's we can do the biopsy, CT-guided biopsies easily we can perform, because there is a space there between the ribs over there, and CT-guided biopsy directly from the mass we can do. Okay.
So do you think we should also do biopsy from the secondary lesions that are there?
It's, it seems that if that mass is clear-cut carcinoma, these are the, radiologically, these are the meds. But if you think, if the surgeon wants to do the staging and if they have some doubt about the metastasis, they can do from the meds also, that other lesions also.
Now, next question is just out of curiosity. When you're obtaining a biopsy material, how do you assess adequacy? To Naren, sir.
For that, I think we see the tissues is there or not. That's the thing.
Okay. Yeah, we can, as a pathologist, we can help here, the interventional radiologist.
Yeah, my next question is directed at Dr. Vanita. Yeah.
Okay, thank you. So whenever we do the intervention, we can help by doing a rapid stain, which is called the rose. So what we usually do is during the procedure, when the radiologist, interventional radiologist take out the specimen, we can do imprint and blue the cells and then instantly see under the microscope for the adequacy of the cells and be sure that the tumor cells are there for further evaluation. Or if you are not taking out the biopsy, if you are taking out the smears, like for FNAC, then also we can do the same thing. And I think we have been practicing this, and I think this has increased our accuracy rate, and we could give more information afterwards.
I believe Dr. Banita has also published one article from
not
Nepal
really,
Cancer.
not
Okay.
really.
Okay. So, Anurag sir, so what's your experience on this?
So I think this is very helpful to make imprint smear, as you said, rapid on-site evaluation. So that way you can limit the number of slides that you will take for examination under the microscope, and the rest of the material can go for biomarker testing. So that way you can actually, from cytological material, complete the pathological work, both for diagnosis as well as for biomarker testing. So that way you can actually economize. Otherwise you make 20 or 30 slides and then you stain them all. So you have wasted a lot of material. So you stop when you see the malignant cell, and the rest of the material goes into the tube preservative, which you can then use for biomarker testing. Only thing is that in this particular case, one could have used pleural effusion also as a specimen for diagnosis and also the biomarker testing. Cell blocks are very good.
Yeah, and we can save the time, and we don't need to call the patient again and again saying that the sample was not adequate. We can save a lot of time.
So, on to the histopathology. Yeah, so this was a true cut biopsy. Any opinion on this, Dr. Banita?
Yeah, I can see two pictures here which is zoomed in, and we can obviously see the tumor cells here. But I really cannot very frankly appreciate any glandular structures or any particular structures. The cells are really scattered, and in the second photo I think there are some clusters and nests of cells, but they look malignant.
Okay. So, yeah, so, so what's the recommended pattern of reporting given the histomorphology? Like, should we be brave and call it adenocarcinoma directly or squamous cell carcinoma directly at this point?
See, we have to work in a team. So just looking at the slide, we cannot just abruptly say that this is, yes, primarily from lungs, or is it from somewhere else, because since the beginning, even the radiologists have been saying that this might be metastatic lesion. So I think we exactly cannot say that this is, yes, from a lung primary, or this is metastatic. But we can at least say that these are the poorly differentiated tumors, and they look like carcinoma. Yes, we can say that. But that carcinoma might be different types of carcinomas. So here I think we can at least say poorly differentiated carcinoma, but looking at the clinical scenario and other tumor markers and correlating with the team and looking at the patient, maybe we can say, okay, this is non-small cell carcinoma.
Okay. Yes, sir. So you have something to contribute?
So I think pathologists get very easily intimidated. The onus of telling whether this could be metastatic lies with the physician. Yes. If the physician has not said it is metastatic, you don't have to work it up for metastasis. In a small biopsy, there are 5 categories of reporting. There is no 6th category. The first category is NSCC, and WHO has made it NSCC from NSCLC. So, non-small cell carcinoma, irrespective whether it has come from somewhere or it is primary of the lung. And if you see glands, acini, a residual lapidic pattern, then you say NSCC hyphen adenocarcinoma. Level of evidence, morphology. If it is showing good keratin pearls and good intercellular junctions, you say NSCC hyphen squamous carcinoma. If you have solid growth patterns like in this particular case, then you should do IHC. If it is P40 positive, then you say NSCC favor squamous carcinoma. If you say CTTF, you say NSCC hyphen favor adenocarcinoma. If you get none, or if it is an ambiguous, you get both, you get overlapping both, you don't say adenosquamous carcinoma, you say NSCC NOS, and put a note, level of evidence, IHC, dot, IHC is ambiguous, adenosquamous carcinoma cannot be ruled out. These are the 5 categories under which you shall report small biopsies of lung. And till such time the physician says that this could be metastasis, you are not supposed to work for metastasis and conserve the tissue for biomarker testing.
Okay. Yes, so this case was given out as non-small cell carcinoma with a recommendation for immunohistochemistry for categorization. Now, what is the recommended basic panel for IHC panel, IHC, at this point? Like you have to keep in mind that we are in a resource limited setting.
So my basic panel will always be, if I see mucin-laden cells, I will do a mucicarmine, use one slide. Okay. And if 5 mucin-laden cells are positive for mucicarmine, I stop there. I use one slide.
Okay.
Otherwise, I use 2 slides, one P40 and TTF. But I am telling you only when the pattern of growth is solid pattern. If I have recognized definitive markers, definitive patterns, glandular pattern, acinar pattern, papillary pattern, micropapillary pattern, I won't do IHC. Same way, for squamous carcinoma, of course, remember your threshold should be high. You should definitely see good pearls or good intercellular junctions. Large pink cells, polyhedral cells, does not make a squamous carcinoma. Those could be pseudo-squamous carcinoma. And if you do IHC, they may turn out to be adenocarcinomas. So only 2, TTF and P40 and mucicarmine. Basically, the whole concept is to economize on the use of tissue. Before biomarker testing begins.
Okay, now
I totally agree with you, sir.
So you've already addressed our second question. So because you just said tissue, we have to save the tissue. Tissue is the issue. So tissue saving strategies, what do you think are those?
In our scenario, we can, whenever we get these small biopsies, we can actually allot them in different cassettes. Like, don't put everything in only one cassette. Because when we evaluate in different cassettes, then we can use these, each cassettes for different markers, so that we don't deplete all of them all at once. So this is one of the very easy way that we can work.
So I completely agree with what she said, that we shall make separate block for each core. Here the cost should not be the consideration. The consideration should be economizing on the use of tissue rather than economizing on cost. So if you have 4 cores, 4 blocks. And the second thing is, don't cut ribbons. Your lab technicians will cut ribbons and he puts them in a semi-arch and you feel so happy, my lab technician has done that. But he has put 10 sections there, 9 of which are useless. And with those 9, you could have done all the biomarker testing. And third thing is that don't stain your cores with eosin so that they can be seen in the paraffin block. Because when you stain them with eosin, you actually are introducing a PCR inhibitor. And this PCR inhibitor will prevent RT-PCR as well as next generation sequencing when you test. So these are the 3 recommendations that I make for tissue block. Apart from the fixation should not be for more than not less than 6 hours, not more than 72 hours.
And we can even use the cell blocks for these, and any body fluid can be turned into cell blocks, so we can use that also. And one more scenario, when we get tissue blocks from like outside, the tissue has already been, slide has already been made, and few sections have already gone. So when these kind of blocks come to us, we request our technicians to do minimum sections, or we rather prefer to see that slide so as to save our tissue.
So you're suggesting that whenever a patient wants to take the block for review, for lung, I'm saying it for lung.
Yeah.
So it's recommended that you also send a slide so that they don't have to trim and take another section.
Yeah, we can do that, and we can always return that slide for archive for that particular hospital.
So I think this issue has already been addressed. So are there any points to consider during grossing? You've already said, like putting tissues in different blocks and preventing, avoiding eusin. Yeah, so in our case, the tumor cells were positive for BRP4, napsin, TTF1, and P40. So, sir, so your opinion on this?
So TTF1 is focally positive, napsin is also focal?
Yeah.
Okay. And even P40 is focally positive with BERP for diffuse. So these are the adenocarcinoma markers which are very specific for lungs. But one tricky thing that I see here is that P40 is also positive. So we, as Anurag sir said, that we usually start from 2 markers, TTF1 and P40, but when these two come together, so we have to be a little bit careful. Because even adenocarcinoma in few percentage can get P40 positive.
Yeah, sir.
So I will probably report it as NOS.
NOS.
And why I will report it as NOS? Because NOS also mature for biomarker testing. Generally, if you have TTF positive and focal P40, TTF will trump P40. You will call it adenocarcinoma or favor adenocarcinoma. But if you have both of them, wishy-washy kind, you really don't know. You have 6 cells, 8 cells with TTF. You have 10 cells with P40. And you are really not sure whether this is strong enough for you to report either way. Then I will call it NOS. And it doesn't make any difference to the patient because the biomarker testing will still be done.
Okay. So why not adenosquamous?
Because adenosquamous is a resection diagnosis. You are supposed to see 10% of each component on the resection specimen. In a small biopsy, what you are seeing as a squamous component may finally end up being 0.5% of the entire tumor. You just happen to hit it there. So you should not consider it adenosquamous. At the best, you can give a note that adenosquamous carcinoma is a possibility. But don't call it adenosquamous carcinoma on a small biopsy. Call it NOS.
Okay, let's go to another scenario where there is 90% tumors are taking up P40 and only 10% different population is CTF1 positive.
It'll be NOS again.
Okay.
And with the same comment that this is NOS because of ambiguous immunohistochemistry, adenosquamous carcinoma cannot be excluded.
So you're suggesting that we do not diagnose adenosquamous on a core biopsy?
Because a small biopsy, 10%, maybe for a resection just about 0.1%, for all you know.
We need to evaluate the other areas.
Yes.
Because that classification is only for resection specimen.
Okay, thank you. So the final diagnosis in this case was non-small cell carcinoma, favor adenocarcinoma. Now, this I'll direct to Dr. Arun. So in scenarios where patients are unable to afford even basic IHCs, this patient was lucky, I should say. that she was able to undergo IHC testing. So if patient is unable to do it, what would your next step be?
Thank you. First of all, whenever we come across any patient, in oncology, we do the multidisciplinary tumor board. In that, we again invite the radiologist, radiation oncologist, and now pathologist part is already finished. So we three, actually we sit and we decide like whether to send IHC or other thing or not, because we have some aid process as well. Sometimes we can provide in a free as well. So if that is also not possible, that in this case, we already know that this is the stage 4. So in this case, we'll give a palliative chemotherapy.
Okay. That
is a pemetrexed-based chemo, pemetrexed and carboplatin.
Okay.
3 to 4 cycles. Then we do the response evaluation.
Okay. So are there any tests that you would recommend before initiating definitive treatment, if the patient is affording?
So if the patient is affording, and since it is an adenocarcinoma, we will look for the driver mutation and PD-L1 for the immunotherapy. And if the patient is asymptomatic, is fine, then we can also wait for till the results comes. We would not start the chemo immediately. We will wait for the driver mutation reports.
So do all the cases of lung carcinomas need to undergo these batteries of molecular tests?
By NCCN guidelines and all these ACPS, we say like now, even from the stage 2, all the lung cancer, excluding the small cell, all the non-small cell lung cancer should go for the molecular testing. Because now like from the stage 2, we can start the TKI. And then also there are few studies, 3 or 4 studies, which support that if there is PD-L1 expression is higher, we can also start the immunotherapy. So now we say that all the patients should go for the driver mutation.
Even squamous?
Yeah.
Okay. Yeah. So is there any logical sequence? I'm asking this to Anurag sir. So is there any logical sequence, because there are so many molecular tests, which to order first?
So it depends upon the resources available. So in a very resource-rich country, and in those places where the NGS report can come within, let's say, 10 business days, many countries, they do it. And if the patient is not moribund, then go for the NGS.
Directly?
Directly.
Okay.
But if you are resource constrained, then I think we do first lap of testing of EGFR, ELK, which are high frequency alterations, and also ROS1, so you cover 32% of EGFR, 7% of ELK, 3% of ROS. So 40% you have covered. You have left out about 7-8% additional ones, which you can then wait by doing in a second lab the NGS. That is the practice that we have adopted in our hospital. First lab we do EGFR, ELK and ROS, and then in the second lab we do the NGS.
Okay.
So that is one strategy, but the other in countries which are resource rich, where turnaround time, irrespective of the optimization, can be reduced to 8 to 10 days. The best thing is to do NGS upfront.
Okay. So EGFR comes positive, we need not send for?
You need not, yeah, you need not send for any further testing.
So in this case, PD-L1 was done, so TPS score is less than 1%. Would you like to elaborate a bit on this? How is this significant for the patient?
So TPS less than 1% is negative, you know. This patient will not mature for immune checkpoint inhibitor therapy.
So Dr. Arun, would you like to say anything on this?
What I would like to say to everyone that if any patient diagnosed with lung cancer, I would say please send for NGS or ISC. Why? Because there are medicine free available in Patan. So if there is a ELK positive or ROS1 positive, those medicine which we buy in the market is from 80,000 to 8 lakhs. So these medicine are freely available in our hospital. So I would say like for the NGS maybe it is like 15 or 20,000, but we are getting free medicine for all life. So because of that reason, I think we have to send for everyone.
Okay. So what is this TPS? Anurag sir, what is this TPS and what is CPS?
So
please enlighten us.
Tumor proportion score is the number of tumor cells showing positive membranous sustaining, weak or intense, complete or incomplete in relation to the total number of viable cells. The TPS is the one that is used for lung cancers. CPS is the combined positive score in which we take the immune cells as well as the tumor cells and compare that to the viable area. So CPS sometimes can be even more than 100% because immune cells have more, will add to the total numbers. So immune cells plus the area occupied by the tumor cells divided by the area occupied the viable tumor cells. But I think CPS is used in other places, not in lung cancer. Lung cancer, it is the TPS.
Stomach GI, you're saying? Okay. To Dr. Bonita, so what's the current scenario in Nepal regarding, how difficult do you think it is to implement?
I think it's not really difficult, nothing is difficult actually. But the thing is that PDL1, I don't think it's tested in Nepal. To my knowledge, I'm not sure, I may be wrong. But we can always do this. In our hospital, these clinicians have been sending this test very frequently, depending upon all the clinical scenarios. So I think it can be done.
So Dr. Arvind, you are also sending almost all cases?
I would like to say that I have a little bit different opinion. I would first ask the patient like how much money he has in his pocket. Because this immunotherapy are very expensive. So I don't want our patient to sell their home and go for a immunotherapy. So I would just get to know about what is their financial condition. Then on basis of that, I will tell whether to send PDL1 or not.
Okay.
But driver mutation, yes.
Okay. So for anyone who is looking to start PDL1, what does this clone signify?
So for a specific immune checkpoint inhibitor, you have to test with a specific clone on a specific platform. So if he is planning to use pembrolizumab, he will have to test it with 22C3 on a DACO platform. SP263, if he's testing, I think this is the one that was used as a companion or complementary or a companion diagnostics for durvalumab. SP140 was for atezolizumab and 28.8 for nivolumab.
Okay.
So basically you can't exchange clones and you can't exchange and you can't make a CPS or a TPS using a different clone. So if you're planning to use pembrolizumab, which is what I think is what he will want to use in a lung cancer, then the testing has to be done with 22.C3 on a DACO platform.
Okay.
And then he shall get 1 to 49% or 50 and more % to make his therapeutic decisions. Testing with SP263, you will have to do your homework very well in this sense. You will have to get 15, 20 tests done, a certain number done from a lab which does 22C3 on DACO platform, and then do simultaneously in your own lab SP263 on Ventana platform and create what is known as fit for purpose test. Otherwise you can't interchange them and then say, okay, now SP263 is more than 1% use pembrolizumab. You can't do it.
So for this case, EGFR test was ordered. Now, what is the preferred mode of evaluation for this mutation on Raxar?
Sir, I mean, if I have my ways, I will do NGS only. Okay. But otherwise, I think there are 2 FDA-approved tests. One is the TheraScreen from QIAGEN, and the second is the Cobas, so from Roche. So I will think that these are the 2 FDA-approved tests, well validated. So, and they are based upon the principles of amplification refractory mutation system, and one of these can be used.
So tell me if I'm wrong, these are the RT-PCR?
These are RT-PCR.
Okay. Okay, so what about IHC? Is IHC equivalent?
No, IHC is not equivalent. IHC was, in 2016, the ESCO CAP were on the verge of including IHC as an alternative to RT-PCR. But when they opened up this suggestion for inputs, several inputs were received which said that the sensitivity of, I think there are two Del 19 and 858 for which the IHCs were prepared. 858 was high. It was reaching somewhere around 90% or so. But for Del 19, it was coming to 73 or 75%. So the serious objections were raised on this draft publication, and finally they withdrew this.
Okay.
So today, no guidelines recommend doing EGFR by using mutation-specific antibodies.
Okay, so no IHC for EGFR, yeah.
The updated versions don't recommend to use IHC for EGFR.
Okay. So for this case, no mutation was detected. Now, I want to highlight on this. I won't focus, I won't dwell much into the mutations that are evaluated. So what does this mean, satisfactory for evaluation? So my question over here is, when patient comes to us asking for blocks to send for EGFR, do we just close our, without looking, should we send the block or should we screen? Like, which is the best block to choose for EGFR?
Of course, you must have tumor in order to test for any EGFR.
Is there any percentage of tumor that should be present in a block?
So I think, you know, usually it is believed that 10% tumor fraction is required, or nearly 300 to 400 cells should be there for an RT-PCR to be successful. But you can actually try with lesser percentage of tumor. And one thing that we often do and works very well is macro dissection. So what is done, Diksha would have seen it. What is done is that we put the HE slide, we mark out those areas which contain the tumor cell, and then sections are cut and everything else is scraped off. Only the area which contains tumor is taken. Now, remember, it is not the amount of tumor which is important. What is important is the amount of tumor fraction. If there are too many normal tissue, there is too much of normal tissue, the DNA from normal tissue is diluting the tumor, the DNA from the tumor tissue. So the tumor tissue fraction is becoming so low that it is becoming undetectable. If you do macro dissection and remove all the normal tissue and keep the tumor tissue, then the tumor fraction will reach 70%, 80% in any case. So do this exercise, cut sections, identify on HE1 area where there is a tumor, scrape off everything from the slide, and then this area you take in the Eppendorf tube, and you will get great tumor fraction, and you will succeed every time. Try it.
Okay, so should we look for the most pleomorphic region of the tumor? Or
no, I think this is a driver mutation. This will be present in all cells.
Okay, so we are basically looking for the driver mutation. Anything on this, Bonita, Dr. Bonita?
Yeah, of course we have to avoid the necrotic areas and non-viable areas.
So ALK1 again, which is the preferred mode of evaluation? Wait, for Dr. Arun, do you have any experience on this? Like EGFR, we send for EGFR and it comes out negative or unsatisfactory.
When we send for this EGFR, we actually pray that some markers has to become positive so that they will avoid the chemotherapy and they can go for the tablet or TKIs. And that has a better PFS and overall survival as well. But we have so many cases with this negative.
Okay, so again, ALK1, which is the preferred mode of evaluation for this mutation?
I think IHC is good.
IHC. So for ALK1, IHC is equivalent.
Absolutely.
So I think there is also, we also have to look for clone?
Yes.
Or does ALK1 for IMF?
No. So this is a complete assay. And I believe that the assay is an assay. That means it should be D5F3 with all the other reagents from Ventana and done on Ventana benchmark XT. So if you do it all together, then it's an assay, and then you can say IHC is adequate. But if you are taking just D5F3 clone, the retrieval from some other place, using some other model for staining, then again you have to go and do what I said, fit for purpose testing.
So we cannot just call the vendor and ask for ALK1, any ALK1. We cannot do that.
So it should be as an assay. It should be like the kit has been obtained from Ventana and run on a Ventana benchmark XT.
Okay, so you're suggesting that specificity and sensitivity of IHC for ALK1 is at par with that of fish? Okay.
It's better than fish because fish is troublesome. You know, you require with thin sections, and sometimes you may not know which is the tumor area, which is not a tumor area. IHC is excellent, and IHC can be done by all labs. The only limitations, as I said you, is that if you're using anything else than D5F3 Ventana assay, then you have to do the fit for purpose testing.
Okay, so our case again was negative for ALK1 protein expression by IHC. So, yes. So ROS1 also was negative. So what would be the next course of action to Dr. Arun?
For this kind of cases, we usually in our setting, we go for a palliative chemotherapy again. But sometimes, like if some patients are sensitive, we can go for a multi-gene panel assay as well.
Okay. So with this, I'll ask Dr. Saugat here. At this stage, do you think the patient will benefit from radiation therapy after what Dr. Arun has already said?
Well, thank you for the question. I think, is there any role for radiation therapy? Upfront, you start with chemo in such cases. One of the things that I forgot, that we haven't discussed earlier was how many mets there were in the PET-CT. I mean, were there limited mets, like 3 or 5 mets? I saw in the PET-CT there were around 4 mets. So that would suffice to call it an oligometastatic disease as well, if we consider 3 to 5 mets, since there are no brain mets. So in that case, for management of this patient, since none of the driver mutations are positive, you proceed with chemotherapy. After 3 months, you could do a PET-CT, see the status, and of course, if you can, then you can choose it for treating the oligometastatic as well as the primary lesion in such cases. Or else, if there are any other mets, let's say polymets in the liver or the lungs or anywhere else, then I think radiotherapy will be reserved for palliative purposes. Maybe if the patient has hemoptysis, we could control it with radiotherapy. So in such cases, radiotherapy would play a role then.
Okay, thank you. So next question again.
So when do I give a SPRT?
Just out of curiosity, this one.
SPRT, well, it's in case anyone is wondering, it's a stereotactic body radiotherapy. Something high-focus radiotherapy that's given outside the brain is SPRT. We do perform it. In Tata, we've done a lot of these things. We have a case series as well. So if the lesions are, let's say, 3 or 4 lesions that we have in the lung and we can meet the constraints of the other normal tissues there, then we do give a high-focus radiotherapy, and there are evidences From 2018 onwards, we had the SABR COMET trial, the SABR COMET trial, and that's it. There is increased survival with such approach, with the SBRT. But again, choosing patient is very important in such cases. The disease has to be controlled by systemic treatment upfront, and if there are remaining meds in such cases, you could choose. The ideal time that we wait for is around 3 months after starting the systemic treatment. And if there are limited meds, yes, why not give the patient a chance?
Okay.
So it's always better.
Okay, thank you, Dr. Saugat. So patient was started on pemetrexed and carboplatin-based chemotherapy, and which was tolerated uneventfully. Now, this P53 mutation was detected. Does this have any significance, Dr. Anurag, sir?
So TP53, really speaking, is seen virtually in majority of the cases of lung cancer. For biomarker-directed therapy, it has got absolutely no significance. But if you're using immunotherapy, then the combination of KRAS and TP53 mutant cancers are likely to respond best. Those with KRAS alone intermediate, those without KRAS and TP53 will show low levels of response, and those with STK11 and KEAP1 will show no response to immunotherapy. So in that context, a TP53 mutation may be useful. Otherwise, a biomarker-directed therapy, TP53 has no role.
Dr. Arun, do you have any experience with this?
No experience with this kind of patient.
Okay. However, yeah. So this is post 3 cycles of chemotherapy. Naren, sir, would you like to say anything on this?
I think radiologically, the main bulk of that mass is almost similar in size and something like that. Effusion is also there. But the lesions, these small nodular lesions, which were seen in the previous sections, I think there is some decrease in number like that. Only in this section, I can say much about this.
So.
Okay, now in this case, I think that in the long window, which shows in that long window is not a component of mass lesion. Now we can see that the lesion is decreased in size. It's definitely decreased in size as the effusion is there, and the other nodal lesions are also, numbers are also decreased in numbers also.
Okay. Sir, this is PET.
Again, I think this improvement is there.
Improvement. Okay. Sir, there is one kidney lesion, I think. Would you call this a lesion or normal uptake?
I think these are the normal uptake in the kidney. Which phase is this? Need to see all the. I think these are the excretion lesions are not there. It's normal.
Okay. So because there were new bilateral kidney lesions and the overall features were those of a progressive disease. A biopsy was done of kidney because they wanted to rule out the mets. So polydifferentiated carcinoma, likely metastasis in a known case of adenocarcinoma. To Anurag sir, should we be doing IHC given the patient is already a diagnosed case of lung carcinoma?
But this was adrenals, no, this was adrenal or renal mass?
Renal.
No, the secondary one. Right now it's definitely kidney, it's not adrenals. Because if it's adrenal, I will not, because adrenal is a very common site of metastasis. But if it is a kidney, then I think I will probably, but kidney in any case you don't biopsy, isn't it? You don't biopsy kidney tumors. So probably if it's a stage 4 metastatic, then you will want to. Maybe if you think it's a metastatic kidney now, maybe you can biopsy. Otherwise, if it's a resectable kidney tumor, you won't biopsy it. But here then the challenge will be you have a disease which is very aggressive, which is not already responding to your chemotherapy. But why will you want to actually, fiddle with the kidney at all?
I think like this might be the logic might be like, because from lung to kidney is very rare, but from kidney to lung is very common. So maybe the physician might thought that it might be the second malignancy. So maybe because of that reason, they want to do the kidney biopsy. I see, yeah, second primary. I think that is the only logic for that.
Anyways, our case was, yes sir, Naren sir, were you?
Yeah, I think so. It's, the adrenal should be there for the metastasis from the lung. And as you said, that clinician might thought that there is another tumors may be there. And that's what I said in the lungs, that may be a metastasis from the kidney. That's the thing.
So our case was CK7-EMA, vimentin, TTF1, napsin positive, and markers for renal primary were done that were negative, and FH was also done, which shows retained expression. So should we do FH on all kidney cases?
It's a very rare cancer.
Yeah, fumarate hydratase.
It's a very rare cancer. It's usually seen in those cases who have a germline fumarate hydratase deficiency. Very rare, and it has a very peculiar morphology in which the cells are large, eosinophilic. They have a prominent nucleolus with perinucleolar clearing. Rarely you see a kind of papillary carcinomas which are called CpG island methylator phenotype of papillary carcinomas, in which there is methylation of this fumarate hydratase and CDKN2A. Those are somatic cancers. But I think it is taking too far to do fumarate hydratase testing without first even being sure whether it's a kidney cancer at all or not.
Okay, so Dr. Arun again. So, yeah, what's the next step?
So we did the second biopsy from the kidney, and it also favored the biopsy the primary from the lung. So in this case, like since the disease is progressing, I would change the chemotherapy, or else we can do the molecular testing for to find out other any targetable mutation are there or not.
Yeah. So when do we stop? When do we stop the molecular test?
When do we stop?
Yeah. When do we stop chasing?
Actually, if the patient wants, then only we'll send for the molecular test.
Suppose the patient wants, would you recommend?
Then we'll send for the NGS or higher molecular.
So if in this case we had stopped at EGFR at ELK, then I think we shall look for the other lung-specific alterations. I will not suggest that do a very large panel because you may find several non-actionable alterations. But if you have not done already RAT, NTRK fusion, ROS1, if you have not done MET exon 14 skipping mutation, BRAF V600E, then maybe you can actually do an NGS to find these alterations. That's all. I think you
for
can
the
do
actionable,
an NGS. But we have found case, like I remember there was one case, failed 2 cycles of therapy, and we found on NGS, I think I showed that case also yesterday with the ETV6 NTRK3 fusion, and she responded beautifully to entrectinib.
Yeah, so patient underwent cell-free DNA testing and was found to have a BRCA2 mutation and P53 mutation. So looking at this report, Dr. Arun, how do you think the patient should proceed?
First of all, I mean, this is very rare in lung cancer. These things are more common in breast, ovary, pancreas, prostate. But before thinking about anything, I will first try to find out the source from where this was done. If it is done in Rajiv Gandhi or Tata,
No.
then I will definitely
That
go
I
for
cannot
a PARP
disclose.
inhibitor, that
I
is
cannot
olaparib.
disclose.
And again, we will give for maybe 15 days, 1 month, then we can do the response physically. Then after that, we can also look for the response evaluation by doing the CT scan or PET CT scan. Then according to the response, we will plan for the next action. But if it is positive, and this report is from Rajiv Gandhi or Tata or from higher center, which we trust, or even Nepal, in that case, I think we have to start with the PARP inhibitor. And at the same time, we also need to find out whether we missed anything being a female. Maybe it came from the breast or from ovary or maybe pancreas. This we can search.
Anurag sir, anything on this?
So this was a germline testing, because on top it is written summary of detected somatic alterations.
Okay.
So somatic alterations means that this has been done on a tumor tissue, and we are not sure whether it exists in germline or not.
It was done in blood.
It's done on blood. Okay, so let's presume it has been a germline case with a 49.6% PAP, which is what is anticipated of a germline alteration. So 2% of the lung cancer have BRCA alteration. 2% of the lung cancers have BRCA alterations, but there is no current recommendation for use of PARP inhibitor in lung cancer. With the level 3 evidence, that means actionability in other cancers, not this cancer, you can use that kind of a level 3 evidence and then use olaparib. But it is definitely not level 1 or level 2 evidence on the basis of which you can use olaparib.
I think there are 3 or 4 studies that's underway looking at PARP inhibitors right now. The lung map, the Lodestar, I think, and there's one from Gustav Rossi as well. So they are looking into it. We don't have the published result yet.
Okay. So,
one more thing, like in 2020, there was one publication, meta-analysis from the NIH, US. So they say like if there is a BRCA2 positive in a lung cancer, it might be from the squamous cell origin as well. So in that case, like instead of, if this olaparib doesn't work, and then we can again start the palliative chemotherapy, other than that we used in the previous line.
okay, we'll move on to next case quickly.
Before moving on to next case, I want to ask this question about this tumor mutation burden, which is 3.44 mutation per megabase. So my question to Anurag sir, what is the best platform to do this test, and how it is relevant as compared to PD-L1 testing?
So they are not non-overlapping, all 3 of them, PD-L1, MSI and TMB, they are non-overlapping. In some cancers, the TMB and MSI are overlapping. But in lung cancer, MSI is seen in less than 1% of the cases, but TMB is positive. I mean, TMB can be used as a biomarker in lung cancer. The only approval, FDA approval, is for Foundation 1 tumor mutation burden, where you need with the cutoff of 10 mutations per megabase. There is no harmonization. There is an agency called Friends of Cancer. They try to compare the several platforms, several panels, and finally they came up with no answer. And therefore I think tumor mutation burden is something that should be used last after exhausting all other options for use of immune checkpoint inhibitor. And if you really want to do it, then do it through Foundation Medicine using a cutoff of 10.
Okay, thank you, sir. So we will quickly move on to case 2. So this case is a basic case, mainly oriented to all our residents who are eager to listen to our panelists. This is a 69-year male who presented with a chest pain and cough since 1 year, and he recently developed hemoptysis since 1 week. So chest X-ray showed a mass in the lower lobe of the left lung, and this is a CT chest. So our radiologist would like to comment on this.
This is the given section of the CT in the long window. There is a relatively well-defined areas of alveolar opacities in the left lower lung. I think only the alveolar opacity is there. Any other section is there?
No, sir. This is the only section we could get.
Okay, so after seeing this, this opacities, there is no mediastinal window and the contrast image is also there. So we have a lot of differential diagnosis in this. It's the first thing is the infective one, that is a pneumonia is the differential. But as you know that we have now the lipidic growth pattern is also there. So there is some invasive type of this, previously we call as a bronchoalveolar. Now we can see that the invasive lipidic growth, that's a kind of adenocarcinoma maybe also there, considering the age and the history that hemoptysis is there. So we should need to differentiate between the infective and the malignancy by seeing just this section only, because we need a lot of mediastinal window contrast and non-contrast CT also. That's why.
So, sir, just by looking at this one slide, is there any relation of the tumor to the pleura?
Yeah, I think there is, even the pleura is better seen in the mediastinal window. That's why I am saying, and we need a contrast CT of the mediastinal window. This is only a long window, so, but that lesion is abutting the pleura. And I think there is some thickening in the pleura also is there.
Okay, sir. So further on, MRI brain was done and there were no lesion detected. And further, the PET scan of chest and abdomen and was also done, and there was no other lesion except for the lesion in the lung. So further moving on, the CT-guided two-cut biopsy was done, and this was H&E stain slide which is received. So Dr. Banita, would you like to comment on this?
It looks a little blurred to me, I don't know. I see again two pictures here. It looks like non-small cell. What do you say, Anurag sir? Yeah.
Okay, so histopathological diagnosis was non-small cell carcinoma. So actually the question is repeating, but still a few of our residents were coming and going, so we want to highlight this point on them as well. So the minimal initial ISC panel that has to be applied as per recommended by the WHO, and why? I think the question is repeat, so the basic ISC panel was applied on this patient. So TTF1 and P40 both were negative. So further moving on to the case, since the basic panel was both negative, and can this tumor be still be a non-small cell carcinoma and still be negative for this tumor? And also in the P40 ISC staining, what should be the percentage of the tumor cell that has to be positive to determine tumor as P40 positive?
So I really don't know the answer to that. I think if there are cells which are P40 positive and there is nothing which is TTF1 positive, I will call it waiver squamous carcinoma, but I don't have a cutoff. I don't think I have read anywhere that there is a cutoff. So this for me will be NSCC, NOS, and will qualify for further biomarker testing.
I think, what about metastatic lesion? Couldn't it be metastatic lesion?
This is what I always said, but if you are, so biopsy is not the first investigation. So if the physician is sending a biopsy to you, he should have done that basic workup where he is suspecting a metastasis and he tells you that there can be a metastasis. So you look up for metastasis. Otherwise, it is not your responsibility as a pathologist to do metastatic workup. That onus is on physician and physician alone. Don't assume his responsibilities.
Okay, sir. And further on, to add on, NAPSIN-A and P63 was also negative in this patient. So regarding this P63, how effective is this stain as compared to P40 when comparing the squamous cell carcinoma of lung?
In lung it is, I think they are all equal. In some salivary gland carcinomas, P63 stains something which P40 do not. But and sarcomatoid carcinomas of the oral cavity, P40 may be negative, but P63 is sometimes positive. But in lung, P40 and P63, P40 is probably superior.
Is there any adenocarcinoma of the lung which can still show P63 positivity?
I don't know of one.
Dr. Banita, would you like to add some comment on that?
I have no idea about this, sorry.
Any other ISC marker to be applied? So this is the CK7 staining which is done. So Dr. Banita, would you like to comment on this?
CK positive is general, it can come in any.
Yeah, this is CK7, cytokeratin 7.
Oh, okay, 7. Since this is 7 positive, we can have it in adenocarcinoma, or it can also be in metastatic carcinoma from upper GI. So we need to rule that out again.
Okay. So further extensive this ISC panel was done in this patient with synapto and chromogranin as well, which finally came out to be negative. So what is your take on this? Do we need to apply this neuroendocrine marker on all these cases, and what does the guideline talks about?
I think we have to go back to the morphology before going to a panel of ISC test. So if it's, as far as I saw those two photographs of your H&E section, so that really doesn't look like small cell to me. So I would rather not really go in the first phase to have these markers.
So I think, you are a pathologist, and not just an immunopathologist. So your first step when you are looking at a biopsy, and all this discussion becomes relevant, once you have ruled out it is not a salivary gland tumor arising from tracheobronchial salivary glands, it's not a nut-driven cancer, it's not a carcinoid. After having done that, by morphology, and then by in case you suspect, you have to do appropriate immunostaining. But these are the three things you have to first, at least these are the three things that you have to first rule out in your mind, and then start the workup for NSCC. For this, there is no shortcut. So this is the algorithm you keep in mind. Lung biopsy, I just need to see these three things first. If these three things are not there, and the physician has not said that it could be metastatic, then you say SCLC, NSCC, and proceed.
Okay, thank you, sir. We are running short of time, so we are wrapping this panel discussion session. We once again would like to thank all our panelists for their very enthusiastic and thought-provoking discussion. So, and I would like to ask all the audience to close this panel discussion with a big round of applause to all our panelists. Thank you, sir. Thank you, ma'am.
This panel discussion was fruitful. We thank our panelists for wonderful discussion and our moderator for this. We request Dr. Anil Dev Panta to provide a token of love for our panelists. Dr. Anurag Mehta. Dr. Narayan Bikram Thapa. Dr. Arun Sai. Dr. Saugat Podel. Dr. Bonita Gurung. Thank you, sir. It's high time for lunch. No doubt, it's most awaited time, and we are already delayed. So we are taking lunch break of 30 minutes, which will be followed by sponsor session. We have one thing to announce that if anyone have not got gift from Om Surgical Concern, please kindly visit their stall for their gift. And also they have lucky draw for winners, one winner who will get one night stay at Club Himalaya. Thank you. We'll resume after lunch. Thank you.
SNIPE, a leading company in chemiluminescence immunoassay field, has a full biochemistry product line as well. BioSage 240 Plus, the latest SNIPE biochemistry analyzer with compact design and high efficiency, is a reliable member worth choosing in clinical labs. BioSage 240 Plus is one of the fastest small-size analyzer with 240 tests per hour for biochemistry and 200 tests per hour for electrolyte testing. The sample and reagent area are combined in a single disk. It contains up to 90 sample in 90 reagent positions. Both polytype primary tubes and micro-container cups are compatible. The sample and reagent disk provides constant cooling at 2 to 10 degrees centigrade. Continuous loading function for sample and reagent is also available during measurement. The detachable design is convenient for sample and reagent storage. The sample and reagent needle coated with Teflon is washed automatically after each pipetting to avoid cross-contamination. Other functions, including liquid level detection, clot detection, and crush-proof are also available. 1,400 round per minute high-speed mixer coated with Teflon is used to fully mix sample and reagent and is washed with preheated water before and after mixing. Totally 80 reusable optical plastic reaction cuvettes are used for reaction and measurement. Minimum reaction volume can be lowered to 100 microliters, which is cost-effective for customers. BioSage 240 Plus adopts post-spectroscopic optical system and a long-life halogen lamp, which greatly improves the detection accuracy in reducing consumable cost. 16 wavelengths ranging from 340 nanometers to 800 nanometers meet the needs of different assay configurations. 80 reaction cuvettes can be automatically cleaned by a station with 4-step washing procedure. The maximum water consumption of BioSage 240 Plus is ranging from 2 to 3 liters per hour, which greatly minimizes water usage. One BioSage reagent kit includes 30 milliliters R1 and 10 milliliters R2. Smart Design reagent kit makes the benefits of loading R1 and R2 at one time. Each reagent kit has a unique barcode. Barcode recognition function is available for both sample and reagent. A simple and user-friendly software provides excellent user experience. STAT mode and automatic dilution function are supported. The needle and cuvette can be washed by acid-based cleaning solution thought, self-defined settings in software, avoiding cross-contamination to the most extent. The real-time status for reagents and each single test can be monitored on the software. It is highly compatible with major LIS systems and provides bidirectional interface transmission. With multiple kinds of biochemistry assays, BioSage 240 Plus Analyzer can provide comprehensive solutions to satisfy various requirements of small and medium-sized hospitals and laboratories. BioSage 240 Plus, one of the fastest and efficiently small-sized biochemistry systems, is becoming a perfect choice for clinical laboratories.
Hello. Welcome back, ladies and gentlemen. Thank you for joining us again. Hope you all enjoyed the lunch. Me, Dr. Nikita, third year resident from Kist Medical Hospital, will be your MC for this session. To keep you all hooked up, we have informative presentation lined up for you. Now we have short sponsor session. This session is sponsored by Techno Biomed. So now I would like to call Dr. Ajay Gupta to deliver a speech on recent advances on autoimmune disorder. He is currently the technical director in hematology and immunology laboratory, Dr. Lal Path Lab, New Delhi. So thank you.
Can I have my presentation live? So, very good afternoon to all. Myself, Dr. Ajay Gupta, and I'm from Dr. Lal Path Labs. And this is my first visit to Nepal, and indeed a very, very pleasure visiting Nepal from Delhi. And since yesterday you all had a feast of oncology, so we thought that now let's switch from oncology to something different in terms of autoimmune disorders. And why these are important? Because post-COVID era, the incidence of autoimmune disorders have significantly increased. And let it be Nepal, let it be India, let it be Asia or world, the incidence of autoimmune disease in literature, we are just seeing the tip of the iceberg. And since past 50 to 60 years, there have been significant advances which has been made right from LE cell. We all know, some of the residents are there, we all know what is LE cell. And LE cell was discovered by serendipitous discovery at the Mayo Clinic in 1940 and 1950. And that cell was thought to be diagnostic for SLE, lupus. But yes, it was not positive, or it was not seen in every case of lupus. So the diagnostic sensitivity was just 40%. And in 2000, 2010, 20 and now 23, we have a screening tool, very, very important tool, by which we can not only screen, but further diagnose systemic and organ-specific autoimmune disease. And that diagnostic tool is anti-nuclear antibodies. Now, today I am standing on this podium, I am saying that these are anti-nuclear antibodies. But after 5 years or maybe a decade down the line, it will be anti-cellular antibodies. Because these antibodies are not only directed against the nucleus, but they are also directed against the cytoplasm. That means they are misnomerly called as anti-nuclear antibodies. Who knows ACR, American College of Rheumatology, or EULA, the European Union for League Against Rheumatism? They may, in the next 5 years, replace the terminology of anti-nuclear antibodies with anticellular antibodies. Now, autoantibodies, we all know how they occur. They are divided into two types, organ-specific and systemic. We all know about organ-specific. Thyroid, pancreas, kidney, blood, liver. Virtually each and every organ of the body is affected by autoimmune disorders. Some of the systemic autoimmune disease we all know. Battery of diseases, and by fear, anyone from the audience who can tell the most commonest systemic autoimmune disease? Anyone, any volunteer? Which is the most commonest, or you can say the most important, or you can say the most important disease with highest incidence? I can see a faint SLE, faint rheumatoid arthritis. So either it has to be SLE or a rheumatoid arthritis. So final answer is RA, correct. Rheumatoid arthritis. Rheumatoid arthritis is being the world's most commonest incidence among the systemic autoimmune disease. And you see the incidence 5 to 7%. This is absolutely the tip of the iceberg. 5 years or 10 years down the line, you will see a different data. Definitely more common in females as compared to male. Now, you don't ask me that question because the reason is pretty unknown. And I have told you about LE cell. This is an LE cell discovered by Robert Morton, a resident at the Mayo Clinic. The diagnostic sensitivity of just 40%. And here is the gold standard test, ANA-Y immunofluorescence, which has got a diagnostic sensitivity of 95 to 100%. So in past 5 decades, how much is the improvement is from 40% incidence, we have come to 90, 99 to 100%. Now, we all know what are anti-nuclear antibodies. These are the antibodies which are directed and they are bind to the nucleus of the cells. 2 main common techniques worldwide is used to detect anti-nuclear antibodies. Anyone? Anyone? Immunofluorescence is number 1 and ELISA is number 2. Now, if you ask me which is the gold standard and how the ANA should be tested, it is immunofluorescence. It's not that Dr. Ajay Gupta is saying, it is according to American College of Rheumatology. Now, they have laid very, very specific guidelines for that. And if you compare the 2 techniques, IF and ELISA, definitely in terms of sensitivity and specificity, IFA holds a huge upper hand. And not only because of its diagnostic sensitivity and specificity, the immunofluorescence shows different patterns. After all, it is a microscopy. And we all know that anything which is diagnosed by a manual eye is considered to be a gold standard. So that is why, because of these 2 or 3 critical points, IFA holds a huge edge over ELISA. So there are various battery of techniques which are available for ANA testing. Now, where does ELISA stand? Now, there are not many labs in India, in Nepal, in Asia, who can practice immunofluorescence because it needs expertise. It needs some sort of investment. You require kits, you require immunofluorescence microscope, you require trained eyes, you need expertise. But in those areas where we can't use immunofluorescence, ELISA can be used. But you need a robust ELISA. That means you need an automated platform in ELISA if you want to practice ANA on ELISA. Because even if slightest of a false positive result, you are handing over a patient an ANA positive report. That means the patient has a stigma that he is having some sort of an autoimmune disorder. And he will be subjected for further next line of investigations, and they are very, very costly. This is the American College of Rheumatology positional statement. You can see the first point, ACR supports the diagnosis of ANA via immunofluorescence. Very, very important, 2019 ACR Euler criteria for lupus. Now you can see the top. The ACR and Euler has given emphasis on ANA as an entry criteria for the diagnosis of lupus. If we are suspecting a patient to have lupus, fine, he might be having photosensitivity, he might be having a butterfly rash, but then you need to test an ANA. And how do you need to test an ANA? The minimum dilution, the initial starting dilution should be 1:80 by immunofluorescence. Now, why I'm saying 1:80 or more? Because ANA can be false positive in a lesser dilution, in 1:40. So please remember those labs who have started ANA in Nepal or are starting ANA, please, you have to start ANA, the initial dilution, in 1:80, and then you can go on to 160, 320, 640, 1280, and so on, doubling the dilution. And results of ANA, higher the titer, more they are meaningful. If you want to ask me, what is the cutoff titer? If a ANA-IF report you are seeing, and you are seeing a titer of 1:160, it is considered a very, very significant titer, and it warrants the next line of investigation, which is the ANA profile. You can see on the left side how much emphasis it has been given on the lab. Anti-cardiolipin antibody, anti-beta 2, then dsDNA. dsDNA is a very, very specific antibody for SLE. Now, these are the slides, these are the glass slides which we use for testing ANA via immunofluorescence, and you require a ANA immunofluorescence microscope. Now, there are various kits in the market which are available, but not only we have to see which kit has got the global presence, which kit has got a best in class of technology, and which is enrolled under your AQUAS, because you have to enroll for AQUAS, external quality assurance. At Dr. Lal Path Lab, we are affiliated with CAP. So we need to test the CAP samples. There are various kits, and I feel, and though it's an academic platform, but yes, I'm very happy to say that Verf and Innova kits, right now, globally, they are recognized as one of the best kits, not only in Asia, but also in Europe. So these are the various patterns. Now these are the various patterns why these patterns determine the systemic disease which a patient likely be having. This is homogeneous pattern because the nucleus is shining homogeneously. More likely the patient is suffering from lupus. If you are seeing this pattern straight away, you can think about SLE. You can go for a next line of investigation, which is the dsDNA. On the left side is a speckled pattern. Unlike the homogeneous pattern, you can see the nucleus is slightly, you can see the blackish area in the nucleus. And the speckled pattern is one of the most commonest pattern. And you can see in SLE, scleroderma, Sjogren's syndrome. You can see on the right side what has happened to the nucleus. The nucleus has been broken down into bits and pieces. And this is a centromere pattern, which is very, very specific for scleroderma or the CREST syndrome. And what has happened on the left side? Can we see the nucleus? Can we see the nucleus? No, because it is not a nucleus staining. So it is what? It is a cytoplasmic staining. That is why I told in my opening remarks that anti-nuclear antibodies may be replaced by anti-cellular antibodies because the antibodies are also directed against the cytoplasm. So when we see a cytoplasmic pattern, 3 diseases come under our mind. Autoimmune liver disease, second myopathy, third is psoriasis. That's it. If you are seeing a cytoplasmic pattern, please keep these 3 diseases in your mind. And what is there inside the nucleus is nucleoli. You can see multiple nucleoli inside the nucleus. And these are more likely seen in scleroderma and polymyositis. DFS70, a very, very recent pattern. Now this pattern is also seen in normal patients, but also seen in autoimmune disease. So we have to be very, very careful while we are reporting this pattern. This is a new pattern. We have to go a very, very strong understanding on this. We have to identify on this. And then 5 to 7% of the people have normal ANA. See, it is not that ANA is positive in autoimmune conditions. ANA can be positive in non-autoimmune conditions. Non-autoimmune, even tuberculosis, schistosomiasis, chronic lymphoproliferative disorders. These are hepatitis. These are some non-autoimmune conditions in which ANA can be positive. But ANA will be positive in low titers. They will not be strongly positive, which will help us to differentiate these diseases from the autoimmune disorders. As I told you that a titer of more than equal to 1:160 is considered significant and warrants the next line of investigations. Now you can see that at the National Reference Lab, Dr. Lal Path Lab, we are giving the photograph of the immunofluorescence, ANA, dsDNA, and the ANCA. This is the incidence of autoimmune disease, SLE heads, 95 to 100%. Even for the, you can say, juvenile rheumatoid arthritis, not a very, very common condition, but still 15 to 30%. And what next? If you have got an ANA positive report, what to do? The next is ANA profile. Now, this is a line immunoassay profile in which the antigens are coated, and these strips are incubated with the serum, and the antibodies, they bind to the antigens, and we get a band. Based on this band, we get different autoimmune conditions. For example, we have a homogeneous pattern. Then straight away you need to go for a dsDNA. If the dsDNA is positive, it is SLE. Then speckled pattern. Speckled pattern, you can go for a SM, SSA, SSB, RNP, and SCL70. Now what is this? These are ANA profile, or the extractable nuclear antigens. SM stands for anti-Smith antibody. Anti-Smith antibody is very specific for SLE. SSA, SSB for Sjogren's, RNP for mixed connective tissue disease, scleroderma, SCL70 for scleroderma. So this is an algorithm which will help you to clinch to a diagnosis of a systemic autoimmune disease. Also, this is another algorithm. On the right side, these are the systemic autoimmune disease, and on the left side, you can see the associated antibodies which are there. Now, these antibodies are only tested when ANA is positive. I'll take just 2 minutes more. And there are different conditions. So my take-home message is that ANA should be screened in 1:80 or more titer. Higher titer are more significant. Immunofluorescence is the gold standard method. Please use standardized kit when you are going or you are starting a new test for ANA. If the titers are more than 1:160, please go for an ANA profile for the proper diagnosis. ANA titers fluctuate regardless of diseases. So please don't test ANA again and again. If a patient is suffering from lupus, will you want that ANA should be tested? No, should not be tested, because ANA has got just a screening significance, not the diagnostic significance. Okay, some patterns are very, very common, like nucleolar and speckled. So high titers are more meaningful. The last paragraph, false positive cases can be seen in hepatitis C, tuberculosis, and even with the result of certain medications. Now, antihypertensives, captopril, procainamide, phenytoin, quinidine, sulfasalazine, and interferon. This is the last slide, a guess for the postgraduates and the SRs. Come on, my time khatam ho chuka hai already. Yeah, I want a quick answer. Of course, he's Michael Jackson and he's no more, but I will not like to share Michael Jackson with you. What has happened to Michael Jackson? Anyone? What has happened to Michael Jackson's cheek? What is the rash? Butterfly rash. A typical butterfly rash. Michael Jackson had lupus, suspected at the age of 35 to 36. And what he used to do, he used to undergo a plastic surgery. But autoimmune disease, if it is there, it will come up. Again, it used to come up, you can see. Again, he used to undergo a plastic surgery. He died at the age of 56 or 57. 20 years he lived with lupus. He danced, he entertained us. Never felt that Michael Jackson had lupus. So, why? What is the aim of myself showing this slide is that we need to catch hold of this autoimmune disorder at a very, very early stage. In case we are able to initiate the treatment at a very early stage, the better is the diagnosis, the early is the treatment, the better is the prognosis. Thank you very much. And if there are any questions, I will be more than happy to answer. Yeah, please. Yeah. Great. Oh, excellent. Please, a big round of applause. Absolutely. Absolutely. So for the beginners, very, very relevant questions. Yeah. So your first question, he says 1:40 is the most commonest titer. Sorry, 1:80 is the most commonest titer. And some lab reports 1:80 as 1 plus, and some lab reports it as negative. Now, there are 2 or 3 reasons for this discrepancy. First of all, it's how you are seeing. Because 1:80 is weak titer. So you require a trained eyes, you need to be very well versed with that 1:80 dilution, and only then you will be able to give it positive. So what I will tell you, when you are seeing a field of immunofluorescence, please try to identify the pattern, not the immunofluorescence. Everything which is dark green doesn't mean that it is positive. You need to see the nucleus very, very stringently, very carefully. If you are able to identify a pattern, then only you give a positive report. Might be the other lab is just giving a false positive in a report, just basis on the fluorescence, not on the pattern, number one. There are different sensitivities and specificities of kits which are available. You can go through the literature of these kits, you can scroll Google, you can go with the international journals, what they have done. Please use standardized kits which are best suited and best available in the markets. Even if the other lab has reported 1:80 as negative and you have reported it as positive, you are confident, please take a photograph of that immunofluorescence sample. You can share with the patient or you can share with the clinician who has sent you the report. If you are confident, if you are seeing the pattern, no one can deny that. Is it clear? Now, what was your second question? See, what I feel is, it is not about the substrate because both are mammals. They are mammal substrate. The thing is that how you have prepared the slide, the art of preparation of the slide, and in the end, how we are mounting it and how we are seeing it. There is no deficiency when we compare the two substrates. There is no deficiency in any substrate. It's the matter how you have prepared the slide and how you are looking into the microscope. Okay. Third question of your asthma. Now, you have told that when we look to anti-smooth muscle antibody, we see the muscular layer. Okay. Muscle layer of what? The stomach. Okay. We can see the blood vessels. What we see? The muscular layer of the blood vessels. So in case the smooth muscle layer of the muscle is positive and the muscular layer in the blood vessel is positive, and in between the parietal cells, the fibrils, which are positive, it is more than sufficient for you to classify that sample is anti-smooth muscle positive. Now your next question is that there is also a liver substrate which is there. It helps us to identify LKM. In any case, if liver substrate is positive, your PCT and DCT are positive for kidney, and your parietal cells are positive. That means you are having three things positive: the liver substrate, the PCT, DCT, and the parietal cells. If all these three are positive, it is not AMA, it is not ASMA, but it is LKM. So the importance of adding the liver substrate to mouse, stomach, kidney with liver is to identify anti-LKM, which is the liver-kidney microsomal antibody. Thank you.
Thank you, Dr. Ajay Gupta, for your valuable, informative presentation. So now I would like to invite on stage Dr. Runa Jha to provide certificate of appreciation to Dr. Ajay Gupta. Thank you, Dr. Runa and Dr. Ajay Gupta. With further no delay, I would like to invite on stage Professor Dr. Geeta Sayami and Professor Dr. Abhimanyu Jha, a chairperson for this session. Professor Dr. Geeta Sayami is currently working as senior consultant pathologist at HAMS Hospital with special interest in cytopathology. Professor Dr. Abhimanyu Jha is currently head of department at Maharajganj Medical Campus, past General Secretary, ACPN, with special interest in bone and soft tissue cytopathology. Ma'am, I would like to call, ma'am and sir, I would like to call you on the stage.
Now we are going to start next section, and in that we have 4 papers. First presenter is Dr. Krishna Kumar Maharjan. I would like to invite him. And he is head of cytogenetic department, MediQuest Laboratory Clinic Private Limited. He has got several publications in national as well as international journals. And his special interest is in cytogenetics. Dr. Krishna Kumar Maharjan, please.
Thank you, ma'am. Good afternoon, respected chair, respected seniors, colleagues, and friends. My topic for today is role of cytogenetics in cancer care. So this is the content of my presentation. So basically, study of genetics can be done at 2 levels. There will be, there can be abnormality in genetics in 2 levels. That is in chromosome level or in a DNA level. So various kinds of tests are included in cytogenetic, it's an umbrella term. So karyotyping, fluorescence in situ hybridization, chromosome microarray, sequence-based test, and optical genome mapping is a new technology. So karyotype has a role in both hematological and solid tumors. This is how cytogenetic karyotype and fish laboratory will generally look like. This is the system available where I work. So fish has a role in both hematological and solid tumors. This is the image of HER2-neu. On the left, it is 2 signals of red and 2 signals of green. It's a normal pattern. And on the right side, it's an amplified HER2. The HER2 is labeled by red, and because of multiple signals, it is looking like it is burning. So this is a HER2 amplified. Similarly, use of fish in bladder cancer. So on the left, there are 2 green signals, 2 aqua signals, 2 red signals, and 2 gold signals, which is a normal urothelial cells, whereas on the right side, there are multiple red signals, multiple green signals, aqua signals, and 2 gold signals. This gold is diploid, while others are numerous in number. So it is a hyperdiploid abnormal urothelial cell. So another technology is there. It's a microarray. Microarray is usually used for microdeletions and microduplications. It can be easily picked up. That's why it is more sensitive and more informative. But it is less expensive and not widely available. The thing we have to remember is that microarray cannot detect balanced translocations. And we know that there are, especially in hematological malignancies, there are balanced translocations are there. So those will be not picked up. And also the location information will not be detected, means it won't give this information. What I mean by location information is that, so this is the, both on the right and the left, these are non-hematological cases, but we have received this case for evaluation of Down syndrome. So on the both right and left, these both cases are of Down syndrome only. So on the right, it is the female with trisomy 21, while on the right, it's also trisomy 21. Can you see these 2 chromosomes, and 1 chromosome 21 is sitting on top of chromosome 15. So this kind of information will not be available in chromosome microarray. If we subject this case to chromosome microarray, it will tell that 3 copies are there, but it won't tell that where it is sitting. So this is called Robertsonian translocation actually, but it is Down syndrome. So this is chromosome microarray. Like I told, it is good for detecting micro deletions and micro duplications. So this is how microarray will come. So this 0 you can see, this means that this region is normal copy in number. So anything that goes down is deleted, and anything that goes up is duplicated. So this means that the chromosome 11 has a small portion on the long arm that is duplicated, and here in chromosome number 7, a small part has been deleted. It is difficult to appreciate here in karyotype. This faint band is there, and this faint band is there. It seems like it is little thicker, but it will be difficult to tell in a karyotype, because at least 5 to 10 megabases deletion should be there to be detected in a karyotype. So it has low resolution. So in that case, microarray is more sensitive. So this is a new technology, optical genome mapping, which seems to be promising in detecting structural variants. It is a new technology, and little is known right now. So the role of cytogenetics in malignancies, we now know that all malignant process has a genetic basis. The genetic lesion could be at a chromosome level or at a nucleotide level or DNA level. So in case of hematological malignancies, the chromosomal abnormalities are observed in more than 50% of cases. So it is widely used in hematological malignancies. But also in the previous sessions, we have come to know that not only hematological malignancies, solid tumors also can have chromosomal abnormalities. So it is used in there also. So every suspected case of hematological malignancy undergoes cytogenetic testing for diagnosis, risk stratification, and for follow-up of treatment and response. So different solid tumors can have different translocations, chromosome abnormalities. I'm not going in detail. Dr. Ronson has just told us in the morning. So why cytogenomics is important in cancer care? This is for diagnosis. Like presence of philadelphia chromosome or BCR-ABL fusion is mandatory for diagnosis of CML, so for diagnosis. Similarly, finding translocation, these translocations 821 is sufficient to label any case as AML irrespective of the blast count. So second is for risk stratification. Now we know that if we find this kind of translocations, it is favorable prognosis they have. Similarly, if we have del 5q, monosomy 5, monosomy 7, del 7q, inversion 3, translocation 6-9, complex karyotype, we now know that they will have poor prognosis in AML. However, if it is del 5q in MDS, it has good prognosis. So for risk categorization, it is necessary. Another is for follow-up. Now we have diagnosed. Now the patient will get treatment. Now they will be followed up in some time. So I'm giving some example. So if we find an additional philadelphia chromosome in a case treated for CML, we now know that there is a clonal evolution and disease is progressing. Similarly, if people, that patient had a philadelphia chromosome and that patient got treatment, and if we do cytogenetics, and if the philadelphia chromosome is regressing now, if we do not find it, we know that there is a cytogenetic response. That means the patient is getting good response. So I'm skipping this. I have put one chart. I have tried to put everything in a one slide. So what I want to tell is, this karyotype is will have low sensitivity because only 20 metaphases will be studied in karyotype. Similarly, it will need a live cells and a dividing cells, so there is a chance that it will fail. Some of the times it will come as non-diagnostic. And these mutations, microdeletions and microduplications cannot be picked up in karyotype. So if we are suspecting such kind of, means if we are suspecting some mutations, then this will not help. That is what I wanted to tell. And FISH is a targeted test. What FISH does is, we are applying a probe for a specific region only in one slide. We cannot, so it will tell us about that region only. It will not cover other regions, okay? And we cannot put many probes. We cannot put n number of probes. So it is very specific. If you are suspecting clinically something like PML-RARA, then we have to put PML-RARA. That is what, we cannot just send FISH. We have to send FISH for this, or AML panel, or ALL panel, or PML-RARA, or CM, or BCR-ABL. That we have to specify. Otherwise, lab will not process, because this is targeted test. For karyotype or microarray or NGS, we don't need that one. It is good if you give clinical details, but because we are looking on all the chromosomes, we don't need that. But for FISH, we have to specify. And this sensitivity is intermediate. What I mean by that is 200 cells will be evaluated in FISH. So for diagnosis, at diagnosis, we will suspect like maybe 5, 10, 20, 40, 50% of cells will be abnormal. These can pick up. If you are using this test, if you try to use this test for MRD, then it will not help because there will, because of the sensitivity. So these tests are high sensitivity they have, and they are DNA-based tests. And FISH also, mutations and duplications will not be detected. Microarray, I have already mentioned that balanced translocations and mutations will not be picked up. And sequence-based test, there are various types of tests included in this test. Like aneuploidy, amplification, and large deletions, usually they will not be picked up, and they are for other translocations, mutations, insertion deletions, it will be picked up easily by NGS or a sequence-based test. Optical genome mapping, mutations will not be detected. So the role of cytogenetics in AML. So if we have these, any mutations, any translocations, I'm sorry, so this will fit for a diagnosis of AML despite the number of blasts, except for the ones I have highlighted in yellow. So for diagnosis. So this is, here you can see there is a deletion of 5q. This is translocation 821, and there is a loss of Y chromosome. So if we do different types of tests, in this case, what will happen? Karyotype will pick up. So this del 5q and deletion of Y will not be picked up by FISH, because we have not simply applied these probes, because we didn't know that. We have applied probes for AML only. So in chromosome macroarray, the deletions will, and deletion and loss of Y will be detected, but translocation 821 will not be detected because it is a balanced translocation. Similarly, in sequence-based test, this translocation will be detected, and these deletions will not be. Optical genome mapping will detect all these abnormalities. So the ones that we know that in AML there are 3 categories, risk categories. So the one I have highlighted in red box, these are mutations, and they will be picked up by NGS only. In myelodysplastic syndrome also, there is criteria of cytogenetic abnormality and mutations. So if we find mutations, it will help us in the diagnosis. So for MDS also, if there is no dysplasia, even there is no dysplasia, the presence of del 7 or monosomy 7 and complex karyotype will help us to diagnose it. Similarly, AML, MRC, also some cytogenetic abnormalities are also there, and genetic abnormalities are also there. So this is a case of Philadelphia chromosome is there, translocation 922. So chromosome microarray will not detect this abnormality. Rest of the test will detect this abnormality. This is also a case of CML. There is a Philadelphia chromosome is there, but what is interesting here is actually there is involvement of another chromosome. Chromosome 1 is involved in this case. So chromosome microarray will not will not give a result in this case. And in FISH, it will give partial information. Partial information means that the translocation 922, this is actually translocation 922 and 1. So FISH will give an unusual signal that indicating that some another chromosome is involved, but it will not tell, it cannot tell that chromosome 1 is involved. Similarly, we had another case. This is also the very much similar. So here, what is different is chromosome 10 is actually involved in chromosome 10 is the third partner here. So similarly, microarray will not detect this case.
Can you please wrap up?
This is Philadelphia chromosome. Chromosome 10, part of chromosome 10q is translocated to 9. Part of 9 is, has gone to 22, and part of 22 has gone to 10. It's a 3-way translocation, it is called. This is another example of CML only. This patient had 2 clones. On the right side, there is 922 only. On the left side, it has 922 plus there is another translocation 3 and 14. So if we do different tests in this case, karyotype will pick up these both. FISH will pick up only 922 because we have applied only 922. We didn't know that there is translocation 314, so we have not applied, it will be missed. A chromosome microarray will not detect both the abnormalities because both of them are balanced translocation, it will be missed. And optical genome mapping will detect both, and sequence-based test is likely to detect both. This is another example. So this is also a case of CML, but history was query accelerated phase. So what we see here is there is translocation between 922, and in addition to that, there is 2 copies of 8 and 1 copy extra of chromosome 21. So if we do different tests, so karyotype will pick up. FISH will not pick up presence of additional chromosome abnormalities because we have not put probes on for 8 and 21. Microarray will detect additional chromosomal abnormalities like trisomy 21 and tetrasomy 8, but 922 will be missed because it's a balanced translocation. Similarly, sequence-based test will miss this additional chromosome 8 and chromosome 21. So this is a case of there is a triplication of chromosome, long arm of chromosome 1. So FISH will not detect this case because we didn't know, we didn't apply probe for that, and we didn't know. This was a case of MDS with excess blast. Though this is not a MDS defining abnormality, there is a clonal, abnormal clone is there. This is what it signifies. So there is a marker chromosome. So what is marker chromosome? Marker chromosome is any chromosome that is not identifiable by banding technique is marker chromosome. So what happens here is, in karyotype we cannot tell what chromosome is that, so marker is there, but microarray will tell what is that marker chromosome is. So to summarize, there is no ideal test yet. So karyotype is simple but informative whole genome test. However, a culture may fail in 10 to 20% of cases, and the report also depends upon the quality of metaphases obtained. If we have a clinical clue, then FISH will give us answer really fast. However, we should keep in mind that we cannot put n number of probes. So one probe is one target only. Since a list of gene mutations are now considered defining genetic abnormalities, NGS panel is a wise method to pick up those mutations in one go. Knowing the technical detail of test and strengths and its strength and weakness of different tests will help us combine these tests so as to save time and money and have a best workup. Thank you.
Thank you, Dr. Kamal. So since we are lagging behind the time, so I have just one question on behalf of audience. So you rightly said that if there is translocation 821, despite blast count, you label as AML.
Yes, sir.
So, so PBS and bone marrow doesn't have blast, but there is translocation 821.
Yes.
So are these patients are candidate for chemotherapy?
Yes. Because these are recurrent cytogenetic abnormalities, they will be labeled as AML with defining genetic abnormalities, and we should not wait for. The concept is they will definitely become AML, and blast will increase and will become more than 20%.
So will you give chemotherapy?
Yes, they will.
How do you assess the response then? Response of chemotherapy.
Response of chemotherapy, because there is 821. This can be yes.
Go
this
for
can
821 again.
Sorry.
Will you do bone marrow again?
No, because 821 is there. That can be targeted with real-time PCR, quantitative real-time PCR. That will give.
No need to assess bone marrow blast following chemotherapy to see MRD.
That for MRD we need a sensitive test. So real-time PCR
you
quantitative.
will not do bone marrow.
I think no.
Okay. So now, thank you. So I would like to call Dr. Banita Guru. She is consultant pathologist at Nepal Cancer Hospital and Research Center. She has several publications in national as well as international journals. Her interest is in molecular diagnostic, demographic cancer statistics in Nepal, cell biology, molecular diagnosis of cancer, targeting new anti-cancer drugs, prediction and prognosis of disease. Dr. Banita Guru.
Thank you. चन्दा म्यामले हिजो भन्नुभएको थियो म त यहाँ त झन् डुब्छु है त्यही भएर म यहीँबाट बोल्छु ल थ्याङ्क यू म चाहिँ मेरो एउटा यो ओरिजिनल आर्टिकल हो इट्स अल अबाउट लङ क्यान्सर एन्ड रोल अफ EGFR म्युटेसन इन नेपालीज पपुलेसन सो लङ क्यान्सर के हो लङ क्यान्सर कताबाट आयो के टेस्ट गर्ने यसको बारेमा हामीले धेरै बोलिसक्यौँ सो आई वुड लाइक टु डाइरेक्टली कम टु माई रिजल्ट्स My topic is prevalence of epidermal. So my topic is prevalence of epidermal growth factor EGFR mutation in non-small cell carcinoma at a cancer center in Nepal. Yo sabai chhaदैछ, so I'll directly come to the result. We know that the diagnosis of lung cancer has shifted so much. initially we used to call it just non-small cell and small cell, and then subtyping, and then now moleculars. So this is all because we have targeted therapies, and I want to talk a little bit about this EGFR receptor, which is actually located in the cell membrane of our cells. And whenever the epidermal growth factor comes and attaches to the EGFR receptor, there is cascades of reaction that occurs inside the cell, ultimately leading to cell proliferation and differentiation. So in lung cancer, what happens? This EGFR gets mutated, and there is uncontrolled, non-stoppable tumor proliferation. There was a study by Anita Midha et al. Who did a meta-analysis, and she found that there are so many EGFR mutational data found in the whole world. But sorry, this arrow has shifted, but we could not find the real data of Nepal. So Nepal was white in color, that's why. I'm skipping this. So my main objective was to find out how much was EGFR mutation in Nepalese population. I collected 5 years data from 2015 to 2020, and I did a retrospective study. I digged out all the archive, and then I collected information on age, gender, the diagnosis, the amount of EGFR mutation, where it is located, where were the people mostly from in Nepal, and the ethnicity group who had EGFR mutation. So my results showed total number of primary lung cancers were 505. Among these, non-small cell were 75%, and adenocarcinoma was the most common one, 60%, followed by squamous cell carcinoma and others. So we included this adenocarcinoma in our study, and we found only 148 cases of those adenocarcinoma underwent EGFR test, and among these 148, 56 cases showed EGFR mutation, which was 38%. Among these, the different exons, the exon 19 was the most commonly mutated, we found that, and after that, the exon 21 was the second most mutated exon. Exon 18, there were no deletion of, no mutation in the exon 18, and we found one interesting case where 19 and 20 both were mutated. So this is 5 years timeline data, which shows again the EGFR mutation. You can see the middle green graph, the test of mutation, mutational analysis of EGFR has increased, and in the middle where there was corona time, and this has drastically increased, but again, it has simultaneously increased. The total male to female ratio of the whole lung adenocarcinoma showed that male had the more lung cancers, but interestingly, as you can see the other graph here, the EGFR mutation was more in female rather than in male. And our youngest patient was 16 years female, and our average age group ranged from 50 to 69 years of age group. Yes, we ultimately had a small data of Nepal, and we saw that central Nepal had the most mutation in EGFR, followed by western Nepal, and then eastern Nepal. According to the government of Nepal, the ethnicity has been divided in this way. So I categorized them, and the Newars were the most Newars community had the most EGFR mutation, followed by Brahman and Kshetri, Janajati, Tarai Madesi, and Dalit. Discussion. I have categorized this table into 3 colors. The upper one are the pink, the Western and the European countries, who showed EGFR mutation rate not more than 20 to 25%. The blue one are the data of Asian countries, China, India, and Pakistan, whose EGFR mutation was relatively high, and it was almost over 25%. And in red, it's our study, which showed 38% of EGFR mutation. Different studies, again, showed the different exons which were mutated, and they also found that exon 19 was the most commonly mutated gene, followed by the exon 21 and then 20, which was very much similar to our study. Age group, the East Asian origin, the mean age was 50 to 69, and we had the similar finding. This is the comparison between male to female ratio, where the East Asian origin had 80% of female and very less percent of male, and we also had female more in our study with EGFR mutation. So EGFR mutation were found similar in Asian population when compared to our study. However, the Western countries had a relatively low percentage of EGFR mutation. Newars and Brahman Kshetris were the most common population with mutation in Nepal. And also, looking at the geography, most of the lung cancer patients were from central part of the Nepal, followed by west and then east. The biasness here could be that this study was conducted in the center of Nepal, so it might be because of that we had so many patients from central Nepal. So I think more studies from far east and far western part of the Nepal is yet to be done. So conclusion, EGFR mutation was seen more in female with median age 67 and youngest being 16. EGFR mutation frequency was more than one third of cases. Most frequent mutations were observed in 19 and 21 exons. Thank you. EGFR mutation in Asian population and Nepalese population was very similar. Newars and Brahman Kshetris were the most common population with EGFR mutation, and most of the lung cancer patients were from central part of the Nepal. So to our knowledge, I think this is the first report in Nepalese population about EGFR mutation. And my 3 recommendations, lastly, this is the last slide. 3 recommendations. A detailed study in larger population is warranted to know about the actual prevalence of EGFR mutation and its types in Nepalese lung cancer patient. Studies of larger areas in far east and west part of the Nepal is mandatory to know the actual EGFR mutation, and correlation of EGFR mutation with smoking and food habits and other parameters can be studied to find out the actual cause of EGFR mutation in our context. Thank you.
Was there any history of lung cancer in that 16-year-old girl?
I did not go very detailed into her genetic family history, but I have no idea. I have to see that. She had lung cancer, but about her family, I'm not sure.
What about like EGFR mutation is found to be more common in adenocarcinomas occurring in non-smokers?
Yes, that is another parameter that I'm planning to include in my next study, to include smoking also. But as we see globally in other studies, it was found that the Asian female, non-smokers had more EGFR.
Okay, thank you.
Thank you,
Any more
ma'am.
questions, please? If no, thank you very much for a nice presentation.
Thank you, ma'am.
Now I would like to invite next speaker, is very famous medical oncologist, Dr. Arun Sai. He is assistant professor working at present in Patan Academy of Health Sciences. He is also author of 3 medical books and has few publications as well. And he has presented several papers in different national and international conferences. And his special interest is in pulmonary oncology. Welcome, Dr. Arun Sai.
Thank you, ma'am, for very nice presentation. Honorable chairpersons, seniors, colleagues, juniors, good afternoon. Today, I'll be talking about the lung tumor. What is our oncologist perspective? So I have no financial disclosure. So whenever I am invited to speak on any cancer, and especially lung cancer, I get really very emotional. You know why I get very emotional is because in Nepal, 6 people die each day due to lung cancer. And if we compare with the global data, in 2020, almost 2,500 patients were diagnosed with a lung cancer. And if you see the mortality rate, death rates, almost 2,200 died in the same year. You can see that more than 80% people are dying on the same year they were diagnosed. And if we see the world's data, we can see that 22 lakhs were almost diagnosed in 2020, and 17 lakhs were died in the same year. So this rate is also not less compared with Nepal. So we need to find out why this is happening. Maybe it is because of our lack of understanding about the disease, or maybe awareness, or maybe because of smoking is increasing. There might be the different reason, and this topic can be in discussion for next time. But today we'll talk about how we are treating cancer patients in Nepal. So in 2078, the lung cancer cases in Patan Hospital, we had almost 64 lung cancer patients. Out of them, 31% were female and 69% were male. So according to the histopathology, most of them were adenocarcinoma, followed by squamous cell, and adenosquamous and small cell carcinoma. But very interestingly, we in our literature read about the large cell carcinoma. But I have not seen, since my last 5 years I'm practicing as a medical oncologist, I have not seen even single case of large cell carcinoma. I don't know why is it, but it's mentioned in the literature. And another thing is like I mentioned in the earlier, we have a collaboration with the Max Foundation. That means Patan Hospital has a collaboration with the Max Foundation. And those patients who have a ALK positive, they get a targeted drug that is called crizotinib, lorlatinib, alectinib. Out of this drug, crizotinib and lorlatinib is free in Patan. So all the patients who are diagnosed all over the Nepal, they come to Patan Hospital. And since 2016, we have almost 68 ALK positive lung cancer patients, all stage 4. Out of them, 35 are active cases. And you can see in 2022, we have 17 cases. So maybe this number is increasing, and 2023, it's not only 3 or 4 months, we already have 7 cases. Maybe because of the awareness and maybe because of this diagnostic test, we are getting now more patients. And there are few patients who had progressed to the crizotinib. So those patients, they get the lorlatinib. And this drug is very, very expensive. For 1 month, it costs around 4 lakh to 8 lakh. And we have almost 12 active cases. That means who are surviving and they're taking. This is the Max Foundation, collaboration. And beside lung cancer, we also get the medicine for the CML, GIST, and kidney cancer. So last month only, we organized a patient support group meeting, and you see all these, except 2 or 3 of us, all of them are patients. So I would request again, if you have any known person who are diagnosed with the CML, GIST, ALK or ROS1 positive lung cancer or kidney cancer, please send them to Patan. And they are getting free of cost for all their life. So let's go into the topic, right? Lung tumor, how we medical oncologists proceed. I always say that any cancer is not treated by only oncologists. We need a multidisciplinary tumor board. And an ideal MDT should include medical oncologist, radiation oncologist, a pulmonologist, or trained in pulmonology, specialist CTVS surgeon or lung surgeon, and very important, a pathologist, that is molecular pathologist or biologist and diagnostic radiologist. So based on this, if we have any case of lung cancer, how we share our responsibility. I want to share one case. We had a 61-year-old gentleman with no comorbidities and no smoking history. Initially presented with complaints of cough on and off since 2 months, headache, nausea, and vomiting on and off since 15 days, and no history of tuberculosis. And they did a chest X-ray initial, and there was they found the mass lesion. So it was suspicious of the lung cancer, so they directly went for the PET-CT scan. And whole body PET-CT scan showed that there was a mass size 5 into 3 into 5 into 6.16 centimeter in the left lung apical segment, medial vessel segment, sub-centimeter size lymph node present in left hilar region, and abdomen was normal. This is the PET-CT scan report. And then we did the MRI brain, and well-defined solitary lesion, 20 millimeter in the right hemisphere, parasagittal with mass effect was correlated with the confirmed with MR, and we again had a tumor board meeting, and they said like the brain metastasis. And then we proceed with the biopsy of the lung mass. It shows that moderately different adenocarcinoma. We went for the driver mutation, and it was like ALK positive. And then the final diagnosis was the TNM stage 4. So I want to ask one thing, like if some patient is diagnosed with a lung cancer, with a brain mets, so what will be your approach? Will you first hand send for a treatment or not? यदि तपाईको परिवारमा कसैलाई पक्सो क्यान्सर भएको छ, एक्सटेन्सिभ मेटास्टासिस टाउकोसम्म गएको छ भनेपछि तपाईले के सल्लाह दिनुहुन्छ? अहिलेसम्म ट्रिट गर्ने भन्नुहुन्छ कि नगर्ने भन्नुहुन्छ? गर्ने भन्छौ. यदि यो पेशेन्ट if it was 80 years or 90 years, what would be your recommendation? Would it change or same? Same हुन्थ्यो. What if the patient age was 40? So I suppose that someone is saying yes, someone is no, and there is a mixed result. But I want to show our real world experience.
नमस्ते, मेरो नाम नवीन तन्त्रकार, मेरो घर चाहिँ क्षेत्रपाटी टकको काठमाडौँ. विगत 8 वर्षदेखि चाहिँ मलाई चाहिँ क्यान्सर, फोक्सोको क्यान्सर भएको छ. अहिले चाहिँ म यसको उपचार चाहिँ पाटन हस्पिटलमा गरिरहेको छु. यसको यो रोगको उपचार चाहिँ अहिले नेपालमै राम्रोसँग भइरहेछ.
नमस्कार, म देवेन्द्र प्रसाद पौडेल. हाल मेरो बसोबास भरतपुर महानगरपालिका वडा नम्बर 5 प्रेम बस्तीमा चाहिँ छु र म विगत 6 वर्षदेखि मेरो फोक्सोको चाहिँ क्यान्सर हो. 4th स्टेजको क्यान्सर भइकन पनि म अहिलेसम्म रेगुलर नेपालबाटै पाटन हस्पिटलबाट चाहिँ निःशुल्क रूपमा चाहिँ औषधि लिएर मैले यो रोगमाथि धेरै हदसम्म चाहिँ विजय गएको थिएँ.
So the first patient is surviving with brain mets in the last 5 years. And he was started with the crizotinib. He took for almost 4 years. Then the disease progressed, and now he has a brain mets. And we have giving him lorlatinib since last 5 years, and he's doing very good. He comes by himself to collect the medicine. And another patient is stage 4, but he doesn't have the lung mets. He had a liver mets, but now it is all. There is remission of all this, and he's continually taking. And we have many patients with this. So there is a hope. So I would say, like, even if it is a brain mets, stage 4, please send for the treatment. So how do we treat the lung cancer in 2023? So lung cancer, we have a small cell lung cancer and non-small cell lung cancer. In non-small cell lung cancer, squamous and non-squamous. In non-squamous, large cell and adenocarcinoma. But interestingly, I have not received any case of large cell carcinoma. I don't know why. So how do we treat the small cell lung cancer? 12 to 15% of total new lung diagnosis is of the small cell lung cancer. And small cell lung cancer has a very strong association with the tobacco. And it is characterized by its rapid growth, high response rates of both chemotherapy and radiotherapy in the first line. But 70% of cases are advanced at the time of diagnosis and poor long-term survival rates. And how do we do the staging evaluation of the small cell lung cancer? It is a little bit different compared with other cancer and non-small cell lung cancer. We had a veteran lung cancer classification. In this, we don't say about stage 1, stage 2, or stage 3. Instead, we say the limited stage and the extensive stage, and we treat accordingly. So if it is a limited stage, and if luckily if we diagnose in an early stage, we send all the patient for the surgery. And after surgery, every patient must get the adjuvant chemotherapy or palliative chemotherapy. So, small cell lung cancer, till now, only platinum-based chemotherapy plus etoposide has been the preferred first line since last 20 years. There are so many studies going on, but they don't show any benefit in progression-free survival or overall survival. And in addition, there is no targeted treatment has till now demonstrated any activity in small cell lung cancer. So, small cell lung cancer prognosis is within 1 year, and the chemotherapy drug available and better is only cisplatin and etoposide, and it is very cheaper, maybe 1,000 or 2,000 per cycle. What about the non-small cell lung cancer? So much research and all this understanding and all this investment are going in the non-small cell lung cancer. So whenever the patient is diagnosed with non-small cell cancer, then we do what we do first is staging evaluation. In staging evaluation, we do the locally advanced and then advanced. So stage 1 to up to 3A, we call it early stage or locally advanced. So stage 1 to 3A, most of the patient go for a surgery. And why we need to do the staging evaluation is because if you see the overall survival, if the patient is diagnosed in stage 1A, their 60-month survival will be 92%. Whereas if they are diagnosed in stage 4B, nobody survives for the 60 months or 5 years. So this is the reason we need to find out the cancer in an early stage. So if it is a stage 1 to 2, surgery should be offered to all patients. And after surgery, up to 2A, if it is R0 resection, we can keep them in observation. They don't need any adjuvant chemotherapy. But beside them, everyone needs the adjuvant chemotherapy. And all this meta-analysis shows that those patients who got adjuvant chemotherapy compared with those did not get chemotherapy had a better overall survival compared with those who did not get the chemotherapy. So this is the reason we need to give chemotherapy to all the patients who are resected. So what about the stage 3? All stage 3 lung cancer is not possible to resect or do surgery. So it is divided into 2 groups. Those who can do the resection, we have to send for the surgery. And those who cannot be resected, for them we again sit for the tumor board. So for unresectable non-small cell lung cancer stage 3, we give a concurrent chemo and radiotherapy is the treatment of choice. And for those patients who cannot go for a surgery, maybe comorbidities, age, for them we can go for a concurrent chemoradiotherapy or first chemo, then followed by radiotherapy. But optimal chemotherapy to be combined with radiation should be based on the cisplatin based. And how much chemotherapy or how many cycles we give? 2 to 4 cycles. So we all have heard about the immunotherapy, targeted therapy, and there is so much hype about all these new drugs. These are very expensive. So whether these drugs are useful for locally advanced lung cancer or not, there are studies going on, and there was one trial, it was in 2019, so they did with the TK, first generation tyrosine kinase inhibitor for those who have EGFR mutation. In those patients who are EGFR mutation positive, if we give a gefitinib, it's an oral drug, it shows that with chemo, it has a better progression-free survival and overall survival. What about the other drug? There is again third generation TKI, it's called osimertinib. If we give this osimertinib in a stage 1 to stage 3 lung cancer patient, their overall survival and disease-free survival improved dramatically for almost 4 years. So because of this reason, now if any patient with stage 2, 3, if they are EGFR mutation positive, we go with this osimertinib drug. And what about the immunotherapy or checkpoint inhibitors? There are several studies going on this, and these 2 or 3 studies have shown that like Keynote 091, IM Power 010, BR31 has shown that if we give 1 year of immunotherapy to those patients who are resected or not able to resection, they have a better disease-free survival and overall survival. Because of this reason, now NCCN guidelines has also included this immunotherapy for the treatment of this locally advanced lung cancer. So in conclusion, For locally advanced lung cancer, we can use surgery, chemotherapy, radiotherapy, immunotherapy, or all modalities of the cancer treatment. But there are some cases, some scenario where after surgery, we don't need any chemotherapy or any adjuvant treatment. That is for the stage 1A, those who are resected as R0 resection, or another one is stage 1B, that is T2A, and otherwise is stage T2B. For this lung cancer patient, if the surgery is R0, then they don't need any adjuvant treatment. So what about the stage 4 non-small cell lung cancer? So when it comes about the stage 4, we all have one thing in our mind, that it is all about death and dying, a battle with stage 4 lung cancer. So how do we sequence our treatment? Whenever it is stage 4, again we divide into non-squamous and squamous. If the non-squamous or squamous with PD-L1 expression less than 1% and all these driver mutation negative, for them chemotherapy is the backbone. We don't have any other option. We have to give chemotherapy. And what chemotherapy we give? There are several chemotherapy, but all chemotherapy have the same overall survival and overall progression-free survival. This is the reason we give 3 to 4 cycles of the chemotherapy. So if there is a PD-L1 expression more than 1% or more than 50%, then in those patients, immunotherapy is the front line. We don't give the chemotherapy, or sometimes if PD-L1 is less than 50, we give them chemotherapy with immunotherapy. But before heading into the immunotherapy, if we do not remember these two great scientists who discovered the immunotherapy and they got the Nobel Prize in 2018, it will be unfair. So with in their name, like, and another very interesting study, like this is the Jimmy Carter, who was diagnosed with the melanoma at the age of 90, and he was treated with the immunotherapy, and he also had 4 brain mets, and now he is a cancer-free. So since then, immunotherapy has brought up very hype, but I don't know whether it is a miracle or just science, because we have tried so many patients, and very few patients are cancer-free, except this gentleman. So how do we decide which immunotherapy to give? So it all depends on the PD-L1 expression. The higher the expression, the better the immunotherapy response. So if initially it was the 50% cutoff, if PD-L1 expression is more than 50%, we used to give chemotherapy. But now, more than 1%, you can also start the immunotherapy with chemotherapy. So you can see this phase 3 trial, and this all Kaplan-Meier shows that the more the PD-L1 expression, better the result of the response with the immunotherapy. And where chemo is not needed, if PD-L1 expression is more than 50%, we can only give the immunotherapy. We don't need a chemotherapy. So what about those patients whose PD-L1 expression is negative, and they are the non-squamous adenocarcinoma, and they have a driver mutation positive, that is EGFR, ALK. There are so many driver mutation, also we call oncogene addiction. So there are so many driver alteration found in non-small cell lung cancer. We can say in adenocarcinoma, we find 50 to 60%. In squamous cell carcinoma, 20 to 30%. That's what we say now, even in squamous or adenocarcinoma, doesn't matter. Please send the driver mutation. But in Nepal, if we send all the driver mutation and we don't have the drug, what is the use? So what are the common driver mutation and what are the drug available in Nepal? Is that there are 4. That is, the one is the ALK translocation, or BRAF B600 mutation, EGFR, or ROS1. And for the ALK translocation and ROS1 translocation, these drugs are very expensive, 80,000 to 8 lakhs, but these drugs are luckily free in Patan Hospital. So again, I repeat that if you have any known patient with this mutation, please send them to Patan. So there are some trials which shows that if there's a patient is an oncogene or EGFR mutation positive, and they compare with the tyrosine kinase inhibitor, that gefitinib is the first line, with the chemotherapy. You can see in the left side, you can see here, because this has the EGFR positive, here it shows that gefitinib has the better overall survival compared with the chemotherapy. Whereas in the EGFR negative patient, this chemotherapy has a better overall survival compared with the gefitinib. That's why sometimes we know that we have heard about this TKI, and we don't do the driver mutation test and we give these drugs. Please don't do that, because if you don't know the driver mutation, don't prescribe these TKIs. And there is another drug. Sometimes there are some EGFR is positive, but this first generation TKIs like gefitinib, arlotinib, they don't work. Why? Because there is another mutation. It's called T79 mutation. I think most of our these things is not done in Nepal. So some have recently started. So if we have not seen this T79 mutation, in that case we can give osimertinib in the first line without trying first or second generation TKIs. And what about that ALK positive? It shows that those patients who have ALK positive and who received the crizotinib had better overall survival compared with those patients who received only chemotherapy. This is the reason we can give now. We should, instead of giving chemotherapy, we should give the TKI, that is crizotinib, and it is free. So if we see the landscape, since from the 2004 to 2020, now almost 30 plus immunotherapy, targeted therapy has arrived. So we have so much option, and in what mutation positive, what drug is available. But again, I will repeat that all these drugs are not available here, but few drugs are available. But before sending all these tests, we need to know, or we need to find out whether these drugs are available or not, whether our patient can afford that drug or not. So if we keep this thing in mind, I think it will be a always peaceful situation. So to take home message is that in lung cancer, teamwork makes the dream work, especially MDT, multidisciplinary tumor board. So always, it's not about oncologists, it's not about only surgeon, or it's not about only radiation oncologists. We all need team, including pathologists and the radiologist. And not all patients, even I talked about so much hi-fi things, there are so many discoveries, but not all patients respond to and benefit from this treatment. So we need to enrich the treatment population for the benefit. And another important thing is like immunotherapy, this targeted therapy has some side effects as well. So before starting, we have to consult or counsel the patients about the side effects as well, or the toxicities of this drug. But having said that, so much discoveries, but we need to keep in one thing in mind, that lung cancer awareness and education is paramount. And most important thing we can do to prevent lung cancer is to not start smoking. And if we smoke, please quit smoking. And again, we have to avoid the second-hand smoke. So before concluding my presentation, I think you all have one thing in your mind, that why this drug costs so much. And should we go with the innovation, or we have to find the best balance between the cost and science? I think in the next election, we have to talk about why our drugs cost so much, because our cancer patients are also very important. So thank you very much once again, and again, I would advocate for the teamwork.
Thank you, Dr. Arun, for nice presentation. So I have one answer to your question, why we are not having large cell carcinoma. That is the diagnosis we make on resected specimen, not on small biopsy. And also on resected specimen, after doing all the tests, if it is negative for adenocarcinoma, squamous cell carcinoma, small cell carcinoma, by ISC and also electron microscopically, sometimes it is done in Japan, then only we make the diagnosis of large cell carcinoma. And most of the cases that we diagnose here, they are not resectable. Only 5 to 10% cases are resectable. That's why we are not getting the cases of large cell carcinoma.
Thank you, ma'am. I think this is the best platform to get this answer. Thank you.
If there are any questions to Dr. Arun? If not, thank you very much, Dr. Arun, for nice presentation. Now we conclude our session.
Thank you all the delegates for your enlightening presentations. Now I would like to call on stage Dr. Geeta Sayami and Dr. Abhimanyu Jha to provide certificate of appreciation to keynote speakers. I would like to invite Dr. Krishna Kumar Mahajan, Dr. Banita Gurung, and Dr. Arun Sai on the stage. म्याम एप्रिसिएसन मात्र हो। Dr. Krishna Kumar Maharjan, Dr. Banita Gurung, Dr. Arun Sahi, please be on stage. Now I would like to call on stage Dr. Amarnath Thakur to provide token of love to the chairpersons.
Good afternoon, ladies and gentlemen. Now we move towards the next final quarter of this session. I am Dr. Rubina Roy, third-year resident from KIST Hospital, and I will be your MC further. Before inviting our next speakers, I would like to welcome the chairpersons of this session, Dr. Seema B. Pradhan. She is the consultant pathologist in Advanced Pathology Lab, Birtamor, Jhapa, Nepal, and Dr. Anil Dev Panta. He is Associate Professor at Tribhuvan University, Maharajganj Medical Campus, Kathmandu, Nepal. Please, sir and ma'am, please be seated on your left side. For prize category, our judges will be Professor Dr. Rajesh Pantha. He is a consultant pathologist at Upendra Devkota Memorial National Institute of Neurological and Allied Sciences and consultant pathologist at Nepal Medicity Hospital. And Professor Dr. Amarnath Thakur. He is the chairman of Mangalam Diagnostic Birganj and ex-principal and head of Department of Pathology at National Medical College, Birganj. Thank you, sir. Proceeding ahead now, this session will be the resident session mostly. The session has much to offer, and I hope it will keep you all engaged. The session, our fellow residents from various medical colleges will be speaking up on several interesting case reports. Thank you.
Good afternoon. Now, since we are beginning this session, I'd like to invite all the residents to come forward and cheer your fellow students. First, I'd like to invite Dr. Jenish from Manipal Medical College, and she'll be talking about efficacy of cytopathology and its correlation with histopathology in pulmonary lesions. This is an original article, and she's allotted 10 minutes for the presentations. 8.5 for the presentation and 1.5 for the discussions for the topic. And I'd like to remind that this is a presentation that will be judged on, and the judging will be based on your topic, the way you present, and the time efficiency of the use of the time during the presentation. Thank you.
Good afternoon and namaste everyone. I'm Dr. Janice Chatkuli, second year resident from Manipal College of Medical Sciences, and today I'll be talking on efficacy of cytopathology and its correlation with histopathology in pulmonary lesions. Shall I start? Okay. I'd like to start with my topic. These are the contents of my today's presentation. First of all, I'd like to start with the introduction. Neoplastic and non-neoplastic pulmonary lesions account for a majority of morbidity and mortality, not only in our country, Nepal, but also worldwide. Currently, lung cancer is one of the most frequent cause of morbidity and mortality worldwide, like said by our respected seniors in the previous panel. Cytology plays an important role in the initial evaluation and diagnosis of pulmonary diseases, and these are significant where biopsy procedure is difficult or impossible to perform. The aims and objective of our study was to study the cytopathological features of pulmonary lesions and correlate the findings with the histopathological diagnosis. Coming on to the methodology, a prospective observational study was conducted in Department of Pathology of Manipal Teaching Hospital for a period of 13 months, beginning from October 2021 to December 2022, and 155 cases of cytology samples were taken in our study. Considering sputum, bronchoalveolar lavage, pleural fluid, and fine needle aspiration cytology, which was done guided, either CT or USC guided, and the stains used for cytology was Leishman and Papanicolaou stain as routine stains, and for histopathology, hematoxylin and eosin stain was used, and special stains such as Ziehl-Neelsen staining, PAS staining, and GIMSA stains were used whenever required. All cytology samples and corresponding biopsy specimen, whenever available, were included in our study, and unlabeled specimens and poorly fixed biopsy samples were discarded. Coming on to the results, the age range of the patients included in our study varied from 13 years to 95 years, with the mean age being 60.9 years. Male to female ratio was 1.31:1, with cough being the most frequent chief complaint, followed by fever and chest pain. However, patients had multiple complaints simultaneously. This table depicts a summary of cytopathological diagnosis. 35 cases were positive for malignancy, among which 24 were diagnosed in fine needle aspiration cytology, 7 were diagnosed in bronchoalveolar lavage, and 4 in pleural fluid. 9 cases were suspicious for malignancy, 13 cases were benign of infectious category, and 94 cases were from benign, diagnosed as negative for malignancy in cytology, and 4 cases were inadequate for definite opinion. Again, this table depicts a summary of cytopathological diagnosis, categorizing them into various specific lesions. Adenocarcinoma, like previous talks, was the most common malignancy found in the found in our study, followed by squamous cell carcinoma, and then small cell carcinoma and metastatic carcinoma were 4 each cases. Now coming into the summary of histopathological diagnosis, 33 samples were available for histopathological and cytological correlations, among which 23 cases were malignants, 10 cases each of adenocarcinoma and squamous cell carcinoma was proven, and 3 cases were of small cell carcinoma. 1 case of low-grade squamous dysplasia was diagnosed in biopsy, and 1 case of solitary fibrous tumor was diagnosed, and another case of mucormycosis was confirmed to be in histopathological diagnosis. 3 samples had normal histology, and 4 cases were inadequate for definite opinion. Now coming on to the correlation between the cytological and histopathological diagnosis. Among the 14 cases diagnosed as adenocarcinoma in cytology, 7 cases were proven to be adenocarcinoma, whereas sample was not available for remaining 7 cases. Among the 12 cases diagnosed as squamous cell carcinoma, 9 cases were found to be squamous cell carcinoma as well. Among the 4 cases of small cell carcinoma, 2 cases were proven to be small cell carcinoma in histopathology. 1 each case of adenocarcinoma, squamous cell carcinoma, and small cell carcinoma was diagnosed, which was given as suspicious for malignant lesions in cytology. 1 case which was suspected to be mucormycosis was proven to be mucormycosis in histopathology. The sensitivity of our study was 88%, the specificity was 66.67%, positive predictive value was 95%, whereas the negative predictive value was only 40%. The cytology and histopathology concordance was found in 85.7%. In this figure, we can see clusters of malignant tumor cells. This was diagnosed as adenocarcinoma, and in the right-hand side, we can see the histopathological sections where we can see adenocarcinoma with areas of necrosis. This is a case of metastatic adenocarcinoma diagnosed in pleural fluid. Here we can see pleomorphic tumor cells arranged in clusters. This figure shows squamous cell carcinoma diagnosed in FNAC and squamous cell carcinoma in histopathology. This is a figure of small cell carcinoma where we can see prominent nuclear molding in these tumor cells with scant cytoplasm and absence of nucleoli. And we can appreciate this small cell carcinoma in the histopathological sections in the right-hand side. This is a case of aspergilloma where we can see acute angle branching septate hyphae with areas of patchy necrosis. This is a case of lung abscess in FNAC. Now coming on to the discussion. This is a comparative analysis of present study with similar studies. The number of samples were almost equal in other studies, except from Gildial et al., where there were high number of samples. The cytology specimen used were almost similar, except for additional bronchial wash and bronchial bus sample. Male to female ratio is comparable to other studies, except for the study conducted in Russia by Zambas et al. The inadequacy rate in our study is lower as compared to the other studies. Negative for malignancy diagnosis is higher in our cases, similar to the study by Gildial et al. This could be because the majority of sample in our study was cytological pleural fluid samples. Then specific benign lesions diagnosis are almost comparable to other studies. Suspicious for malignancy diagnosis was lesser as compared to the study by Chandra et al., whereas it was higher as compared to the study by Zambas and Gildial. And positive for malignancy was higher as compared to the study by Gildial et al., but however it was lower as compared to the study conducted in Nepal by Shrestha M et al., Zambas et al., and Chandra et al. Like our ma'am, Banita ma'am and Arun sir said previously, our study also has adenocarcinoma to be the most frequent malignant lesions. The sensitivity is comparable to other studies. Specificity is lower as compared to the other study by Zambas. Positive predictive value are almost comparable, and negative predictive value is lesser in our study, and the concordance rate matches to the study by Giltial et al. Coming on to the conclusion of my topic, cytological techniques are relatively cheaper, easier, and safer method for the initial modality, for initial investigation of the patient and categorization of the pulmonary lesions, and they help in the prompt management of the patient. However, the diagnostic efficacy of cytology can be evaluated by establishing the findings and correlating the findings with histopathology. Thank you for your time.
Thank you, Janice. Dr. Janice, now I will open the floor for discussions. You can ask 1 or 2 questions only to be limited. No questions? So we move on to the next presenter, who is She's Dr. Elina Basnet from Tribhuvan University Teaching Hospital, and she's presenting a rare case of solid pseudopapillary neoplasm extending to the duodenum. Your time is 3.5 minutes for the presentation and 1.5 minutes for 4 minutes for the presentation and 1 minute for the discussion.
Good afternoon, everyone. I am Dr. Elina Basnet, resident from Tribhuvan University Teaching Hospital. My case of presentation is a rare case of solid pseudopapillary neoplasm extending to the duodenum. So going through the introduction. So solid pseudopapillary neoplasm of pancreas, it is a rare neoplasm which has a low malignant potential and lacks specific pancreatic epithelial differentiation, and it commonly occurs in adolescent girls and young women, which represents 1 to 2% of total pancreatic neoplasm. Histologically, these tumors are solid with pseudopapillary and Good afternoon, everyone. I am Dr. Elina Basnet, a resident from Institute of Medicine, Tribhuvan University Teaching Hospital. Topic of my presentation is a rare case of solid pseudopapillary neoplasm extending to the duodenum. So going through the introduction, solid pseudopapillary neoplasm of pancreas, it is a rare neoplasm of pancreas which has a low malignant potential and lacks specific epithelial pancreatic differentiation. It commonly occurs in adolescent girls and young women and represents 1 to 2% of total pancreatic neoplasm. Histologically, these tumors are solid with pseudopapillary and pseudocystic components and are rich in microvasculature, and it is most commonly located in body and tail of pancreas. So here I present you a case of a 26-year-old female who presented in emergency department of TUTS complaining of abdominal discomfort and pain. She had no any prior medical history. So subsequently, CT scan was done and it showed a mass in head of pancreas. So patient underwent pancreatoduodenectomy and the specimen was received in our department. So on gross examination, 2.5 centimeter solid mass was present in head of pancreas. However, duodenum, ampulla and common bile duct were free of tumor and margins were negative. So this is a low power view of a tumor in pancreas which are circumscribed, and this tumor, as we can see, are arranged predominantly in nest, and these tumors are monomorphic, having round nucleus, inconspicuous nucleoli, fine chromatin, and have abundant vacuolated cytoplasm. So the tumor with the same morphology are seen infiltrating the duodenum up to the duodenal mucosa. So this is a high-power view of the tumor cells having a round nucleus, fine chromatin, inconspicuous nuclei, and abundant amount of vacuolated cytoplasm. These tumors are seen in the duodenum as well. So after that, as we wanted to exclude neuroendocrine neoplasm, so we performed immunohistochemistry, and the tumor cell was positive for beta-catenin, and it showed paranuclear dot-like positive for CD99, and the tumor was negative for synaptophysin and chromogranin. So on the basis of immunohistochemistry, we diagnosed this case as solid pseudopapillary neoplasm. So coming to the conclusion, solid pseudopapillary neoplasm, it is a rare neoplasm, pancreatic neoplasm, and it's so peculiar morphologic features, but sometimes the differential diagnosis with other pancreatic neoplasm can be challenging task. So a diagnosis can be made through the basis of histopathology, immunohistochemistry, and correlating it with history and imaging. And as in our case, rarely this neoplasm may directly infiltrate the duodenum, and its presence in the duodenum may identify the worst prognosis. These are my references. Thank you.
Thank you, Dr. Elena. Any questions?
Okay, thank you, Elena.
Thank you.
Okay. So we move on to the next presenter, Dr. Madhuri Shah. She's from Nobel College, and she's doing a case of high-grade serous carcinoma with variable patterns.
Good afternoon, everyone. I am Madhuri Shah, resident in Nobel Medical College. I am going to present a case report. First slide. I'm going to present a case report of high-grade serous carcinoma of the ovary with a solid endometrial-like and transitional pattern. Firstly, starting with the case history, there was 59 years postmenopausal female presented with lower abdominal pain since 1 month and the fullness of the abdomen. On the examination, abdomen was soft, non-tender, distended, and the per-vaginal examination shows bilateral fornix was free. On the imaging, USG abdomen shows mixed echogenic lesion with a left ovary with multiple septations, and the CT of abdomen shows a thin walled multilocated septate cystic mass and with enhancing mural nodule, and the solid component was aborting the left external and internal iliac arteries. These are some tumor markers. Among these, C125 was slightly increased, and the imprint cytology was malignant. And the staging surgery are performed, and the sample sent for the histopathological examination was total abdominal hysterectomy with bilateral sulfingo-oophorectomy specimen with right and left iliac lymph node, omentum, and appendix. And the grossly, the ovarian cyst was well encapsulated, soft, and the cut section shows area of cystic area and solid as well. And the solid area was pale gray to white in color with presence of papillary excrescences and the focal area of necrosis. On microscopy, the tumor cells, the bizarre tumor cells are arranged in solid morphology and endometrial-like transitional pattern, and there was increased tumor infiltrating lymphocytes and the areas of necrosis. On the basis of the morphology, the differential diagnosis of the high-grade serous carcinoma and the endometrioid carcinoma ovary was rendered. And in immunohistochemistry, the T53 was moderately positive and the WT1 was focally positive. And the final diagnosis was high-grade serous carcinoma of ovary with solid endometrial-like transitional pattern. on discussion, the most common mutation in the high-grade serous carcinoma is the TP53, followed by BRCA1, BRCA2, and ATM. And the germline mutation in the BRCA1 and the BRCA2 accounts for the majority of the inherited case of high-grade serous carcinoma of ovary with SET variant. And the BRCA1 inactivation may be associated with the relative chemosensitive, and the prognosis is good in the presence of, compared to the BRCA1 intact function. And the innovator to the PARP therapy, which are the more beneficial to the patient with tumor which have the deficient of BRCA1 and BRCA2 mutation. On conclusion, the SET variant is a special subtype of serous carcinomas, and it is important to diagnose based on the histology and the supported by the ISC, and the targeted treatment can be done. In high-grade serous carcinoma showing the association with the SET variant has tend to the survival, good survival. Thank you.
Okay, thank you, Dr. Madhuri, for the presentation. Any questions? We have some time for questions right now.
So why this case was selected to present here in this forum? What is the rarity in this case?
Thank you, sir. Because the SET variant of the high-grade serous carcinoma is associated with BRCA mutations, and the BRCA mutations patients have a good prognosis. And so we can inform them, we can suggest them to have a genetic testing for the BRCA mutations. No, sir. This diagnosis is based on the morphology and as well as help of ISC. And then we can, further next test will be the genetic testing in this patient after diagnosis of this SET variant. No, sorry, sir. This is a type of a variant of high-grade serous carcinoma, and among the variant, this is the have a good prognosis. But this SET variant has a good prognosis.
This transitional pattern, this pattern
Yes, sir. SET variant has a good prognosis. Yes, sir. Yes. Thank you, sir.
Yes, okay, next presenter is Dr. Om Jha from Shri Birendra Hospital. And
he is presenting on importance of clinico-pathological and radiological correlation in pulmonary sarcomatoid carcinoma with diverse presentation, a lesson to learn.
Good afternoon, everyone. I am Dr. Om Jha, pathology resident from Shri Birendra Hospital, NIHS, and my topic title is Importance of Clinico-Patho Radiological Correlation in Pulmonary Sarcomatoid Carcinoma with Diverse Presentation, a lesson to learn. So talking about patient history, patient was 63-year female, presented with swelling in right flank since 2 months and associated with pain. And initial USC finding of the lesion was reported as epidermal inclusion cyst, but for which we get excisional biopsy. And on biopsy, when we cut through the specimen, there was a single globular mass, and we cut through the mass, there was a homogeneous white area. Then it was not anything matching with epidermal inclusion cyst. At the time of at the time of biopsy itself, we have some sort of suspicion. So under microscopy, again, totally it was different from epidermal inclusion cyst. It was no more in the picture. In low power, we can see this the lesion was comprising a partially encapsulated tumor, which comprises of atypical cells that was infiltrating, arranged in diffuse sheets and was infiltrating the nearby adipose tissue. And on higher power, we can see these cells showed marked pleomorphism and had abundant, moderate amount of eosinophilic cytoplasm, high NC ratio, irregular nuclear membrane and vesicular to optically clear nucleus with prominent eosinophilic nucleoli, and few hyperchromatic cells were also noted. And we can see numerous binucleated and multinucleated tumor giant cell were seen with brisk amount of mitosis. So on the basis of the site of the tumor and these morphological findings, our provisional diagnosis were poorly differentiated carcinoma, sarcoma, lymphoma, and melanoma, for which we sent IHC panel. And on IHC, LCA and HMB45 was negative, so ruling out lymphoma and melanoma respectively, whereas these cells were positive for pancytokeratin and vimentin. So these narrowed down our diagnosis to both vimentin and pancytokeratin positive sarcomas and carcinoma. And excuse me. And for that, for that we sent IHC panel. Along with that, we also asked the radiologist to do re-scan of abdomen pelvis to rule out any genitourinary tumor. And on repeated USG of abdomen pelvis, it again showed a solid lesion that was infiltrating the psoas muscle, and this time the radiologist reported it as likely neoplastic lesion. And these are the CK and vimentin positive synovial sarcomas, and in our cases, the IHC marker for these tumors were negative, ruling these out of the diagnosis. Similarly, these are CK and vimentin positive carcinoma, but the IHC marker for renal cell carcinoma, endometrial adenocarcinoma, and biphasic mesothelial carcinoma turned to be negative, again ruling these out of diagnosis, whereas the tumor cells shows P40 positivity for positivity. So we only remained with the diagnosis left, that was sarcomatoid carcinoma. So considering the multiple tumor foci along with ISC findings, we suggested whole body CT scan to look for primary, as it could not be a primary, the subcutaneous lesion could not be the primary. So in whole body CT scan, we saw very large mass, that is in largest dimension, it was 12.8 centimeter mass in right lung, along with multiple subcentimetric masses in right lung. Along with that, there were multiple metastases and mediastinal lymph nodes along with that in left lung also we saw many metastatic deposits, and in liver it was also involving liver and omentum. So based on this, the radiologist reported it as likely sarcomatoid carcinoma with metastasis, pulmonary sarcomatoid carcinoma with metastasis. So, and talking to the patient retrospectively, the patient was a chronic chain smoker and had history of chronic cough with occasional hemoptysis. So again, further pointing towards favoring our diagnosis. So finally, metastasis from pulmonary sarcomatoid carcinoma was given. Talking about, and oncologists further these tests for targeted therapy, and the tumor cells turned to be positive for PDL1. And unfortunately, the patient, before starting the therapy, the patient was admitted in ICU, and the patient died a week after admission in the ICU, so we could not do much in the patient. So taking home message, these are few cases of pulmonary sarcomatoid carcinoma, and take home message is that there is a very importance of highlighting the importance of clinical history, diagnostic workup, and multidisciplinary effort in the diagnosis of such rare entities and management of such rare entities. Thank you.
Thank you, Dr. Om. Good presentations with good slides on immunostains. I'll open the floor for discussions. You can ask one or two questions. No questions? Then thank you. Next, I'd like to invite Dr. Rituraj Baral. He's from Triveni University Teaching Hospital, IIM, and he's presenting on recurrent multiple myeloma, presenting as plasmacytoma of the breast.
Namaste and good afternoon, all the delegates and respected chairpersons. I am Dr. Rituraj Baral. I am from second year pathology resident from Institute of Medicine Teaching Hospital. My topic of case report is recurrent multiple myeloma presenting as plasmacytoma of the breast, a rare entity. As we all know, multiple myeloma is a malignant monoclonal neoplasm of plasma cells, and that primarily involves the bone marrow, whereas extramedullary plasmacytoma are malignant proliferation of plasma cells in absence of bone involvement. And when it occurs in soft tissue, it usually involves the upper respiratory tract and upper GI or oral cavity. However, plasmacytoma of breast are very rare entities. We present you a case of 54-year-old female who presented with a breast lump. Core biopsy was performed and sent for histopathological examination in our department. Multiple cores were received, measuring 2 by 0.6 centimeter. This is the HE section on low power, showing multiple cores. Slightly going on to the high power, this shows infiltration of a tumor cell. The blue cells are all tumor cells. On next high power, we can see the tumor cells are arranged in sheaths, and some of them are arranged in single file pattern as well. High power of the same slide shows individual tumor cells, which shows tumor cells having eccentrically to centrally placed nucleus. Some of them even giving the plasmacytoid appearance as well. So initial diagnosis of invasive lobular carcinoma of breast was made on the basis of histomorphology, as the tumor cells were discohesive and plasmacytoid in appearance. However, upon detailed history taking, patient was found to have a previous history of multiple myeloma, which prompted us for the differential diagnosis of plasmacytoma as well. So digging up the history, we found out patient was a diagnosed case of multiple myeloma, and she underwent 4 cycles of chemotherapy 7 years back. Patient was virtually in remission until she presented with a breast lump. On immunohistochemistry, so to differentiate, we performed immunohistochemistry. CD138 shows diffuse positivity. Lambda restriction was observed. However, kappa staining, CPAN, CK staining, and CK7 staining was negative on the tumor cells. This is the summary of the immunohistochemistry. Above immunohistochemistry findings favors the diagnosis of plasmacytoma and ruled out the invasive lobular carcinoma of the breast. Patient was discharged after completing the first cycle of chemotherapy following the recurrence. So moving on to the discussion about the case. Extramedullary plasmacytoma may represent the initial manifestation of systemic multiple myeloma, or it may herald the recurrence of previously treated or questioned multiple myeloma. And extramedullary involvement in multiple myeloma is frequently linked to high-risk cytogenetic alteration, resistance to therapy, and a poor prognosis. So we should diagnose these promptly. So to conclude my case report, although rare, plasmacytoma should be considered in the differential diagnosis of breast masses whenever the morphology is suggestive and when there is history of multiple myeloma. And comprehensive examination, not only pathologists, but comprehensive examination involving radiologists, clinical history, histological, immunohistochemical, and cytogenetic test is required to distinguish breast plasmacytoma from other breast tumors. There were no conflicts of interest in the research. These are my references. Thank you.
Thank you, Dr. Rituraj. Any questions? Thank you.
Thank you, ma'am. Thanks, sir.
We now have Dr. Sharat Sharma, again from Tribhuvan University Teaching Hospital. He is presenting on clinical and pathological heterogeneity in diagnosis of moderately differentiated neuroendocrine carcinoma of the larynx.
Good afternoon, delegates. I am Dr. Sharat Sharma from Tribhuvan University, IIM. Today I am going to present a topic, clinical and pathological heterogeneity in diagnosis, moderately differentiated neuroendocrine carcinoma of larynx. I am going to start with the case detail. 70 years male, present with history of smoking, dryness of nasal cavity and snoring, and whereas there is no history of any odynophagia, dysphagia, and no lymph nodes. Now CT scan was done, which shows the polypoidal outgrowth around 5.2 mm in the lateral aspect of laryngeal surface of epiglottis, query malignant pathology. Now, biopsy was done from the lesion, and this is the section we get. We can see the tumor cells infiltrating into the stroma. Overlying epidermis is somehow, it looks normal. And this is the high power view of the tumor cells. These tumor cells exhibit moderate degree of nuclear pleomorphism, round shape with indistinct cytoplasmic border, and with few frequent intranuclear inclusions and mitosis. Now, on the basis of morphology and history, we have 4 differential diagnoses: poorly differentiated squamous cell carcinoma, glomus tumor, paraganglioma, and neuroendocrine tumor. Now, points favoring poorly differentiated squamous cell carcinoma is that the cells are arranged in nest. It is a most common cancer in case of smoker, 70 years male, presented the lesion in the larynx. So these cells are also arranged in nest and pleomorphic. So we have to think first differential diagnosis as squamous cell carcinoma in this lesion. We performed P63, it was negative, and CK5, CK6 was also negative, cytokeratin. So we rule out the first differential diagnosis. Now, points favoring the glomus tumor are, these cells are arranged around the vessels and have round shape with indistinct cell borders, arranged in the pseudo-rosette pattern. So we did SMA, it also turned out to be negative. We can see these vessels are positive for SMA. Now, frequent intranuclear inclusions, nesting and pseudo-rosette pattern with cells having abundant pale cytoplasm, this all favors paraganglioma. We did synaptophysin. Synaptophysin turned out to be positive. So we have now two possibility of diagnosis: paraganglioma as well as neuroendocrine tumor. Both are positive for synaptophysin as well as chromogranin. We did GATA3. GATA3 turned out to be negative. So paraganglioma is now less likely. Again, S100 is also negative. So paraganglioma is ruled out. So we favor the diagnosis neuroendocrine tumor. While doing the pan-cytokeratin marker, it was positive. So we favor to term is as neuroendocrine carcinoma. Ki67 was done. It was around 10 to 15%. So these are the summary of the immunohistochemical markers. These are the positive markers we can see, and these are the negative markers. And Ki67 around 14%. Now, according to WHO classification head and neck tumor 2017, neuroendocrine tumor is divided into well-differentiated, moderately, and poorly differentiated neuroendocrine carcinoma. Since our patient is a smoker, around 70 years age, size is around 5 mm, mitosis was more than 2 per 10 hyperfill, so it fit into the criteria moderately differentiated neuroendocrine carcinoma. Now our final diagnosis was moderately differentiated neuroendocrine carcinoma, atypical carcinoid tumor, grade 2. Now this neuroendocrine tumor could be either origin from hormone secreting cells or epithelial origin that undergo neuroendocrine differentiation. So those tumors that are of epithelial origin and undergoes neuroendocrine differentiation will term as neuroendocrine carcinoma. And conclusion, it is a rare tumor. And diagnosis is often delayed due to its clinical and pathological heterogeneity because of the overlapping morphological features. And if we miss any one of the immunohistochemical marker, then it will be very difficult to diagnose. So prognosis is moderate. 5-year survival is around 48% in this patient. This is a case report. This neuroendocrine carcinoma also we should think. Although squamous cell carcinoma is common, these are my references. Thank you.
Thank you, Dr. Sharad. Any questions?
I have no question, but I would like to congratulate you. You have done an excellent job. You have made a four or five maybe, huh? Four differential diagnosis. You have ruled out one by one, and you have come to a conclusion. You have a good job. You have done a good job. Thank you very much.
Thank you, sir.
Yes, that is very well done, sir. Okay, you can go.
Thanks.
Thank you. Next, we have Dr. Srijana Khati. She's from TUTH, and she'll be doing a presentation on renal leiomyosarcoma.
Good afternoon, everyone. I'm Dr. Srijana Khati, second-year pathology resident from IIM TUTH. Okay, I'm going to do a presentation on a rare case of renal leiomyosarcoma. A 31 years old female having complaints of right-sided flank pain since 2 months presented to emergency department of our hospital with a complaint of severe flank pain. She was managed and investigated accordingly. CCT abdomen pelvis showed a mass involving mid and lower pole of right kidney, which was extending up to the right psoas muscle, renal vein, and pelvic-ureteric junction. Based on this finding, provisional diagnosis of right renal cell carcinoma with inferior vena cava thrombus was made, and she underwent right radical nephrectomy with inferior vena cava thrombectomy. After the surgery, resected specimen of kidney was sent to our department, and this is how it was looking. On gross examination, 13 into 11.5 into 10.5 centimeter mass involving whole of the right kidney was seen. Mass was heterogeneous, showing gray-white area along with areas of hemorrhages and necrosis. Microscopically, the tumor was composed of spindle-shaped cells, mostly arranged in interlacing fascicles and bundles. These tumor cells had moderate amount of eosinophilic cytoplasm, oval to elongated nuclei, with vesicular chromatin and inconspicuous nucleoli. Mitotic figure was frequent, constituting of about 19 mitosis per 10 high power field. In this figure, mitosis was highlighted by the arrow. Area of necrosis was also seen. Based on these histomorphological features, we made 2 differential diagnoses: leiomyosarcoma and sarcomatide renal cell carcinoma. In spite of extensive regrossing, epithelial component of renal cell carcinoma was not seen, so our diagnosis was favoring more towards leiomyosarcoma. To confirm our diagnosis, we performed immunohistochemistry. On immunohistochemistry, tumor cells were positive for SMA. This is a high power view showing tumor cells with SMA positivity. Desmin was focally positive and cytokeratin was negative. Analyzing all the gross features, microscopic features, and immunohistochemistry finding, we made a final diagnosis of leiomyosarcoma with FNC-LCC grade 2. Talking about leiomyosarcoma of kidney, it is a very rare but aggressive tumor arising from the smooth muscle of intrarenal blood vessels, renal vessels or renal pelvis, constituting of about 1 to 2% of total renal malignancies. It has got a very poor outcome. In our case, patient received 2 cycles of chemotherapy. Later that, she developed pulmonary complications due to pulmonary metastasis, and she passed away after 4 months of diagnosis. Okay, how to differentiate leiomyosarcoma and sarcomatine renal RCC. In leiomyosarcoma, tumor cells resemble the smooth muscle cells, and they are mostly arranged in interlacing fascicles and bundles. Renal cell carcinoma component is not seen. Talking about ISC, in leiomyosarcoma, cytokeratin is negative and it is positive for SMA and desmin, but in some cases, CK or EMA can be positive. In contrary, sarcomatid variant of renal cell carcinoma is composed predominantly of pleomorphic-looking epithelial cells, and they typically lack the alternating fascicles. And renal cell carcinoma component is seen usually within the tumor. Talking about ISC, cytokeratin is positive, SMA and desmin are negative. And some tumor may express SMA, but in this case, desmin can be usually helpful because desmin is usually always negative in sarcomatous RCC. So concluding my presentation, leiomyosarcoma of kidney is a very rare tumor with a very poor prognosis as it behaves in a very aggressive manner. So clinical history, gross examination of the specimen, morphological analysis, interpretation of the ISA markers are necessary for correct diagnosis and management. I don't have any conflict of interest. These are my references. Thank you.
All right, so we have time for questions if anyone wants to ask.
My question. You didn't think of any other sarcoma. You just thought of leiomyosarcoma only.
Yes, sir.
Why?
Because the tumor's cells were more towards smooth muscle cells. It was resembling the smooth muscle cells, and the pattern of the arrangement of the cells, it was more towards the interlacing fascicles and bundles, as we see in the leiomyoma. Because of the morphology, we were thinking of the leiomyosarcoma, and or sometimes sarcomatous variant of RCC can be seen, but due to the epithelial component was not seen, we were focusing more towards the leiomyosarcoma. Thank you.
Okay, thank you. Okay, then we have to call Dr. Anjila Pokhrel-Baral. She's from National Academy of Medical Sciences, and she's going to be doing a topic of squamous cell carcinoma of jejunum case report.
Good afternoon, everyone. I am Dr. Angela Pokhrel from Bir NAMS Hospital, second year PG resident. Today, I will be presenting a rare case report of squamous cell carcinoma of jejunum. This 50 years old gentleman presented to our institute with presenting complaints of intermittent generalized pain abdomen, abdominal distension and constipation for 1 month. He was even treated with anti-tubercular therapy during the course. However, there was no improvement. So again, he presented to our institute with complaint of continuous pain abdomen, vomiting and obstipation for 5 days. There was no relevant past history of any surgery or any other chronic medical illnesses. His baseline investigation showed slight leukocytosis. However, hemoglobin, platelet count, liver function test, and renal function test and other biochemical function tests were within normal limit. His prior upper gastrointestinal endoscopy, post-enteroscopy, and colonoscopy revealed normal study. And CT scan of chest revealed a well-defined heterogeneously enhancing soft tissue lesion in the left lower lobe, indicative of malignant mass. And CT scan of abdomen revealed features suggestive of small bowel obstruction. Then the patient underwent exploratory laparotomy, and we received this specimen labeled as resected part of a small intestine, which was 17 centimeter in length, with thickness varying from 2 centimeter to 4 centimeter. The specimen consisted of a constricted area with grayish-white thickened areas. And microscopically, the tumor cells were seen in the submucosal region with intact overlying epithelium, and it was even infiltrating up to the muscle layer. The tumor cells were arranged in nest, island, and singly infiltrating. Individual tumor cells showed features of squamous differentiation, that is cellular keratinization and intercellular breaches. And frequent mitotic figures were also seen. An immunohistochemical test was performed. We showed strong diffuse nuclear positivity for P40. Unfortunately, patient developed complication and he succumbed to death on 25th post-operative day. Now, introducing the case, malignant tumors of small intestine are very rare, and mostly metastatic cancers are more common than the primary one, and usually they are from the malignant melanoma. However, squamous cell carcinoma from lung is rarer one, and these are the few case reports. This is the report. This is a case series from Virginia, which states that small bowel metastasis from the primary carcinoma of lung comprises only 7.5% of the squamous cell carcinoma. And this is the next study which shows that a metastatic jejunal tumor from squamous cell carcinoma of the lung in 85 years old male from Japan. And next study of a 59 years old female presenting with small bowel obstruction with histopathology reports favoring squamous cell carcinoma in small intestine. However, no sufficient document were available regarding prior hysterectomy status, so the primary was occult. And next study, this states that when there is involvement of invasion of the tumor in the submucosa, muscular layer and serosa, they are usually the secondary squamous cell carcinoma, and also there is no involvement of glandular epithelium. Thus, considering all these features, like atypical squamous cell infiltrating in the submucosa up to the muscle layer with intact overlying epithelium, tumor cells showing diffuse nuclear positivity for P40 marker, and lesion in the lung, radiologically diagnostic of malignant mass, there is a high probability of tumor being metastasized from the lung lesion. So our final diagnosis is squamous cell carcinoma jejunum, probably metastasized from lung. And concluding the case, malignant tumors of the small intestine are very uncommon. They can also be easily misdiagnosed. Thus, correlation between clinical, radiological, histopathological findings are essential to consider the diagnosis of metastatic carcinoma. And early detection and diagnosis are of great significance. Thank you. There are no conflict of interest and no source of funding.
Thank you, Dr. Angela. So do we have any questions?
First of all, I would like to thank you for bringing this rare case in this forum.
Thank you, sir.
See, I am practicing pathology since last 25 years. I have not seen any squamous cell carcinoma in jejunum, but you are lucky enough you have seen in 2 years only.
Yes, sir.
So I suggest you have shown some articles published.
Yeah.
Multiple articles, none of them were from Nepal.
No, sir, no.
You please publish this case. You will be the first author to report squamous cell carcinoma of jejunum in Nepal.
Yeah, okay, thank you, sir.
So I was also thinking of the same thing, that exactly we haven't seen till now squamous cell carcinoma, as Sir had said. So this is quite a rare case. So and it's good to see so many of the papers have been supported by immunohistochemistry. So that's encouraging, and we hope that we can get more advanced technologies in the future. Okay, thank you.
Thank you, sir.
So with that, we're going to conclude this session. So thank you.
Thank you, sir.
Okay.
Thank you, fellow residents. It was wonderful and a nice opportunity listening you all. Now, I'd like to call our respected chairpersons to distribute the certificate of appreciations to the residents. I'll be calling the names, and please receive your certificates accordingly. Dr. Jenny Satkuli, Dr. Elina Basnet, Dr. Madhuri Shah, Dr. Om Jha, Dr. Rituraj Baral, Dr. Sarad Sharma, Dr. Srijana Karki, Dr. Angela Pokharel Baral. Thank you, sir and ma'am. Now I'd like to invite Dr. Pratibha Bista to give the token of love to the chairpersons. Thank you, ma'am. Now, moving ahead, we'll be having a short sponsor session from Maglumi Snaib. Thank you.
Could anyone please?
Good afternoon, respected professors, consultant pathologists, national and international delegates, residents. I'm Anup Samser Burathoki, product manager, SNIBE Nepal. On behalf of SNIBE Nepal, I would like to thank ACPN for providing us this opportunity to join this wonderful scientific and the academic session. So I'll be talking very briefly about our company profile and products. So SNIBE Diagnostic, it's a IVD company, the manufacturer from Shenzhen, China. We are mainly focused in production of immunoassay platform, CLIA, and also we are manufacturing biochemistry and PCR amplification and the extraction. So SNIBE, the abbreviation, the full form is Shenzhen New Industry Biomedical Engineering. As a SNIBer, we also take SNIBE as a start new innovation, be excellent. So our vision is always to be a global IVD pioneer, and we have already proved ourselves as a #1 fastest chemiluminescence manufacturer. So globally, we are we have extended our business in 151 nations, total installation around 25,000. So my content will be briefly on the company profile, product introduction, and global sales and marketing. So talking about the milestone of SNIBE, we have the experience of 28 years. The company was first established in 1995. Our main focus is in immunoassay. We started our production with RIA. Then we moved on to more betterment, ELISA. Now we have focused our manufacturing mainly in CLIA, which is the queen of immunoassay technology. So we are the first manufacturer of automated CLIA, also the semi-automated CLIA from China. And we proudly say that we are the first FDA-approved CLIA manufacturer with analyzer. Also, the major reagents of our are US FDA approved. And in 2018, we have produced one of the benchmark CLIA product with a mega throughput of 600 tests per hour, and which is the fastest CLIA in the world till now. So this is our chairperson, Dr. Rao. He's a doctor of biomedicine, and he has proposed several new theories related to nanoparticles and also the third generation's immunomagnetic microbeads. So we prove our quality with different international certifications as ISO, CE. Okay, we also have patent from different European and American nations in our technology. We assure our quality through the third-party QC. Also, we are tied up with the external quality assessment scheme like EQUAS, REQUAS, CAP proficiency testing. So this is the way we ensure the quality, assure the quality. And as I've already told, we are the first and probably, as far as my information, the only manufacturer from the China who has received the US FDA in one of our analyzers and in most of our routine test parameters. So, addressing the demand of the large sample volume laboratories and the hospitals, we also do the total automated laboratory systems, and our authorized distributors for this is Thermo Scientific. So this is our business segment. We mainly focus on chemiluminescence, and we have wider range of CLIA platform, targeting the smallest end user to the largest one. So the smallest CLIA platform of ours is Maglumi 800, and Maglumi X8 is the analyzer with the highest throughput till now, and which is the fastest CLIA in the world. Also, one of our analyzer is US FDA approved, which is Maglumi 2000. And recently we have launched Maglumi X3 in Nepal, which is more innovative, upgraded system. We also have the biochemistry and the electrolyte system, also integrated system that is called Biolumi CX8. Also we have the nucleic acid extraction system, and we have jumped into the future of diagnosis, that is the molecular diagnosis. We also have the PCR amplification system. So highlighting a little bit about our reagent kits, the specialty we have is we provide the integrated calibrators. Also the QC, internal QC is free, and also to better assure the quality, we are also tied up with the third-party QC. And also our reagent pack size comes in 50 and 100 test unit, so that will be more convenient in case if we have the low test load in special parameters. So one of the peculiar feature what Maglumi has is the broadest test menu till now, okay? So we have the comprehensive test menu starting from the TFT, thyroid also we have the thyroid receptor antibody, T uptake, okay, fertility panels, we have wide range like AMH, 17-OH, progesterone. In tumor markers also, we have HER2, which can be specially used for like screening of breast carcinoma, PIVKA2, pro-GRP, NSC. These are the tumor markers which is exclusively, maybe many tumor markers are exclusively present only in the SNIPE test menu. So the advantage of choosing Maglumi, why Maglumi? So we have the wide variety of analyzers, which is more suitable for the small end users, also the large end users. We have the comprehensive test menu. And also, second additional point is our reagent is compatible for all the analyzers. You are already familiar, you might be familiar with like other commercial analyzers, they restrict certain tests in one model and to other model, but we are compatible. Our reagents are compatible for all models. We guarantee our quality by third-party QC, also by the external quality control scheme. We are non-enzymatic fast chemiluminescence technology, so we ensure stability and sensitivity. We have the intelligent microbead separation technology, which also assures like unwanted, which reduces the unwanted complex formation. And our analyzer is automated and user-friendly. And we have 10-point master curve that ensures accuracy. And we have the advanced component design that creates excel performance. So I would like to talk briefly on our benchmark product, that is Maglumi X8, which has a throughput of 600 tests per hour. We can load 300 samples at a time, 42 reagents at a time, and it is also capable of to link with the laboratory automation system. It is basically targeted to the large lab users. So this is also our next biochemistry product with the mega throughput of 600 tests per hour. At a time, we can load 400 samples, and we have 72 reagent positions. Sorry, we can load 300 sample at a time. So this is integrated system. There are also many integrated systems in Nepal from the other brands, and we also have the integrated system that is Biolumi CX8, which is more suitable for the end users which have the bulk test volume. So we are globally present in all the continents. We have major business in 43% in Asia, accounting 42% combining America and Europe, and 50% business in Africa. So far we have 25,000 units installed, including biochemistry and CLIA. So SNIPE is always looking forward, and it's always we are always enthusiastic to participate, to support this kind of scientific session, not only in the national but also in the international platform like MedLab, AACC, Middle East, Euro MedLab, and IFCC, Medica. So these are our end users, Maglumi X8 end users from different countries. So we also believe in joining the corporate, academics, and the scientifics all together. So we held workshops, teaching, learning activities in local level also in different countries. We have also exhibited in different international platforms, and this is some of the milestones we achieved doing the workshops in different parts of Nepal. We did this in Marriott. We launched Maglumi X8, where distinguished professors of biochemistry from different medical colleges, they were participated. They were the key speakers in the workshop. We also did the workshop in Biratnagar, which was more effective. We got good response and the feedback from those workshops. Also, we did in Chitwan, similarly in Botual, Nepalganj, and recently, the starting of this year, we did the program in Nepalganj, then in Kathmandu, then recently we did the workshop in Dongari. So we also exhibit ourselves. We have the local partners. As a local partners, we have BSR Biotech and Sudeep International, and for biochemistry, we have Imperial Medilink as our local partners. So take-home messages at the end, why choose SNIPE? Because we are morely focused in immunoassay manufacturing for about 28 years of experience. We have been globally trusted by wide end users. We have our wide presence. We also assure our quality by ISO, EQA, FDA certification, and technology-wide, we are more recent, advanced, and as a service point of view, we are the best for providing the service as well. So at the end, the aim of SNIPE is to be the pioneer in the global diagnostic field. With this, I would like to conclude. Thank you.
Thank you, sir. To provide certificate of appreciation, I would like to request Dr. Runa Jha, President, for providing certificate for Mr. Anup Sir Budathoki from SNIPE, Nepal.
Okay, thank you very much. Now we have come towards the end of the day, and there is a lot more waiting for you after this also. So now we'll proceed to the closing ceremony of this. 2 days conference and 1 day pre-conference. And after this closing ceremony, I request the life members of ACPN to gather in Hall 2 for a small general body meeting. And all the residents and the non-members can enjoy the dinner and other activities organized by Serolab. So I request you all to stay back till the dinner and make this day more lively. Thank you very much. Please settle down for the closing ceremony. अरू बाहिर साथीहरू हुनुहुन्छ भने please call them so that we can start soon.
Good afternoon, everyone. We are back again. Now it's time to distribute certificate of appreciation for our sponsors, without whom this program would not have been successful at all. Now I would like to call upon Dr. Runa Jha to distribute certificate of appreciation for our session sponsors. I would also like to call our General Secretary, Nirajan Mainali sir. Please give them a big round of applause. Session sponsor, Techno Biomed Private Limited. Please come on stage. Om Surgical Concern Private Limited. Please can we have Om Surgical Concern Private Limited. Next we would like to have Agape Diagnostics Limited. Please give them big round of applause. Everest Trade Link. Can we have representative from Everest Trade Link? Next we have Lab Line Traders Private Limited. Next, we would like to call upon silver sponsors. ABC Suppliers Private Limited. Can we have ABC Suppliers Private Limited? Please don't hesitate to put your hands together. Next, we have Bosch Global Software Technologies. Bosch Global Software Technologies Private Limited. Next, we would like to call upon the Trading House. Now, we would like to call upon our gold sponsors, Sanjay New Industries Biomedical Engineering Cooperative Limited. Next, we would like to have Access Medibase Private Limited. Now it's a matter of privilege to welcome our title sponsors, Sero Diagnostic, Serolab Nepal Group. We would like to thank Serolab for sponsoring today's dinner. Please put your hands together for Serolab. We can't hear from the back. Now we would like to call upon our poster presenters. Dr. Askuna Roop Shrestha, can we have on stage? Dr. Anamika Priyadarshini. Click it. Dr. Anji Maharjan. Dr. Angela Pokhrel. Clip it. Dr. Anju Maharjan. Dr. Anju Maharjan. Dr. Asa Chapagai. Dr. Baisali Bhattacharya. Poster presenters, please be alert. Dr. Bonita Guru. Dr. Diva Shrestha. Dr. Dheeraj Khetan. Dr. Dilashma Gharti Magar. Dr. Deepti Shrestha. Dr. Isha Gawali. Dr. Isha Shrestha. Dr. Indra Prasad Chapagai. Dr. Tritika Chaudhary. Dr. Karuna Khadka. Dr. Karisma Ghimire. Dr. Karuna Khadka. Dr. Kavita Devi Baral. Dr. Kausal Kishore Prasad. Dr. Krishna Murari Yadav. Dr. Mausami Singh. Dr. Misu Pokhrel. Dr. Mlindu Tiwari. Dr. Nitesh Kumar Yadav. Dr. Nikki Thakur, Dr. Nirazan Karki, Dr. Pradeepta Gautam, Dr. Pragya Adhikari, Dr. Jani Satkuli, Dr. Prasita Bhandari, Dr. Pritha Acharya, Dr. Ratan Saha, Dr. Ramesh Shrestha, Dr. Rohit Khadki, Dr. Rajendra Chaudhary, please give them big round of applause. Dr. Shunisa Vaidya, Dr. Sudeep Regmi, Dr. Subal Amichane, Dr. Cecile Barwal, Dr. Soshan Raz Acharya, Dr. Sankar Vastakoti, Dr. Sandeepa Kuwar, Dr. Sazana Dahal, Dr. Sabita Maharzan, Dr. Sangeeta Dahal, Dr. Susil Adhikari, Dr. Sonia Jha, Dr. Uma Devi, Dr. Uttam Ghimire, Dr. Usha Sharma, Dr. Upashna Lamichane, Dr. Yasmin Shrestha, those who have missed taking the certificate from our lovely ma'am, Dr. Runa Jha, please collect the certificate from the organizing committee. Thank you.
Without any delay, let's dive into the certificate distribution ceremony. I'd like to invite Dr. Runa Jha, President of ACPN, and Dr. Nirajan Mainali, General Secretary, to do the honors of distributing the prizes and tokens of appreciation. Now, I'm sure all of you are very, very eager to know the results of the poster and oral presentation. But before I announce the winners, I'd like to heartily thank and invite Dr. Seema Pradhan and Dr. Karishma, the judges for poster presentation, and Professor Dr. Rajesh Pant and Dr. A.N. Thakur, the judges for oral presentation, to receive a khada as a token of appreciation. I would also like to invite Dr. Rekha Manandar and Dr. Vandana Satyal, judges for the oral presentation, to please receive their khada. Now, without further ado, I will be announcing the winners for the poster presentation. The second runner-up for the poster presentation is Dr. Sushil Adhikari. Dr. Adhikari, please come forward to receive the prize. Dr. Sushil Adhikari. Dr. Sushil Adhikari. Anyone on behalf of Dr. Sushil Adhikari to receive the prize of 6,000 rupees? Congratulations, Dr. Sushil Adhikari. The first runner-up prize for poster presentation goes to Dr. Isha Gewali. Congratulations, Dr. Gewali. She wins a cash prize of 8,000 rupees. Many, many congratulations. Now last but not the least, the winner for the poster presentation and 12,000 rupees that truly impressed everyone present is Dr. Akshunda Roop Shrestha. Congratulations, Dr. Shrestha. Congratulations to all the three winners. Moving on towards the winners for the oral presentation. The second runner-up for oral presentation, winning the 6,000 rupees cash prize is Dr. Pooja Khadka. Congratulations, Dr. Pooja. Can you please come up on stage to receive your prize? Next, the first runner-up for oral presentation and the winner of 8,000 rupees cash prize is Dr. Usha Kiran. Truly an impressive performance, Dr. Usha. Can you please come up and receive your prize? Now finally, the winner for today's oral presentation and the grand prize of 12,000 rupees is Dr. Jadish Chatkuli. Can I ask Dr. Chatkuli to please come up to receive the prize? Many, many congratulations to all the winners today.
Having distributed the prize for poster and oral presentations for the residents, I would also like to remember in this moment Dr. I.L. Shrestha and Dr. Vidurvasti. The prize for the residents were sponsored by Dr. Vidurvasti. He has donated a fixed deposit of rupees 1 lakh to ACPN, the interest of which was utilized for the prize. And for this oral presentations, the prize was contributed to us for this conference by Dr. I.L. Shrestha. Thank you very much to them.
Thank you so much, Dr. I.L. Shrestha and Dr. Vasti. It truly encourages all the future pathologists of Nepal. Now, what an honor to have a truly impressive lineup of speakers, guests, and participants, and generous sponsors and audience. But let me take a moment to appreciate our dear MCs for the entirety of this conference, who have kept us all informed, engaged, and entertained throughout. So now I want to call on stage our MCs to receive a small token of appreciation. Please, as I call your names, I would like to ask you to come on stage. Dr. Nikita Thanet, Dr. Rubina Roy, Dr. Pooja Khadka, Dr. Pritha Acharya, Dr. Rashmita Acharya, Dr. Rojin Thapa,
I would like to call upon Priyanka Vasti, Sadiksha Neupane, Dikshita Bhatrai, Please give them a big round of applause. Dr. Asma Sai.
Now I'd like to call upon the stage Dr. Nirajan Moinali, our General Secretary of ACPN, to please give out a vote of thanks. Dr. Moinali, I would like to welcome you to the stage.
Good evening, all my seniors and my friends. First of all, I would like to thank all of you for participating in this event, despite of your busy schedule, and making it a successful event. It wouldn't have been possible without your guidance from our seniors and enthusiasm from the young pathologist and the resident. I hope next event will be much bigger than this event. ACPN would like to thank Professor Sumit Gujral, Professor Anurag Mehta, Dr. Divya Mida, Dr. Gaurav Chatterjee, and Dr. Sweta Rajpal, and all our national speakers for coming from different parts of Nepal and India in such a short notice. Thank you once again. I hope all of you stay here during this event has been enjoyable. Thank you. This event wouldn't have been possible without extreme cooperation from the Hotel Himalaya, Mr. Sanjay Joshi, manager, Mr. Bhupesh Lekhak. They were extremely cooperative and flexible during this session, and they have a big role to make this event a successful event. Thank you. Also, I'd like to thank our event manager, admission team, Mr. Asin Shrestha, Sirish Marjan, and rest of the admission team for managing this event in a very nice way. Thank you. Planning is one part, and execution is a different thing. We planned as a ACPN executive committee and the organizing committee, we planned this event, but to put every pieces into the perfect place, the role of MC was really vital. Thank you, Dr. Dikshita, Dr. Asma, Dr. Sadiksha, Dr. Priyanka, Dr. Pritha, Dr. Rasmita, Dr. Pooja, Dr. Rosin, Dr. Rubina, and Dr. Nikita for all of their effort. Please, I think they deserve a round of applause. Thank you. And to plan this kind of event, there is always a big financial burden. And this event was no exception. And when we planned this event, we met Mr. Kiran Shrestha from the Sero Diagnostic. He was extremely supportive. He has been always extremely supportive in all the ACPN event, and it was no exception. And thank you, Kiranji and the Sero Diagnostic, for sponsoring a title sponsor in this event. Thank you. I would also like to thank Mr. Krishna Maharjan from SNIPE, who was very positive to sponsor this event from the day one of our talk. And I'd like to thank Ms. Regina Yang from the SNIPE, who helped to coordinate all our meetings with the SNIPE China, and they offer a gold sponsorship for this event. Thank you, SNIPE team. And Axis, Mediviz, and Gopal Gupta, they also contribute in this event as a gold sponsorship. And then their sponsorship helped a lot to make this event a successful event. Thank you, Axis Mediviz team. And I would like to extend my appreciation to Mr. Kenneth Chitrakar from ABC Suppliers, Ms. Ipsita from Bosch, India, Mr. Soiles from the Chamunda Training House for supporting this event as a silver sponsor. Thank you. Mahindra Badwal from Techno Biomed team, Suman Thapa from Agape India, Uddhav Bhandari from the Om Surgical team, Hari Thapa and the Everest Trading team, and BK Shrestha from the Lab Line team. They supported us as a session sponsor, and without all of their sponsorship, this event wouldn't have been possible. Thank you, all of you. Additionally, we contacted International Academy for Pathology to support this event, and the World Health Organization. They also support this event. So thank you, both of them. Lastly, I would like to thank my own 10th ACPN Congress Committee team, led by Dr. Runa Jha, Dr. Sivaraj Kesi, Dr. Richa Pandey, Dr. Grishma Shrestha, Dr. Nisha Sharma, Dr. Manisha Shrestha, Dr. Prakriti Saha, Dr. Shankar Kafle, Dr. Vivek Kesi, and Dr. Jolanta Paudel. They were, I think, having a restless night for 1.5 months at least. Forgive me if I forget some name. A round of applause for everyone in this hall and who are not present in this hall to making this event successful. Thank you. Until we meet again.
Thank you, Dr. Moinali, for your humble remarks. Now, we are at the end of the program, and I would like to extend my thanks to the event organizers and all those involved in making this program a success. Your hard work and dedication has made this event possible, and the smooth running and execution all comes down to you. I would also like to thank our guests and participants for their outstanding contributions. It is an honor to be amidst such geniuses and talents. Lastly, I would like to thank you, the audience, for being generous with your attention and appreciation. As we wrap up, I would like to thank you once again for being with us today, and I look forward to accompanying you similarly in the future. This marks the closing of the 10th Conference of Association of Clinical Pathologists, Nepal. And lastly, in this bittersweet moment, I would like to request all the life members to please proceed towards the Hall 2 for general body meeting and bid the rest of you a pleasant rest of the evening. Thank you.
Thank you very much. Hall B for general body meeting. ACPN life members, please, we'll have a brief meeting there. And this hall is handed over to Sero Diagnostic now. We'll meet for dinner. Thank you very much.
Hello. Good evening, ladies and gentlemen. We are starting with the session in next 5 minutes, so we would request everyone to please settle down.